Good morning, everyone. We'll be starting our conference within 5-10 minutes. Please ask your colleagues to join as early as possible. Thank you. So, hello, good morning, everyone. I'm Dr. Chaitali Bhatt, and it is my honor to be your host for today's conference. I extend my warm welcome to all our distinguished speakers, respected judges, and esteemed medical delegates from different fraternities. It is our great pleasure that I welcome you to the 10th webinar conference on good clinical practice. And this event is organized by Narendra Modi Medical College, LG Hospital, Maninagar, Ahmedabad. This is in collaboration with Association of Physiologists and Pharmacologists of India, Gujarat State Chapter Branch, and Fraternity of National Research and Publication Society of Medical Sciences Forum. To inaugurate our webinar, we will be proceeding with Deep Pragatya ceremony that will be a virtual, and there will be a rendition of a beautiful Saraswati Vandana. I hope we will enjoy all.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा.
So yeah, that was a beautiful Saraswati Vandana. So now we are proceeding further with, on behalf of appreciation to Dr. Dipti Shah, the Honorary Dean of Narendra Modi Medical College, Maninagar, Ahmedabad. Uh, Her unwavering dedication, continuous efforts, and her remarkable support for our online conference and webinars have been an instrumental in shaping our and enriching the future of medical education. Although she's unable to join today because of her prior commitments, she has sent her blessings and greetings, which we deeply appreciate. Before we delve into today's topic that is on good clinical practice, I would like to extend our profound gratitude to our esteemed association partner, APPI Gujarat State Chapter and Forum. Their steadfast support and collaboration have been crucial in making this event a reality and a grand success. I'm pleased to even extend my warm welcome to Dr. Janardhan Bhatt sir, who is an organizing secretary from APPI Gujarat State Branch, and Dr. Saumil Marchant, the organizing chairman of this event, who is currently working as a HOD of Forensic Medicine at Narendra Modi Medical College, Maninagar. Their both dedication to organizing this conference is greatly appreciated. I would like to call Dr. Saumil Marchant sir if he is present.
Chaitali.
Yes, good morning, sir. I welcome you.
Yes, then. Hello.
Sir, I request you to, yeah, you are audible, sir. I
Yeah.
request you to please say some words for us.
Okay. Good morning to all of you, all the delegates and participants, and welcome to our all the esteemed guests for this session. It is a very important session for the good practice. in the clinical as well as the practice. So there are so many esteemed guests. They will deliver his or her lectures in this seminar. So please attend all the lectures, and I will also invite and thank to GMC observer, Dr. Ashish Bhojal. He is an ophthalmologist and he is also joined within half an hour. So welcome to all of our chief esteemed guests as well as the participant and delegates. Thank you.
Thank you so much for your words, sir. I will be calling you for a webinar talk in just few 1 or 1.5 hour. So moving further, I'm also honored to invite our esteemed presence of Dr. Ashish Bhojal. He's today a GMC observer, and he has done his MS in ophthalmology, and his roles as Joint Secretary of the Indian Medical Association Gujarat and Vice President of Ahmedabad Ophthalmologist Society brings valuable insights to our gathering. Thank you so much, sir, for joining today, and I'll be again inviting you as you join. Additionally, I extend a warm welcome to all the medical fraternity delegates who have taken their time from their busy schedule to participate in this webinar. Your engagement reflects your commitment to advancing medical knowledge and improving patient care. So today I'll just brief today's webinar conference. So there will be a morning sessions of speakers. Once it will be end, you will be given instructions. We have divided all the medical fraternities into different branches. So please contact your volunteers after completing this webinar. This attendance is mandatory. After that, in the afternoon session, there will be oral and poster presentation on different Google Meet and WebEx platform. Now, moving ahead with our today's webinar conference, good clinical practice, and we all know that it is an essential international quality standard for conducting, recording, and reporting clinical trials. The GCP is designed to ensure the ethical and scientific quality of clinical research and the safety and well-being of trial participants. In today's webinar, we are going to cover different main key principles of GCP that includes ethical conduct, responsibility of principal investigator, informed consent, trial risk versus benefit, quality assurance, confidentiality, good manufacturing practice, clinical trial data, trial staff, good quality trials, information on medical products. This whole program schedule has already been shared with you all. So now we look forward to exploring this topic in detail, discussing their impact on clinical research. It's my utmost pleasure to welcome Dr. Swapnil Agrawal. So, uh,
Can you hear
hello?
me or not?
Yes, sir, you're audible.
Yeah.
So I welcome you, sir.
Thank you,
Just a
ma'am.
minute. So Dr. Swapnil Agrawal has done his MD and DNB and MNA MS to speak on the crucial topic of ethics. Dr. Agrawal is a professor and HOD of Forensic Medicine and Toxicology at Pramukh Swami Medical College and Shri Krishna Hospital, Bhai Kaka University, Karamsad, Anand. His extensive role include chairperson of the Student Grievance Redressal Cell, member of several committees at Bhavikaka University. He is also an esteemed member of the International Chair in Bioethics and holds certifications in GCP. Dr. Agrawal's expertise and experience will provide valuable insights into the ethical dimensions of clinical practice. Please join me in welcoming Dr. Agrawal. I welcome you, sir.
Thank you, ma'am. Can you please make me the co-host so that I can share the...
Yes, I have made you co-host and I've also made you presenter. So you can now start sharing the screen.
Yeah. Can you see my screen, ma'am?
Yes, sir.
And is the slide also visible?
Not yet. I can see only this Zoom screen.
Another slide? No.
No.
Now can you see the screen?
Yes, now we can see the screen.
And complete screen?
Yes. Can you
And
just change one slide? Yes. Okay. Go for it.
yeah. A very good morning to all the participants. I welcome you all for this 10th webinar. And I'm the one to start the session, and the topic given to me is ethics in research. Now, it's a brief presentation. There are 20 minutes allotted to me, and I will try to complete it within those 20 minutes. Now, ethics is something that everybody talks about nowadays. It's not that it's just nowadays, but it has been talked a lot, but it has gained momentum probably, I believe, in past 5 or 10 years. And when we talk of ethics, what is being taught in the medical curriculum is, or what we generally believe, it's the moral code of conduct that everybody has to follow. Now, the funny part is that while we talk of ethics, if all of us followed that moral code of conduct, there wouldn't have been a need for any laws. So we talk a lot about ethics rather than following them.
Sir, I'm really sorry
Yeah.
to interrupt.
Yeah.
Can you be a little bit louder?
Okay. Just a second, because I'm using a headphone, probably. Is there any change in my
Pardon?
voice? Is there any
Now,
change in my voice?
yeah, now we can see better. Now we can hear better.
Yeah. Okay. So what I believe about ethics is just this simple thing, and this goes as my behavior that I expect from others. So whenever we talk of ethics and we ask somebody to follow ethics, the simplest thing that one should keep in mind is ethics is nothing but my behavior that I expect from others. Now, this whole webinar is about research. So I'll talk only about what is the role of ethics in research. So importantly, there are the last 2 or 3 slides, which would be my take home messages. But to reach to there, let me share you what has happened in past. So when we talk of ethics in research, the literature says that in the first century, there was a physician called Celsus who had justified experiments on condemned criminals in Egypt. Now, his logic was that if somebody has been convicted of a crime, he loses every right, and we are justified to conduct experiments on such persons. Now, this notion won't hold good now. The defense, what I've already told you, is that it's not cruel to inflict on a few criminals some sufferings, because that sufferings may benefit multitudes of innocent people through the centuries. Now, that was the concept earlier, which no longer holds true now. If we talk of some very good experiments done in the past, I believe that some of you might have seen this photograph. I'll share the details about it. It's about the discovery of the vaccine on smallpox by Edward Jenner. So in 1796, okay, when he was testing this vaccine for smallpox, what he did was he inserted pus taken from a person called Sarah Names, and then he put it into a cut made in the arm of a local boy. Now that boy was actually his gardener's son. So in this case, he used his gardener's son to do his experiments. It's no doubt that he discovered this vaccine. But nowadays, if you ask somebody that without telling a person, if you are going to do an experiment on it, it won't be accepted. So things have changed over the years with regards to ethics in research. Now I'll share with you some guidelines that at present we need to follow. This is a comprehensive list, and you would see that just because ethics is important in research, what has evolved over these many years. So if I go through the chronology, we talk of ethics, it's present in the Charak Samhita. Then Hippocratic Oath also talks of ethics. Coming further to the recent centuries, the American Medical Association came out with its Code of Medical Ethics in 1846. So this tells us why ethics is so important. Then most of us, I believe, would be aware of what is called as the Nuremberg Code. So these are the guidelines that came out after the trial on the German doctors for the research that they did on the prisoners during the Second World War. Now it's a code and not a law, so it was free for people to follow, not to follow. Next year, there was a Universal Declaration on Human Rights. Our own Medical Council of India came with a Code of Medical Ethics in 1956. Coming further, in 1960, there came this Helsinki Declaration. I'll end up my presentation with the 37 principles of this Helsinki Declaration. This is a declaration that is still relevant, and every research has to be conducted as what is given in the Helsinki Declaration. Then there was those Tuskegee trials which were investigated, and in 1979 we got the Belmont report. Now it has also got some significance. I'll share it in the last parts of my presentation. Our own ICMR came out with a policy document in 1980. Then WHO COMS came out with guidelines in 82, 91, 93. Nuffield Council in UK came out in 95. The reason for this webinar, that is the ICH GCP, the first GCP guidelines came out in 1996. As we will see during the course of the day, the stakeholders started forming these guidelines in 89 and they completed in 1996 when the first document came out. Our own ICMR improvised its document of 1980 and came out with the revised guidelines as ethical guidelines for biomedical research on human subjects. So by 2000, we were using the word subject. In 2001, we came out with our Indian Good Clinical Practice guidelines. Till now, we are following those Indian Good Clinical Practice guidelines. Recently, a fortnight or a week back, there has been a draft put up about the new Indian GCP guidelines. It's in the public domain for 30 days to invite the comments. So probably in coming few months, we will have our own Indian Good Clinical Practice guidelines. Then COMs revised their guidelines in 2002 and 2016. Coming to the current scenario. As far as research ethics are concerned, the document of 2017 that ICMR came out, the three documents, one is the National Ethical Guidelines for Biomedical and Health Research involving human participants. Now the word subject was changed to participants in 2006 itself. So now we don't say that you use the word subject, it's better that we use the word participants. In the same year, they came out with the National Ethical Guidelines involving children and the National Guidelines for Stem Cell Research. So if we talk of ethics in research, these three are the guidelines that currently we are expected to follow. In 2019, ICMR came out on a policy on research integrity and publication ethics. So now ethics are not there in conducting just the research, but also in how you publish those research. I won't talk of the new drugs and clinical trial rules here, but the law, as per those rules, say that every biomedical and health research has to follow these 2017 guidelines. So indirectly, even though we say that ethical guidelines may not be mandatory, but now with the 2019 new drugs and clinical trial rules, these ethical guidelines are mandatory to be followed. Then there are certain documents that came out in 2023. One is on the ethical conduct of controlled human infection studies in India. Then an ICMR network of institutions, joint ethics review of multi-center research. In the same year, there was another document of ethical requirement for submission of systematic review and meta-analysis proposals. Another one on application of artificial intelligence in biomedical research and healthcare. Now I'll tell you why I'm sharing you with all these guidelines, names of all these guidelines. And in 2024, there is another document by ICMR which talks about ethical requirements for laboratory testing, laboratory validation testing. Now, if you look at all these guidelines, there are umpteen of them, and all are based on ethics, which involves some or the other kind of a research project. So this shows how much important is that one should be ethical in conducting the research, not just conducting, even reporting the research. One document that I have not shared is what is called as good laboratory practices, which are again related to research, and it also talks about how ethically one should maintain the laboratory to have good research results. Now, all of them, जितने भी ये research के documents हैं, they are all based on certain core ethical principles to be followed in research. This is probably my third or fourth last slide for the day. And this is the crux of this session. What are the ethical principles that we expect a participant of a research? Now, here, participant is not the subject. Every person who is involved in the research is considered as a participant of the research. That is what I am talking right now. So there are four ethical principles. Probably most of you would have heard it. It may be a repetition for them. For those who haven't heard it, these are the four basic principles around which any research revolves around. First is beneficence, which says that whenever a research is being undertaken, the benefit should always be more than the risk to the subject or the participant. Now, here I am talking about the person who is on whom the research is being conducted. Purpose is that one should ensure the safety and well-being. Second principle is non-maleficence. There should not be any harm to the participants, no matter what is your research question. Third is autonomy. Any person who is being undertaken in a research, he or she has a right to choose whether or not the person wants to be in the research or not. This translates practically into what we call as consent and privacy. The fourth principle, which is again very important, and if you Google it out, there have been umpteen researches where this has not been followed. That is justice or an equitable selection, or in practical terms, avoiding exploitation of a vulnerable population. Now, just to correlate it, what Jenner did for this smallpox vaccine, he took the son of his gardener, which now we considered as a vulnerable population because he didn't have a free mind to say yes or no to whatever the person was doing, even if he was asked for a consent. So as of now, every guideline is based on these four principles of research, and I have listed down all the guidelines that one can go through to do an ethical conduct of a research as on 2020. Now, before I finish off this presentation, the most important ethical guideline that everybody has to take care even now is what is the Helsinki Declaration. Now, before we move on to Helsinki Declaration, this is a representation of those two persons who came out with these four ethical principles broadly that we follow nowadays. One is James Childress and other one is Thomas Buchan. These two persons were the ones who put out these four principles of ethical research. And one of them was the member of the National Commission, which inquired the Tuskegee syphilis trial and came out with the report that is called as the Belmont. So as on today, these are the four ethical principles on which every research is based. Now, the last thing that everyone has to follow, even though we are in 2024, is what is called as an ethical principles for medical research involving human subjects. Now, somebody would say that we are to follow the good clinical practices. If somebody who has gone through the principles of good clinical practices, the first principle says that every research has to be done as per the Declaration of Helsinki. And this is what is the document of Declaration of Helsinki. The World Medical Association came out with this declaration in 1964 in its 18th General Assembly. Since then, there have been multiple amendments to these ethical principles in research. The last one was in 2013, which has come out with 37 principles. To my knowledge, they are again under revision, and probably this year or by next year, we will have another revision of the Declaration of Helsinki. When it came out in 1964, there were around 14 principles, 5 basics, 2 clinical research, and 7 therapeutic clinical research. These have broadened till date in 2013 to 37 principles. Now, this is a slide that shows all those 37 principles, which have been divided into 12 different groups. Every researcher should go through these 37 principles. It's a small document, around 2 or 3 pages, but it will tell you how a research has to be ethically conducted. Some of you might be aware, nowadays, if you go for a publication, there are journals that ask you to submit a declaration that your research has been done as per the Declaration of Helsinki. So even though we learn about good clinical practices, we can never forget what is there in Declaration of Helsinki. And this is one document that protects the ethical principles in doing a research, whether it's a clinical trial or whether it's a biomedical or health research. So this was all in short what I wish to share with you regarding ethics in conducting a research. I have shared the PPT with the organizers, and they will share you the PDF so that at least you can get the list of all the ethical guidelines that are present currently for any ethical conduct of research. Thank you. Dr. Chaitali?
Yeah, sir, kindly stop sharing the screen.
Just a second. Yeah. Has it stopped?
Okay, now it's stopped. So thank you so much, sir, for giving us and enlightening us on ethical principles so briefly and focusing on all the important ethical codes which has been given by different names, the organizations and different names, and how the recent updates about the ethics in different groups of research and clinical practice. That is a very brief and summarized part where we all got to know that where to see, how to see, which points to be considered for practice, clinical practice as well as in research. Thank you so much. And thank you so much, sir, for sharing the PowerPoint or PDF of this slides. We will be sharing with our participants. That will be of help to them.
Yeah, thank you.
Thank you so much, sir.
I've already joined.
Yes, ma'am. Good morning, ma'am.
Good
Yes.
morning.
So now, as we are moving forward with our next speaker, Dr. Gurusharan Dumra, who is going to speak on responsibility of principal investigator and its importance in clinical trials. She has done her MPS and MD in pharmacology and fellowship in medical education from ACME in 2017. She is currently serving as professor and head of the Department of Pharmacology at Narendra Modi Medical College since 2019. She has 24 years of extensive teaching experience and has significantly contributed to the education of undergraduates, MBBS, and postgraduates pharmacology students. Her extensive administrative roles include being a faculty member of Medical Education Unit at Narendra Modi Medical College since 2010. And she has been involved with several important committees such as AMC Met Ethics Committee, Institutional Scientific Review Board, and the Institutional pharmacovigilance cell. Also, she has been a chair several institutional ethics committee at Shelby Hospital, Evron Multi-Speciality Hospital, and Advanced Hospital in Ahmedabad. Her professional affiliations include serving as an executive committee member of SAC ACCP since 2023 to 25, and as the past president of the Indian Pharmacological Society Ahmedabad chapter. Her extensive experience and expertise make her exceptionally qualified to address the responsibilities of the principal investigator and other essential components of clinical trials. I welcome you on virtual dais, ma'am.
Thank you so much, Chetali, for all your kind words. I would
Ma'am,
start sharing my slides.
yes, ma'am.
Okay, so Dr. Swapnil has already talked about ethics and what is a clinical trial basically. So when we talk about a clinical trial, we need to know what are the responsibilities of an investigator. Now, whom do you call an investigator? An investigator is the person or the doctor or maybe a dentist who is undertaking a trial on the human subjects, participants, and is responsible for making all the major medical decisions. So there can be a team of an investigator, and there can also be a team. It can also be a team in the sense there can be a primary investigator, there can be a sub-investigator or a co-investigator. So as you already know, why we do clinical trials. So basically clinical trials we do to increase the knowledge regarding a new drug, a new management, a new modality of treatment that would improve the quality of care for the patient, and also to provide evidence-based patient care or prevention of disease. So basically, we are trying to generate some evidence as to why we want to use this drug or a new investigational product if we are planning to do a new clinical trial. Now, who are the stakeholders in a clinical trial? So basically, starting with regulatory authority, regulatory authority like DCGI and CDSCO are responsible, to whom we are responsible, or the sponsor or the investigator is responsible or answerable to. Then there is a sponsor who is sponsoring the trial, who is also giving the drug per se, who might be the inventor of the drug also, investigator who is doing the trial, or the medical person. Then there can be some helpers to the investigators, like clinical research coordinators can be there. Then there is a ethics committee board or a review board. And most important, the patient or the subject or the study participants. So what are the primary responsibilities and role of an investigator in a clinical trial? So first and foremost, the investigator has to be qualified by education and by training. When I say education, he should be having the proper qualification. You cannot expect a general physician who is an MD medicine to do trials of oncology. You need a special oncologist for it. Training, if the doctor is trained to do trials, initially done trials before this, yes, he becomes a better person to do it. But if not, then he should be trained in GCP and should know how to do a trial. If experienced person is there, investigator, nothing like it. Investigator should be familiar with the safety, efficacy, and appropriate use of the investigational product. So investigational product is the one where we are trying to find, it might be a totally new product whom we are not very much aware what would be the effect of that drug when given for the first time to the patient, or maybe in the phase 2 trial also. So, we are still investigating the product. So if that investigational product is to be given, the investigator has to be aware about the basic safety and efficacy, or you can say the scientific rationality of use of that investigational product. He or she should be aware of the protocol of the trial, should comply with the protocol of the trial, should be aware of the GCP, ICA GCP, Indian GCP, and all the local regulatory requirements which are applicable for conducting a trial, and the relevant SOPs. So it can be the different standard operating procedures which are to be followed for maybe by the ethics committee, maybe by the IRB, maybe for conducting any kind of any trial in that particular institute where the investigator is working. So he should be of or any kind of laboratory investigations have to be done, and there has to be a SOP following that. For that, everything he should be aware of. Now, the person whom you are giving, the investigator who is to be given the responsibility of conducting a trial, should have adequate resources for that trial. For example, he or she should be able to recruit the patients. So sufficient number or adequate number of patients he should be able to recruit. If he in his OPD does not have patients related to his trial, he may take help of his the doctors whom he knows, the other investigators he knows, or some institute, but he should be able to recruit. If he is not able to recruit the adequate number of patients, he should not take the trial. Secondly, he should have sufficient time to give to the patient and to the trial, so that he can comply with all the SOPs and the protocol properly. He should have adequate number of staff. He should have adequate number of staff who is qualified to help him with the trial. He should have adequate facilities. So if the institute should have adequate facilities where the trial has to be started or has to start. Supervision of he is supposed to do the supervision of the support staff. So if there is CRC which is involved, if there are sub-investigator or co-investigator who is involved, so any staff who is taking any activities which are related to the patient who is recruited in the trial, he should have enough time and resources to supervise that staff. Now, when we talk about the medical care, because it is the doctor has to be responsible for the medical care of the study participants. So he has to ensure the rights, safety, and well-being of the study participant, research participant, as well as of the data which is being retrieved or which is being collected from the study, has to be very relevant and it has to be reliable. He is responsible, the investigator is for making all the study related medical decisions. So all the medical decisions have to be taken up by the investigator or himself. The person has to ensure that the medical care is provided to all the study participants or subjects if any adverse drug reaction happens. So if any kind of adverse drug reaction is happening and the patient has to come in contact, the patient is supposed to inform the investigator, and investigator should take proper care, medical care, if required, to admit the patient, if whatever is required, whatever medical care is required by the patient, the investigator should be able to provide that. Apart from that, any adverse event which is happening, even if there is lab abnormalities which are required for safety evaluation, whatever is outlined in the protocol, the investigator has to report it to the sponsor also. Now coming to the other responsibility, other is that the patient, because there is going to be a trial, there is going to be monitoring and auditing of all the medical records of all the data, all the data which has been collected. All those records would be monitored and audited. So the auditing would be done by the sponsor, by the ethics committee, by the CRO, or any authorized representative by the regulatory authority. So there can be DCGI inspection. So the investigator has to provide or give permission for monitoring and auditing of all the records. It is also required that the investigator maintain a log of the study related with duties. So if he has delegated the duties to the sub-I or the co-I or to the clinical research coordinators, but the staff has to be qualified if it is sister. So whatever is being recorded, a log of the study related duties which have been delegated to every staff has to be maintained so that it can be shown during monitoring and auditing visits. It is the responsibility of the investigator to make sure that all the people who are involved in the study, whether it is the staff or the co-I, they are adequately informed about the protocol. So they should know exactly the protocol, the SOPs. They should know everything about the investigational product, how to store it, how to use it, where to log it, whatever. So all the study related duties and functions should be adequately known to the staff, and that is the responsibility of the investigator to make sure that the staff is fully aware of everything. Apart from that, there are before you start a trial, the trial has to be approved from the ethics committee. So if the investigator has to obtain a written approval by the ethics committee, so the investigator has to submit the documents to the ethics committee, who is going to deliberate on it, may ask questions related to it, may ask for more clarification from the sponsor, may ask for certain changes if they are not happy with the way it has been written, especially the informed consent, if they are not, if it is not ethically correct, if there is something is missing. So all those changes need to be made once the ethics committee asks to make those changes in the protocol. And after the ethics committee approves of the protocol, of the written informed consent form, which is to be given to the study participant, the recruitment procedures which are to be followed by the investigator. Suppose the investigator has to put up an advertisement for recruitment of subjects in a particular trial. Suppose if the disease is a rare disease, or if the patients are not commonly seen in the institute where the investigator is doing the trial, and they want to put out an advertisement. In that case, the advertisement also needs to be approved by the ethics committee. So all these things need to be approved by the on all other documents, whether there is a translation certificate, and all the relevant documents have to be approved by the ethics committee, and this approval has to be uh, in a written approval by the ethics committee, which has to be obtained before starting the trial. Now, the investigator has to provide the ethics committee with a current copy of the investigator's brochure. So the investigator's brochure might change during the course of the trial. So if then there is any change in the investigator's brochure, that has to be notified to the ethics committee for its review. And if there is a major change, then the ethics committee, the amendment has to be again reviewed by a full committee meeting, and then it has to be approved. And then again, that has, before further application of that protocol, it has to be approved. During the study and the research, the investigator should provide all the documents to the EC which are related to the subject and participant for review. So if there is any change, if there is any deviation, if there is any study related document which has to be approved by the EC, it is the primary responsibility of the investigator to provide all those documents to the EC for review. Apart from this, the investigator should report to the ethics committee as well as to the monitor and the sponsor if there are any deviations from or changes of the protocol. Unless if there are these deviations or changes were done to eliminate immediate hazards to the participant, in that case, he does not need to take prior permission from the ethics committee for any deviation. Apart from that, if there are any deviations, the investigator is supposed to take permission beforehand from the sponsor or the monitor or the ethics committee. So if during a trial the investigator feels that certain changes need to be made or certain deviations from the already existing protocol needs to be done, then it has to be via the approval of the ethics committee as well as from the sponsor. But if there are any immediate hazard to the participant, then that deviation will not require prior permission. In that case, the reason for the deviation can be reported later on. So if there are changes, if they that increase the risk to the participant, or if they are affecting the conduct of the study significantly, then the investigator has to report it to the ethics committee and the sponsor. All serious adverse drug reactions have to be reported to the ethics committee, to the sponsor, to the regulatory body. The timeline has been specified very clearly in the NDCT rules, and the investigator has to follow those rules. As I said, he should be aware of all the regulatory applications which are there of the local regulatory bodies. So NDCT rules are 19 are applied in our Indian context. So the patient, according to that, all the serious adverse events have to be reported to the EC as well as to the regulatory authority within 24 hours, to the sponsor also. And there has to be follow-up on the time limit which has been provided by the regulatory body. So he has to make sure that all the serious adverse events are reported in a timely fashion. If is there any new information that may adversely affect the safety of the participant, then again it has to be reported to the ethics committee and the sponsor and the regulatory body if required. If there has been a SAE that which is a death. In that case, the investigators should supply any additional information which is required. That is, it might be an autopsy report or the terminal medical reports to the investigator, to the sponsor, and to the ethics committee. So if the protocol is there, a clinical study protocol has been provided to the investigator. Now, before the starting of the trial, the legal document, you can say, is signed between the investigator, the sponsor, or the site, you can say, to apply. That is a legal document to comply to the protocol, to not deviate from the protocol. So it is the duty of the investigator to maintain compliance with the protocol. He is legally bound to comply with the protocol. Should deviate, as I said earlier, also only with agreement from the sponsor and prior approval from the EC. Except, as I said earlier also, only if it is going to cause much immediate hazard to the study research participant, or in case if there are certain small changes which do not actually affect the safety and well-being of the study participant. For example, if there are any logistical or administrative aspect of the study research, for example, if there are changes in the name of the monitor, if there are changes in the telephone numbers, so any such small administrative aspect of the study research is being changed, in that case, we do not count it as a deviation per se. So that does not need to be taken a prior approval. But yes, it has to be informed to the site, the EC, as well as to the sponsor. So he should submit the implemented deviation if he has deviated from the study protocol, the reason for it, and if he thought that deviating from the protocol was required because of certain risks which was involving the study participant, and he wants to propose a protocol amendment to make sure that the safety of the study participant is maintained. So that can also be proposed by the investigator. He should propose that kind of amendment to the ethics committee, to the sponsor, and if required, to the regulatory authority. So all the deviation from the protocol needs to be given. He has to document all those protocols and explain why the deviation was from the study protocol. So certain deviations are explainable. Certain deviations, if they are not properly explained, in that case, a query can be generated by the sponsor or by the monitor on the behavior of the investigator. Now, when you are doing a new clinical trial, the sponsor is going to provide the investigator with the investigational product. It is the responsibility of the investigator to make sure that the management of the investigational product is done in a proper way. So it is he is responsible for accountability of the investigational product at the study site. So he is supposed to maintain the records of the product's delivery to the study site, the inventory at the site, the use by each participant, the return to the sponsor, or if there is something which is remaining, and if there are ways already agreed, there is an SOP of disposal of the unused products, he has to maintain the record as well as to comply to those SOPs. I will not go into much detail of the investigational product management because that is a separate topic which would be dealt by Dr. Anuradha Gandhi. So I'll just go what is in brief, what would be the responsibility of an investigator for the investigational product. So there has to be record maintenance, which would include the dates on which the drug, the product was used, the quantities which were used, the batch and the serial number, the expiry dates if applicable, unique code which are assigned to the investigational product packs and to the study participant. That means if the blinding has been done, that also needs to be maintained. So all these data and the logs and the accountability has to be there for the investigational product by the investigator. Apart from that, the major responsibility of the investigator is also the selection and recruitment of the study participant. So in case of selection and recruitment of the study participant, the investigator has to make sure that there is no bias from his side while recruiting the study participants. There has to be justice in the sense that all, as the one of the pillars of GCP is, you can say there should be no harm, there should be benefit, and there should be justice. So there should be no harm. So make sure that the study participants which you are recruiting are the participants which actually need uh, that drug, which are, so you comply with the exclusion and inclusion criteria which have been set up in the protocol in a stringent way, so that you are not causing any harm to the patient and you are causing benefit to the patient who requires it. Apart from that, the study participants should be selected without any bias, a subjective bias, because if the investigator feels he is a appropriate participant to give in this trial because he is expecting a positive result would be brought about by giving this product in this disease, that is a subjective bias which should not be there while selecting a patient. Secondly, the patient has to be selected without any bias of the caste, creed, and religion. So there should be justice. Every patient is who is requiring the drug should be included in the study. So the selection and recruitment of the study participant should be according to the GCP guidelines. Apart from that, according to the protocol which has been there, adhering to the exclusion and inclusion criteria, uh, making sure that the patient has, if there is a vulnerable population which is there, adequate measures are taken to take care of the vulnerable population. Now, there would be, if there is a randomized clinical trial, the investigator is responsible for randomizing the study participant. The randomization process might be decided by the sponsor, and he has to comply to that randomization process and make sure that the bias from the study is completely removed. Apart from that, the most important part is maintaining the patient's confidentiality, maintaining the confidentiality of the records of the patient, study participants. The confidentiality would be dealt again in a separate lecture, so I won't be going into the detail of it. But yes, as I said earlier, the confidentiality of the patient, of the study participant is of utmost importance. The investigator has to make sure that he is able to explain the concept of confidentiality to the patient and also maintain the confidentiality of the patient, participant who he has recruited in the study. Coming to informed consent, Dr. Somil Merchant would be taking informed consent in detail right now. But again, just highlighting a few points, it is the investigator's responsibility to explain the entire study process, the risk and benefit involved in getting enrolled in the study, the fact that the patient can withdraw from the study and there would be no repercussions whatsoever for that. So it is at his free will that the patient can withdraw from the study. All these needs to be explained to the patient by the investigator in a very simple, non technical, non medical language, and in a vernacular language which is understood by the patient or the study participant. Moreover, if it is a vulnerable population, it is pregnant patient, it is pediatric patient, it is students who are vulnerable if the investigator is their examiner, if there are patients who are not who cannot make a decision for themselves. In that case, a legally accepted volunteer has to, guardian has to be there, representative has to be there. In case of a pediatric patient, or you can say adolescent patient, assent can also be taken. So all that has to be, if required, a video, a virtual, if a video has to be taken, so video recording of the informed consent can also be done. It is a legal document and it is the responsibility of the investigator to make sure that the informed consent process is done in a proper manner. Then coming to records and reports, as I said, all the documents need to be recorded, all the data has to be recorded. So all the data needs to be recorded. The investigator has to be maintain that there is accuracy of the data which is being recorded. So if he has delegated the duty to someone else, he has to oversee that the recording of any data which is there, which can be a very simple as measuring of the man blood pressure or any other marker, anything which is to be done related to the patient. Either there is accuracy of the data which is being recorded, there is completeness in the data. So it should not be an incomplete data. The CRF has to be completely filled up. It has to be done in a legible writing. If it is to be filled by hand, many a times nowadays we have ECRF where it has to be typed, so that legibility is not a problem. But still, if it is to be done by, if it has to be done handwritten, the source document, if it is a handwritten document, then it has to be in a legible way. There should be no overwriting. There should be no it should not be done in a way that it cannot be read by a monitor or an auditor when they come for audit or monitoring. Timelines of the data needs to be maintained. If there is a certain test which has to be done in the morning, suppose a patient has to undergo PFT, then it has to be done at that time and the data has to be reported immediately to the sponsor. And so all this timelines, all the legibility, accuracy, completeness of the data has to be maintained, and that is the responsibility of the investigator. As I said, the source document from where you are filling up the ECRF or CRF, it has to have very legible handwriting. It should not be it should be done at the same time where it should not be left to do later on, where there is a chance that some data might be missed out and there might be incompleteness of the data. And the CRF, which is reported and given to the sponsor, and they should not have any discrepancy if the monitoring visit happen or the auditing is happening. There should not be any discrepancy between what is written on the source document and what is reported in the CRF. Whatever is documented has to be reported in the CRF. There should not be omission of any data. There should not be addition of any data, because you feel that this might be required for the trial. So that discrepancy should not be there. And if there are any discrepancies, the investigator should be able to give a logical explanation for that. Apart from that, according to the protocol SOP and according to the SOP of the ethics committee, the local ethics committee, the progress reports needs to be given to the progress reports needs to be given by the investigator to the ethics committee periodically. So those progress reports needs to be given when they would contain the total number of patients who have been recruited, the total number of patients who were, how the randomization process was done, which patients have undergone how many visits, if it is required, if there is any deviation, if the patient dropout is there. Again, all that needs, if there's a patient withdrawal is there, everything should be there in the progress reports, which is being periodically submitted to the ethics committee or to the sponsor. Then at the end of the study, the investigator needs to give an entire report, the final report and the termination report to the ethics committee as well as to the sponsor. The investigator needs to the trial site, needs to the archive according to the SOP of the whatever is the SOP or whatever is the requirement for the protocol. The archival of the document has to be done for that number of years. It can be 5 years, it can be 10 years. In some cases, it can be as long as 25 years. So according to the requirement of the sponsor requirement, the regulatory requirement, and the trial site requirement, the archival of the documents needs to be done. So this is just an overview of whatever is the responsibility of the investigator. So thank you for your patient hearing.
Thank you so much, ma'am, for giving us an overview on the responsibilities of the primary investigator for participants' safety, ethical compliance, accurate recording of the data collection, and how we can take the regulatory approvals from the ethical committees, how we can plan the study design, and how we should report to the committee what sort of problems has been created or had happened during the trials. And also we have to monitor the safety and efficacy of for the patients, participants. So thank you so much, ma'am, for your valuable time. Ma'am, can you just stop sharing the screen? Yes. Okay, ma'am. Thank you so much, and we are very fortunate to have you.
Thank you, Chaitanya.
Now we are moving forward with our next speaker, Dr. Somil Marchant. I have made good morning, sir, once again.
Good morning, Chetaji.
Just a minute. So here I welcome. Yes, sir, you're audible.
Okay.
So here I welcome Dr. Somil Marchant, sir, on virtual stage. He's a distinguished expert in his field, serving as a professor and department of head of the forensic medicine and toxicology at Narendra Modi Medical College, LG Hospital, Maninagar, Ahmedabad. He has in his academic and professional roles, he has held notable positions such as Vice President of Ahmedabad Medical Association during 2015 and 16. He will be addressing the crucial topic of informed consent, fundamental aspects of ethical practice. So we are very honored to have him on for sharing his insights and knowledge. Am I audible to you, sir?
Yes,
Okay,
Chetaji.
I'm sharing your PPT.
Okay.
Can you see, sir?
Yes. Thank you very much for giving me this.
Sorry to disturb you, sir. Your voice is not coming. You're not heard.
We have APPI and Narendra Modi Medical
Hello, Dr. Somil, sir. Hello, Dr. Somil, sir. Hello.
Yes, may I audible?
Yes, yes, sir. Now you're audible.
Okay. Thank you very much, Sitaji, for inviting me as a guest lecturer in topic of consent. Now, what is consent? Consent means it's a voluntary agreement, compliance, or a permissions between two persons. So it is called as consent. It is a simple definitions of this consent. It is to be legally valid when it must be given after understanding for what act it is given and risks involved. It is a doctors. Now, there are two types of the consent. Commonly, implied consent as well as express consent. Now, in implied consent, consent which is not given, that is, its existing is not expressly asserted, but at least it is legally effective. It is provided by the patient and is the most common variety of the consent in both general as well as hospital practice. Implied consent to a medical examinations in general sense, but not to the procedure for more complex than inspection. Start and expression language, and whatever the language is understand to the patient in a vernacular language, you have to express all the pros and cons of treatment, diagnosis, and investigations. It may be oral as well as the written consent. For major would be relative, minor examinations, or therapeutic procedure, oral consent is employed. Should be preferably to obtain in the presence of disinterested party, just like nurse, ward boy, and his or her relatives, near dear relatives, and not a person closely associated with the patient whose later testimony may be biased. So it is very clear you have to give consent with a disinterested party. Next. Now oral consent, where witness said is as valid as written consent, but later has advantage to easy proof and permanent form. So it is more important. Next. Now, informed consent. Apply to the understanding of the patient, the nature of the condition, nature of the proposed treatment, procedure, and how to diagnosis. The alternate procedure, alternate treatment, risks and benefits involved in both the proposed and alternative procedure. You should inform, you should express to the patient the potential risk not receiving the treatment, the relative chance of success or failure, both procedure, so that they may be accepted or rejected the procedure. It is up to the patient. Next. All disclosures must be in a language or a vernacular language the patient can understand. He may be Gujarati, he may be Hindi, he may be English, he may be Marathi. Whatever vernacular language he or she can understand. All the disclosures of the benefits of the treatment. This disclosure will very much reduce litigations when the results are unsatisfactory or unexpected. The patient must show that the doctor did not adhere to accept the medical standard to prove liability for the sake of informed consent. Next. Now, what is full disclosure? How much took disclosure? What is the normal practice? Physician choice to disclose depend upon various factors, just like therapeutic privileges. This is acceptance to rule of full disclosure. Full disclosure could result frightening of the patient who is already fearful or who is emotionally disturbed, involved, and who may refuse the treatment. When there is really little risk, the presence of the malignancy, unavoidable fatal reasons may not be disclosed. If the doctor feels that patient is not able to tolerate the knowledge, if possible, the next to kin. Next. Now, what is paternalisms? Paternalism is the abuse of medical knowledge so as to distort the doctor and patient relationship in such a way that the patient is disproved of his autonomous or his ability to make the rational choice as to not disclosing the nature of the illness and what is to be done. Next. Why we should obtain consent? To examine, treat, operate upon the patient without the consent is assault. That is the main things in the term of law. Even if it is a benefit or done in a good faith, the patient may recover the damage if you are not taking any consent. It is a assault as a legal point of view. A doctor failed to give a required information to the patient before asking for his consent to a particular operation or treatment. He may be charged for negligence. He may be charged for the negligence. Now, rule for consent on clinical examination. Consent is necessary for every medical examinations. That is the mandatory. Ordinary formal consent to the medical exam is not required in a manner which implied consent is already applied. Oral consent should be obtained in the presence of disinterested third party, just like nurse and ward boy. When the written consent should differ in a one specific procedure and not blank permissions on admission to hospital. Written consent should be in a proper form and suitable draft for the circumstances. You have to take separate consent for the procedure, for the investigations, for the pre-operative anesthetics and operative. And administration to the anesthesia also. The wording should be included in the frame of the confirm that patient has informed to the nature of the procedure before sign taken place or before start the any procedure. The written consent should be witnessed by another person's present and the sign to the prevent any allegation that the consent was for fact or obtained under the pressures. Next. Any procedure beyond routine physical examinations such as operations, blood transfusions require express consent. It must be taken before the act, before the procedure, but not at the time of admission into the hospital. Next. The doctor should explain the objects of the examination to the patient, and the patient should be informed that finding will be included in the medical report. The doctor should inform the patient that he has right to refuse to submit to examinations as well as treatment and investigations, and that the result may go against him. If the patient refuses, he cannot be exempt. So, consent should be free, voluntary, clear, direct, and personal. There should no undue influence, fraud, fact, misrepresentations of the fact, compulsions, threat of the injury, death, or other consequences. Next. In a criminal case,
Hello? 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 Am I audible, Dr. Somil, sir? Sir has some problem with internet connection, so he'll be joining again. Just bear with us for a few minutes.
Hello.
Hello?
May I audible?
Yes, sir, you're audible.
Okay. In a criminal cases, may I audible?
Yes, sir, yes, sir.
In a criminal case, the victim cannot be examined without in or her consent. The court also cannot force the person to get a medical examination against his will. In a case of the rape, the victim should not be examined without her consent. Hello, am I audible? Hello.
Yes, sir. Yes, sir, you're audible.
In a medical cases of a pregnancy, delivery, and abortion, the woman should not be examined without her consent. Next. A person is arrested to charge of the committing the offense. There may be reason for the believing that the examination of this person will provide the evidence as to be a commission of the offense. A registered medical practitioner can examine that person even by using the reasonable force if the examination is required by the police officer not beyond the range of the sub-inspector. If the accused refuse to examinations, this may go against him in a criminal procedure. In the case of the female, the examination should be made only for under the supervision of the children registered medical practitioner as per sections 53 CRBC. Next. In case of drunkenness, a person should not be examined and blood, urine, or breath should not be collected without the written consent. But if the persons become unconscious or incapable of giving consent, examinations treatment can be carried out the consent of the guardian or the relatives if the available should be examined. However, in case of the state like Gujarat, where the prohibition law exists for the consumption of alcohol, the provisions clause has to be considered as a section 53 CRS. Prisoner can be treated forcibly without the consent in the interest of the society. Next. The consent given for committing a crime or a illegally accused act so that the criminal abortion is invalid. Specifically in a abortion cases. A person above 18 years of age can give valid consent to suffer any harm which may result from act not intended or not known to the cause of the death or the grievous hurt as per section 87 IPC. A person can give valid consent to suffer any harm which may result from the act not intended or not known to cause death done in a good faith and for its benefit as per section 88 IPC. Next. A child under 12 years of the age, innocent persons cannot give valid consent to suffer any harm which may result from the act done in a good faith for it benefits. The consent of the patient or a guardian should be taken as per section 89 IPC. Now what is loco parenthesis? In a loco parenthesis, In emergency cases, emergency involves the children when their parent or guardians are not available. Consent is taken from the person in charge of the child. It may be a school teacher, can give a consent for the treating a child who becomes sick during the picnic away from his or her hometown, or the consent of the headmaster of the residual school. It is called as loco parentis. Next, a consent given by the person under the fear of the injury or due to misunderstanding of the fact is not valid consent. The consent given by the insane or unsomnolent persons or intoxicated persons who is unable to understand the nature as well as the consequence of that to which he gives his consent is invalid as per section 9 IPC. Any harm caused to a person in good faith, even without that the person's consent is not an offense, if the circumstance such as that it is impossible for the person to cite to signify consent and has no guardian to other person in a awful charge of him from whom is possible to obtain the consent in a time for the thing to done in a benefits as per section 92 IPC. Next. Consent of the inmate of the hostels is necessary if they are above 12 years. Within the 12 years, the principal or wardens or a rector can give a consent if inmate above 12 years refuse the treatment, and he is likely to spread the disease, he can be asked to leave this hostel. However, if he stay in a hostel, he can be treated without his consent. The nature of illness of the patient should not be disclosed to any third party without the consent of the patient. That is mandatory. When the operation is made compulsory by the law, just like a vaccination, law provided the consent. The consent is not the defense in a case of professional negligence. Next. Any communications made in a good faith for the benefit of the person is not an offense if it is cause harm to the persons to whom it is made, as per section 93 IPC. The doctor should inform reasonably to the patient about the nature, consequence, and the risks of the treatment and examination and operations before taking the consent. Next. For the contraceptive study license, consent of the both husband as well as the wife should be obtained. It is unlawful to detain the adult patient in a hospital against will. If the patient demand a discharge against the medical advice, it is called as DAMA. This should be recorded and a signature should be obtained. Next. Now, consent for the tissue donations. A living adult person can give a consent for donating one of his kidney. The donor must be informed of the procedure involved and possible risks. The donation should not be accepted if there is any risk of the death of the donor. If any person has donated his eye to be used for the therapeutic purpose after his death, the eye can be removed only with the consent of the guardian or legal heirs. If the person has donated his body to use for therapeutics or research purposes after his death, it is not binding for his spouse or next of kin. For organ transplantations, the organ of the donor person should not be removed without the consent of the guardian or legal heirs. Next. Now, consent for autopsy. In a pathological autopsy, there are two types of the autopsy: medical legal autopsy as well as pathological autopsy. In a pathological autopsy, consent is must. The requirement of consent of the guardian and legal heirs of the disease for retention of the organ and part of the body. That is the mandatory. In medical legal cases, autopsy or statutory autopsy, consent is not required because the body is under the police custody. The doctor can remove from the cadaveric anything that is essential for the purpose of examination in a chemical examination for the further investigation in the cause for the purpose of the cause of the death. So these are the basic consent for the autopsy. Next. So this is our not only informed consent, all over the consent regarding the medical legal or medical practice. Thank you very much to all of you to attend my lecture. Wish you a safe and prosperous practice. Thank you very much.
Thank you so much, sir, for enlightening us on all the aspects, legal aspects for taking an informed consent in different scenarios, in case of children, in case of different situations like pregnancy, and all the other regarding aspects which we need to taken into considerations. And you being having a degree of LLB, LLM is the right person to be designated for this legal aspect of the informed consent as well. So thank you so much, sir, for your uh, time and your valuable knowledge to share with us.
Thank you. Thank you very much, Chetali.
Okay. Okay, so now moving forward with our next speaker, I would like to call on the virtual dais Dr. Dimple Mehta. I'm making you a co-host. Hello, ma'am. Am I audible? Hello. Am I audible, ma'am?
Am I audible?
Yes, ma'am. Now you're audible.
Okay.
Okay.
I unplugged my earphone.
Okay. So I would be delighted to introduce Dr. Dimple Mehta, who will be discussing our critical topic today on child risk versus child benefit. And she's the additional dean and professor at the head of Department of Pharmacology at Swaminarayan Medical College, Kalol. She's holding this position since August 2023. With over 25 years of academic teaching experience, she has been a guiding force for postgraduate students since 2006, and her expertise is well recognized through her extensive publication record of over 40 articles. Her insights into balancing child risk with potential benefits are crucial for ensuring the ethical and scientific integrity of clinical research. We are honored to have you, ma'am.
Thank you.
You can, ma'am, start sharing the presentation.
Okay. First of all, before sharing my presentation, good morning, everyone. First of all, I would like to congratulate APPI for organizing such an important event of good clinical practice webinar cum conference. I am very thankful. I would like to have my deepest sense of gratitude towards APPI for giving me this platform and inviting me as a speaker. I would also congratulate the team, Narendra Modi Medical College, for organizing such a wonderful event. I'm also thankful to Dr. Chaitali for being a superb, you can say, a coordinator between the presentation and presentations. And last but not the least, I am thankful to all the members present over here in this platform. Without you, this event would not have been possible. So thank you. Let's go with my presentation.
Sure, ma'am. Thank you. Okay, ma'am. We can see your screen.
Okay. Where is that optimization? But
It was there before you share the screen. It was on the. Okay, fine. If you have not done that optimization, that's fine.
okay, okay. Let's go forward. So my topic is clinical trials, risk and benefits. The overview of my presentation will be introduction, risk and benefits, highlights of measure to overcome the risk. These are the, this will be my short presentation. First of all, as an introduction, we all know that clinical trials, also known as clinical studies, they are the research studies that evaluate the effects of medical, surgical, or behavioral intervention on people's health. They are the primary way researchers determine if new treatments or new prevention methods, such as drugs or diets or medical devices such as pacemaker or any clinical procedure, new clinical, innovative clinical procedures, are safe and effective or better than available. We know that why do we do research? To provide some innovation or to overcome the limitations. First, let us talk about the benefits. Clinical trials can help us better to understand and treat diseases and provide scientific proof that investigational drugs, now we call all of them as drugs, even if they are devices, they are the new drugs as per the new NDCT guideline. So investigational drugs are safe and effective for humans. They can also generate better evidence on the safety and effectiveness of therapies for the patients, right? Which can improve public's health and ultimately patients' compliance. But as it is very commonly said, every coin has the other side. This also has the potential risk also. So the risk for this new drug trials are new drugs procedures have side effects which may not be intended for, which may not be unknown to the doctors, or new drugs or procedures may be ineffective or less effective than the current approaches. Even if the new approach has benefits, it may not work for everyone. So these are the potential risks. Now, if we classify risk, there are many risks ranging from low to highest risk, minimal, less than minimal risk, clinical risk, organizational risk, financial risk, confidentiality risk, and reputation risk. And there are many more which may not be important for us in this juncture. So what are the minimal risk? Minimal risk are just what the study has less, what is there in, it's not more risky than what is expected in daily life. The probability and magnitude of harm anticipated in the research may not generate or that is encountered in daily life or during the performance of routine physical or physiological examination or test. Say, for example, drawing of blood samples, doing physical examination, interviewing the patient, it won't harm them. The example of studies having such type of less than minimal risk are non-interventional studies like observational studies, as for example, survey or questionnaire based studies. They contain minimal risk, but that does not mean that consent is not required. In these studies also consent are required. Then we move on to slightly dangerous risk. They are clinical risk. These are the risks whose cause or effects are primarily related to the health and well-being of the service users or provisions of care of them. There should be provision to take care of them. These include risk related to standard of care, consent of treatment, working beyond competence, risk related to environmental features, competence of new medical equipment or device, or risk related to clinical waste management. Then organizational risk. The organization who is carrying out the clinical research must have sound preparation. This, unless the sound preparation, there is always risk of organizational risk. This may include the risk related to communication, business plan, provision of services, data protection, human resources issues, and corporate governance. This refers to performance management strategy. After this, obviously, financial risk. It will be organization risk to manage for the proper infrastructure. If there is no financial gain, there will be loss or lost property to regain the investment. So there will be a huge financial risk. Then information security risk or confidentiality risk. Any breach of confidentiality or deliberate or inadvertent disclosure of persons identifiable or sensitive information will be a punitive action, and it is bound to legal terms, as we have seen in previous lectures, Somil sir's lectures. Everything is bound for litigation. Any such breach in confidentiality or loss of security of data, any loss, theft, or destruction of any record held by the organization in whatever form, paper form or electronic form, is a matter of litigation. So there has to be very confidential security of all this data. Then comes the reputation risk. Reputation, we all know, is the perception that others have about the organization. If it's a measure of success of organization's ability to function within its local community and more broadly within its specialist area. Any risk to their reputation means the risk of losing public confidence. So any organization would never like to lose their reputation, right? A serious service failure or clinical incident could affect the organization's reputation and credibility with partners, and furthermore, it could also increase chances of being litigated or litigation. Now, what to do? How to prevent all this risk? So before starting any step, we would like to evaluate the risk assessment. The ways of risk assessment it's a very good practice and it is relevant to all trials. This is a part of trial planning phase and it is done by institutional review board or ethical committee. I won't go into much detail about ethics committee. That will be taken in the later slides, but there is a committee who overviews and discuss about the risk involved and plans to overcome those risks. IRB or ethical committee follows the trial planning and designing and confirming whether the trial falls within the scope of clinical trial regulations. This committee follows 5-step avenue. This is the highlight of ethical committee's role. They will identify what is the hazard, who is likely to be harmed and how much the harm is going to be produced. They will evaluate the risk should be minimal and benefit should be higher. They will consider the risk and decide on necessary precautions. They will record, they will ensure your record and your findings and implement them. And they will time to time review, and they will have a watch on you on the clinical trial. They will keep reviewing and updating your risk assessment to stay compliant. This is the overview of role of institutional review board or ethics committee. Some important measures to overcome the risk. To protect participants, trial may include following process. We have discussed it in very deep about informed consent. Potential participants are explained about the purpose of trial as well as the potential burdens, risk and benefits before deciding whether to participate or not. That is about consent, we all know. Fair subject selection, subjects are chosen based on scientific question while also considering risk, benefit and vulnerability. And risk benefit analysis. The IRB evaluates the potential risk, weighs the probability of the risk and judges where the anticipated benefit justifies inviting people to participate or not. It is rightly said by Mark Zuckerberg, the biggest risk is not taking any risk. Correct? And it is also said there is no reward without work, no victory without effort. And it is correctly said in Hindi, कुछ पाने के लिए कुछ करना भी पड़ता है, कुछ खोना नहीं, कुछ करना भी पड़ता है. So no battle won without taking any risk. So that's all about my presentation. Thank you all. Thanks a lot.
That was such a brief and summarized view of risks for risk trial risk as well as the benefits of it. So thank you so much, ma'am, for sharing your kind words, kind knowledge, insightful knowledge with us. So now moving ahead with Dr. Anuradha Gandhi, our next speaker. I would like to call her on virtual dais.
Hello, good morning, everyone. Thank you, Chaitali, for inviting me for this lecture. Today the relevant topic related to this. Am I audible, Chaitali?
Yes, ma'am, you are audible. Can I just have an overview? Can I introduce
Yes,
you?
yes.
Yeah. So it
Yes,
is my pleasure to invite our excited Dr. Anuradha Gandhi, ma'am. She's a professor in the Department of Pharmacology at BJ Medical College, Ahmedabad. She will be presenting two important topics, that is trial participants and information on medicinal product. Her insight will provide valuable understanding on ensuring the proper management and communication of information related to the trial participants and the products being used or tested. So I welcome you, ma'am.
Good morning, everyone. This is my to be here every time, and thank you so much for organizers for to the new researcher for giving every time new recent, which is ongoing important topics. Today I talk about the trial participants and medicinal products. Now, when we say the my slides are visible, Chaitali?
Yes, ma'am, your slides are
Chaitali?
visible. Can you
Yes,
just change it to
yes,
the
yes.
presentation? Because it's showing the notes with it.
Yes. Okay, okay, okay. It is a presentation only. Just a minute.
Can you go in display settings?
Yes, yes.
So
Is it now?
we
Is
can
it
see the
slideshow?
screen. Yeah, we can see the screen, we can see the slideshow, but there is next slides which are attached to it and with the notes. So if you want to change it to the slideshow itself.
Yes, I competitive slideshow only.
Okay. So no worries, it's visible. The slideshows are properly visible, so no problem.
Shall I cancel and again? Now? Now, Chaitali?
Not shared yet.
Chaitali?
હજી શેર
Hello.
નથી થયું મેમ. હજી
અહીંયા
શેરિંગ
share.
નથી બતાવતા.
Now?
હજી સુધી નથી આવ્યું મેમ સ્ક્રીન ઉપર.
અહીંયા share થઈ ગયું અહીંયા. Stop sharing આવે.
સ્ટોપ શેરિંગ કરી દો મેમ. હા યસ હવે
આવ્યું?
પરફેક્ટ.
હા.
હા.
Sharing. Today I will talk about the trial participants as well as medicinal products. The clinical trials. It is a research related to maybe preclinical and clinical, but clinical it may be conducted evaluation which are conducted in either human.
હેલો મેમ,
Chaitali,
સોરી ટુ ડિસ્ટર્બ.
screen is visible.
ના મેમ જતી રહી છે, શેર સ્ક્રીનિંગ સ્ટોપ થઈ ગયું.
થાય છે.
મે બી ઇન્ટરનેટ સ્ટ્રેન્થ વીક પડતું હશે.
હવે
આઈ વેઇટ ફોર ફ્યુ મિનિટ્સ, ફ્યુ સેકન્ડ્સ, કારણ કે કદાચ લેગ આવે છે એટલા માટે.
ઓકે.
હજી સુધી નથી થયું મેમ.
હેલો.
હેલો. હા મેમ હજી
Hello.
સુધી શેર નથી
હા.
થયું સ્ક્રીન.
અચ્છા એક કામ થઈ શકે, મેં તમને કર્યું છે ચૈતાલી.
હા હા થઈ શકે. જસ્ટ
Is it possible?
હા હા થઈ શકે, થઈ શકે.
Shall I stop from here?
Yes ma'am, you can stop sharing the screen. I'm just sharing it in a second.
Fine.
Can you see the screen ma'am?
Yes. Please make it a slideshow, please.
Yes. Is it fine?
Yes, perfect. So next. So clinical trials, it is conducted in diagnostic methods or therapeutic outcomes, which may include the drugs, cells, other biological procedures, radiological procedures, any medical devices, or behavioral treatment and preventive care. Now, a research participant, when we say participants, it means a research participant or human subject or experimental or trial or study participant or a subject who is a person who voluntarily participates in research after giving informed consent to the subject of the research. Now, here important words are research, human subject, experiment or trial or study, participants or subject. Now, how nowadays participant, healthy participant or included protocol will be healthy volunteers, patient vulnerable populations whenever applicable. Now, informed consent is already discussed by Dr. Dimple Maparam. So I will not going in detail, but it is important. part of the research
Uh,
and voluntarily by any participants. Please, next one.
ma'am,
Next.
your voice is breaking.
અરે યાર.
આમ આવે
Am
છે
I
અવાજ?
audible now?
અવાજ આવે છે પણ વચ્ચે વચ્ચે જતો રહે છે એવું થાય છે.
Okay.
અત્યારે વાંધો નથી, અત્યારે તમે બોલો છો ને તો પ્રોપર સંભળાય છે પણ વચ્ચે
Okay, fine.
હા.
I'll go slow. Be healthy volunteers, it can be patient volunteers or vulnerable population whenever they are applicable. Now, volunteers are also known as a clinical risk volunteer. There has not volunteers that is the purpose volunteerness of healthy volunteers to develop a new knowledge benefited nature. But the data collected from the research conducted in healthy volunteers will compare with the people already specific disease which is collected will be compared with the data of the specific disease, and we get the crucial data about the outcome or what usually number is 20 to 18. Next, please.
Ma'am, still your voice is breaking. કદાચ ઇન્ટરનેટ કનેક્ટિવિટી વીક લાગે છે એટલે વચ્ચે વચ્ચે બ્રેક થઈ જાય છે. કોઈ બેટર ઇન્ટરનેટ કનેક્શન હોય એવા સ્પેસમાં મેમ તમે શિફ્ટ થઈ જશો તો.
વાઈફાઈ માં છું. હોટસ્પોટ બી એડ કરી દીધું ચાલો. અને મારામાં choose a full audible now.
હજી વચ્ચે બ્રેક થયા જ કરે છે એટલે મને એવું લાગ્યું કે મારામાં જ આ ઇશ્યુ છે. મે બી કદાચ મને એવું લાગતું હોય પણ પાર્ટિસિપન્ટ્સ માંથી પણ ચેટ બોક્સ માં આવે છે કે વોઇસ બ્રેક થઈ રહ્યો છે.
Voice breaking, yes, it is there.
એવું હોય તો મેમ તમે કોઈ હેડફોન્સ કે એવું કઈ પહેર્યું છે
So
મેમ?
slowly. ના પહેરી લો.
હા એવું કરો ને કઈક પહેરી લો ને. Hello, ma'am.
Yes, am I audible?
Yes, ma'am.
Now, healthy volunteers, then patient volunteers are there. Am I audible, Chetali?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yes, okay, fine. Yes. So, patient volunteers, they are the patients who are having specific disease of the research interest area are included for comparison, comparative group, maybe with the standard product or with the taste product. The patient may or may not benefit having any benefit efficacy of, although there is a preclinical data is available, but human data is like, so patient may or may not be benefited from the therapeutic intervention. So patient volunteers for studies in which healthy volunteers take part, usually they are compared with the healthy volunteers, or they are compared with the patients who are having the say, given the reference product and compared with the test product. Now, diverse population. Initially, the study were conducted in white men, but over a period of time, it was observed that clinical when women and other ethical or racial populations are also important, because data, whatever the therapeutic outcome was there, it was somewhat different when it was conducted in only white population, male population. Now, then after clinical trials started including male and female patients and of different racial and ethnical diverse populations. Chaitali, next, please. Chaitali. Chaitali.
Yes, ma'am.
Chaitali.
Yes, ma'am, it is
Next,
lagging. Yeah.
Now, when we say vulnerable population, the vulnerable population or person are those individuals who cannot decide for themselves. They maybe because of they don't have any cognitive maturity, or they are because of the some working under a certain authority having lack of power, or they are not able to communicate properly, or they are in such a situation that prevents them from doing so. So they are socially, economically, or politically having disadvantage, and hence they are susceptible to exploitation. So they are known as a vulnerable population. As for example, incapable of making a voluntarily informed decision for themselves, or whose autonomy is compromised temporarily or permanently. They are, as for example, unconscious patients, because they are not able to decide themselves. On behalf of them, their family members or LAR can decide. One is this. And secondly, who are able to give consent, but whose voluntariness or understanding is compromised due to their situational conditions. As for example, they are working in certain authority. When you get authority, you are supposed to take in this, you are supposed to take part in this. So this is undue pressure is there, right? Or unduly influenced either by the expectation of benefit or fear of retaliation in case of refusal to participate, which may lead them to give consent. So, as for example, patients who are not able to communicate, but they are influenced by others, maybe family members, to take part in a clinical trials. So whenever vulnerable populations are included in the study, researchers must justify the inclusion of a vulnerable population in the research. Next, please. Chaitali. Vulnerable population may be women and children. There are many women, children, refugee, maybe economically compromised, maybe prisoners, maybe terminally ill patients. There are some examples of vulnerable populations. Women and children, research involving individuals with mental illness or cognitively impaired or affected individuals, terminally ill patients like cancer patients. So when there are a very less number of therapeutic options are available, or there is no options are available, so they are also considered as one of the vulnerable population. Individuals who have diminished autonomy due to dependency or being under a hierarchical system. Other vulnerable groups include homeless, refugees, migrants, person or population in the conflict zone, riot areas, or disaster situations. Additional precautions should be taken to avoid exploitation, retaliation, reward or credits, and other inducements when such individuals are to be recruited as research participants or in clinical trials. Next, please. When we consider, we will discuss about women and children, particularly in vulnerable populations during this session. Women in special situations, researchers should provide a justification why they are including of pregnant and nursing or lactating mother in clinical trials designed to address the health need, which is particularly for the woman of that conditions, which may affect either that nursing woman, pregnant woman, or what is the benefit or what could be the advantage to the fetus or nursing infants. So as for example, trials designed to test the safety and efficacy of a drug for reducing perinatal transmission of HIV infection from mother to child. See, this is particularly related to mother to child. So in this type of trial, the justification is the participants are justified. Or as for example, the drugs which are useful during pregnancy to avoid or for the treatment of nausea, vomiting, hypertension, or diabetes. When we include women in reproductive age group, they should be informed about the potential risk to the fetus if they are included and if they become pregnant. They should be asked to use the effective contraceptive measures, like 2 measures, one physical and one barrier method should be given, and be told about the options available in case of failure of the contraceptions. Next, please. Chaitari, next, please. Woman who become pregnant during the clinical trial, when they are included in the clinical trials, and if there is no evidence of harm to the fetus with previous data of the trials conducted, then they could be explained to the woman who become pregnant. Then they are offered the options to either they can withdraw or continue. If they want to continue the participation in the clinical trial, then adequate monitoring is required and support as long as necessary during pregnancy is provided by the sponsor and investigator. Now further, prenatal diagnostic studies are also one of the criteria when women are included in the clinical trials, particularly prenatal diagnostic studies in pregnant women, which is limited to detecting the fetal abnormalities or genetic disorders, not for the STD or sex determination of the fetus, as per the regulations in India. Next, please. Now, another vulnerable population is children. We know the children are different from us, like adult population, in so many ways, physiologically, like body weight, body surface area, liver metabolism capacity, or renal excretory capacity, and whatnot. Now, same way, pharmacokinetic and pharmacodynamic properties are also different in pediatric populations. And not only that, safety concern is also one of the important issue in pediatric populations. When we say children, that they are the individuals not attained the legal age of the consent up to 18 years in India. Now, they are considered vulnerable as they do not have the cognitive ability to fully understand the minute details of the study and make the decisions, and hence their autonomy is compromised. They are not able to decide, but maximum up to 12 years of age. Now, at the older age, like after 7 years of age, although they may attain the cognitive ability to understand the research, they still lack the legal capacity to consent. In India, it is legal capacities of 12 years of age. That is fine. Now, please, now in case of pediatric population, it is important to take the with consent of the LAR, legally acceptable representative, and in 0 to 7 years of age. After 7 years of age, verbal assent of the pediatric patient as well as consent of the LAR is important up to 12 years of age, and 12 to 18 years of age, written assent and consent of the LAR is important in pediatric 12 years to 18 years of age. Now, children are included in the disease or conditions which are exclusively seen in the pediatric age group. Now, both adults and or any other conditions where both adults and children are involved, but the issues are significantly different in the both this population. Now, research are generally permitted if safety is established in adult population, but the data is lacking. Data is lacking in pediatric population. Another condition where pediatric populations are included in clinical trials, that is age-appropriate delivery formulations are required in those patients. Or else, pathophysiology of the many disorders, which depends on the child's growth, developmental and adaptive plasticity. As for example, adaptive changes are there in the motor system following a perinatal stroke. So in this many situations, pediatric population, these are some examples where pediatric populations are considered as a part of the clinical trials. Next, please. Now, when clinical trials are considered for any participant, participation is depend on the design of the research project. Now, who will be a part of the clinical trial? Whether healthy volunteer, men, women, both men and women, pregnant ladies or not, or menopausal age group is there, or pediatric patients are there. That it will be depend upon the design of the research project. Project. And taking part in trial is a completely freely voluntarily consent given by the participant in the adult population, and in pediatric population, consent from the LAR as well as assent whenever applicable. Participants can withdraw at any time with no negative effects on the quality of their medical treatment or on their relation with their doctor. So participate કર્યું પછી કોઈ પણ reason when where participant is withdraw, maybe because of ADR or because of their any reason, maybe social reason or any reason, their management should not be affected. Now, whenever they are included in the study, there are certain eligibility criteria is considered for participation in the study. Describe the eligibility, maybe include who meets the requirement of for that particular study based on their age and weight, gender, they are healthy or patient volunteer or vulnerable population, type and stage of the disease specific is there. We need to specify the disease criteria also. As for example, if it is a diabetic patients, you can have the you have to decide which level of the FBS, PPBS, glycosylated hemoglobin is considered to be allowed in your trial. Secondly, which type of other conditions, disease you will be allowed. That is again based on your research project. Suppose your research project is diabetes with hypertension. So whether you are allowing antihypertensive or not, or which antihypertensive you are allowing, that is based on your research project. Which treatment is allowed, which treatment is not allowed, which health issues are allowed or not, that is also based on your research project, your research title. Next, please, Chaitali. Now, this is just an example, which is randomized clinical trial published in NEJM in 2023, semaglutide and cardiovascular outcome, obesity without diabetes. See the titles. It is a semaglutide, role of the semaglutide, and what are the response in cardiovascular outcome in obese patients without diabetes. Now, next, please, Chaitali. You can see that they have defined the trial population. Age is defined, either gender is defined, BMI is defined, which established cardiovascular disease are defined, including MI, previous stroke, symptomatic PAD, etc. are defined from the starting itself. And they have also decided the exclusion criteria like glycosylated hemoglobin level more than 6.5%. Then they have also described the treatment related to which treatment should not be taken within previous 90 days. And heart failure, stage 4 are not allowed, and stage kidney disease is not allowed. So they have given whole describe the who can be a participant in that particular project. Even supplementary appendix also given. If you wish, you can go that supplementary appendix and you can see how they have selected the trial participants. Next, Chetan, please. Okay, fine. I already told about this. Next, please. Now, now for participation, it is compulsory. It is for any researcher, any investigator. It is compulsory to obtain voluntary, written, informed consent from the prospective participant, who are competent individuals and are entitled to choose freely whether not to participate or continue to participate in the research. The participant, for that consent, participant must have the capacity to understand the proposed research, be able to make an informed decision on whether or not to be enrolled, and convey his or her decision to the researcher in order to give the consent. So, not only it is a responsibility of the investigator, participants should understand what is the research conducted about. They are given time to communicate with their family members. They are also allowed to give time to ask their doctor. They can ask, then after they can have if have any queries, they can ask to the investigator, and then they can decide and give consent. Consent not to obtain under undue coercion or undue pressure or undue inducement. Individual who is not capable of giving voluntary informed consent, already we discussed LAR, with or without assent in pediatric population, and consent is given before initiating the study. It is necessary to maintain privacy and confidentiality of the participant by the researcher at all stages. In certain situation, particularly in case of serious ADR or in certain ethical issues where it is important to disclose the data, then it has to be uh, done with the consent of the EC Ethics Committee permission. Next, please, Chitali. Now, when informed consent is given, I already discussed about this. The informed consent is having two part, patient information or patient or participant information sheet and informed consent form. Information about the research, what are advantages, disadvantages, which could be the side effect, whether they are benefited or not, their compensation, which type of compensation is given, undue advantage or undue inducement should not be there. So compensation should not be given that much that inducement will be there. It can be given related to the area of the research. Compensation can be given traveling or for giving their time, yeah, for their participation and their discomfort. That's all about this slide. Next slide, please. This is there. I think someone has discussed about informed consent. I'm not going in detail. Chetal, next, please. This is something about the trial participants. Now, once trial is over, post-research access and benefit sharing is important. So trial is over. The participant can be have information regarding the result of the trial and whether they are benefits benefit if investigator decide that there is some benefit to the particular researcher, then with the consensus of the sponsor and EC, with EC permission, post-research access to the participant about the therapeutic options should be available to the participants, and this will be decided and taken permission from the EC once protocol is designed and put in the EC. So EC approval should be taken in prior. Next, please. Now, this is something about trial participant. Now we talk about the medicinal drug or study medication. We will talk about the medicinal product which are used in trial. So medicine for research is denoted internationally by the term investigational medicinal product. That is a substance or combination of substance intended to treat or to prevent or to diagnose a disease or to restore correct or modify the physiological functions by exerting a pharmacological, immunological, or metabolic action. That is what study medication is. Why? What is the purpose of this product should be used in clinical trial? So to study the whether to study its efficacy and safety, uh, to study whether it is useful in the disease in the large population once it is available to the community, how much drug is needed, whether it is superior or it is cost, it will be what will be the cost benefit, sorry, benefit risk ratio. That is also important. Information about the potential benefit and risk of taking the drug is also considered when study medication is included for any clinical trial. Next, please, Chaitali. Now, an investigational drug, also called an experimental drug, and is being studied to see if your disease or medical condition improves while taking it. That is one scientific guideline is given this definition. As per NDCT, new drug clinical trial rule 2019 define investigational product is the pharmaceutical formulation. It is a formulation of an active ingredient or a placebo. It can be a placebo, including the comparator product being tested or used as a reference in a clinical trial. A reference means it can be placebo or comparator product or any reference, standard reference, right? Can be comparator product. An investigational new drug means a new chemical or biological entity or substance that has not been approved for marketing as a drug in any country, right? Next, please. Now, new drug, which is not marketed, but a drug including active pharmaceutical ingredient or phytopharmaceutical drug, which has not been used in the country to any significant extent. That is one. There are multiple definition of new drug. One which is not marketed, this particular active ingredient, which is not marketed to any significant extent, or a drug approved by the CLA, Central Licensing Authority, for certain claims and proposed to be marketed with modifier new claims, including indication, route of administration, dosage, and dosage form. That means a drug is available for X condition, it is approved for X condition, but now now it has been observed during that for it is also useful in Y condition. So this A drug, when clinical trial is planned for a drug for Y condition, so that is also considered as a new drug for Y condition, including if it is a route of administration. Suppose it is available for tablet route, and now there is it is approved for tablet route, and now formulation prepared for intravenous administration. Again, it is considered as a new drug, right? A fixed dose combination of two or a fixed dose combination of two or more drugs approved separately. Suppose, as for example, A plus B, A drug is approved for X condition, B drug is approved for Y condition. But you think it has been observed that there might be some advantage. So when you combine A plus B in fixed dose combination for Z condition, then it is also considered as a new drug and whole process to be taken as a new drug and clinical trial is conducted. Next, please. A modified or sustained release form of a drug or novel drug delivery system of any drug approved by the CLA, or a vaccine, recombinant DRA derived product, RDNA derived product, or living modified organism, monoclonal antibodies, stem cell derived product, gene product, or xenograft intended to be used as a drug. The drug other than the drug referred to as the subclause 4 and 5, that means modify or sustained release or drug or novel NDDs or vaccine, recombinant technology or monoclonal antibodies, stem cell or gene therapy are considered as a new drug forever, and previous one, new drug like which is not significantly used or FDC or other routes, they are considered for new drug as of up to 4 years. 4 years. Next, please. Now, phytopharmaceutical drug, it is a drug of purified or standardized fraction Since qualitatively and quantitatively we defined minimum 4 bioactive and phytochemical compounds of an extract of medicinal plant or its part for internal or external use on human beings or animals for diagnosis, treatment, mitigation, or prevention of any disease or disorders, but does not include drug administered through parenteral route. Right? So it is a the quantity qualitatively or quantitatively analyzed for bioactive and phytochemical compounds of an extract of medicinal plant or any part, which can be used either in human beings or animals, either for internal or external use, for diagnosis, treatment, mitigation, or prevention of any disease, but not for the parental. Placebo, as we know, it is an inactive, pharmacologically it is inactive substance, but it is visually identical in appearance or to a drug being tested in a clinical trial. Next, please. Next, please. Investigational pharmaceutical product, which is a physical, chemical, pharmaceutical, which is a physical, chemical, pharmaceutical properties of the formulation of the investigational product, which must be documented to permit appropriate safety measures to be taken during the course of the study. Right? When it is submitted to the in a protocol along with the investigator's brochure, it is important to give the detail about the investigational pharmaceutical product, including its physical properties, chemical properties, pharmaceutical properties, and the formulations of that product that has to be documented to permit the appropriate safety measures to be taken during the course of the study. Then instructions for the storage and handling of the dosage is also important. How it will be stored, who will be accountable for that, how it will be handled. Then it has to be recorded, documented, recorded, and it has to be audited anytime. Any structural similarity to the other known compounds should, if it is there. As for example, one formulation is similar to having structure similar to sulfur drug. So it has also be more mentioned in the document, because there might be risk of the allergic reactions in individual or participants who are also having the allergic reactions to sulfur drugs. Next, please. Now, other information from the sponsor side, it is also important to, in addition to that documentation, other like comparator, what is the comparator product, details of the comparator product, safety concern of the comparator product should be also be provided in documents by the sponsor, and this information should be based on the preclinical and phase 1, phase 2 if it is conducted. So the data should be available, and it has to be accurate and adequate to justify the nature, scale, and duration of the study. Any relevant if during the study any relevant new information arises, as for example, new drug which is A used for X condition, and it has been observed that in particular country or world, if it is worldwide or multicentric trial, and it has been reported that SAE associated is higher in number, then whatever or some other information is obtained, then any relevant new information arising during the period of the study it has to be sponsor's responsibility to make it available to the investigator and EC, and then after appropriately, if it is appropriate, then further decision about the trial should be taken, and it has to be informed to the participant also. And as for example, you want to extend your study, then it is also important for the sponsor and investigators to take the reconsent from the participant with proper information in written. Next, please. Now, sponsor will supply the investigator products, comparator, and placebo whenever applicable. It has to be, there should be acceptable storage condition. Suppose it has to be maintained in -4 to -8 degrees centigrade, then it has to be maintained round the clock. Reconstitution procedure. What will be reconstitution procedure? As for example, it is a dry powder. Then how it will be reconstitution? So the reconstitution material should be also be provided along with the test product or reference product, whatever it is, and devices for product. Suppose if you required, as for example, in diabetes study, if it is a pen device, so pen device should be provided by the sponsor, and if any, communicate them in the writing and setting them on the product label also, right? It has to be documented as well as it should be available in the label also. If any significant formulation changes are made in the IP during the course of the study, the results of the any additional studies of the new formulations provided to the to enable to determine their effects in the PK profile of the product prior to the use of the study. That again, it has to be informed to the investigator, and further plan will be decided and informed to the participants. Next, please. The sponsor should document the procedure and lay down the responsibility for adequate and safe receipt of the product, medicinal product, test product, reference product, or placebo. How it will be handled, storage, dispensing of the product. Retrieval of the unused product from the subject. Now, what will be the procedure of unused product is there from the subject? एक strip आपी दी थी अथवा तो एक bottle आपी दी थी, तो and how it will be retrieved? That is again there is SOP has to be there, and it has to be provided by the sponsor. And how it will be returned from the investigator to the sponsor, it has also be documented by the sponsor. Sponsor should maintain the records for retrieval of the product, establish a system for the management of the product, as the sponsor should maintain the sufficient sample from each batch and keep the record of their analysis and characteristics for reference, so that if necessary, an independent laboratory may be able to recheck the same. As for example, some assay happened in particular batch. So sample of each batch, suppose 1, 2, 3 batch is there, and 1, 2, 3 batch shows the assay in three patients. Now, sponsor is having that samples of that batch, so that samples can be rechecked whenever required. That is why it has to be kept. Next, please. Now, investigational products. From the investigator side, the investigators are primarily responsible for investigational products accountability at the study site. Now, they maintain the records and the unique code number which are assigned to the investigational product, packs, and the study subject. So all the code number, with the code number, how it will be stored, how records will be maintained, who from the study team, who will the dispense and who will keep the record, who will allow this investigational product to handle, will be all SOP should be there with the investigator. In this investigational product should be available in sufficiently throughout the study duration and stored properly for its efficacy maintenance. It has to be supplied only to the subjects who are eligible to receive it and at the specified doses and time. Suppose patient એવું કહે છે કે મારા વાઈફને પણ હાઇપરટેન્શન છે ને હાઇપરટેન્શન મને સારું રહે છે તો તમે મારા વાઈફને પણ ના આપી શકો અથવા તો it should not be allowed. Or suppose someone says, yes, let me try. It is not like that, right? The subjects are provided with the necessary instructions on proper handling of the product, how to keep it, whether it is stored in the freeze from from the children, whether diary should be maintained or not. Everything should be instructed by the investigator. The receipt, use, return, and disposal of the product at the site are controlled and documented as prescribed in a SOP has to be maintained by the investigator. Next, please. These are some references I have used in this lecture. I'm very sorry for I'm not able to connect from my internet. Chaitali, it is still showing full internet. I don't know why it is not. I'm not able to connect it. Sorry, I'm very sorry for.
No, ma'am. Don't be sorry. This happens. The technical issues are there always. when we are actually dealing with technologies or when we are using those technologies. So
Yes,
don't
yes,
worry, ma'am.
Chaitali, we had a lecture on AI last time, even yesterday we have a lecture, same issues where we will discuss, and today it happens with me. Thank you so much, Chaitali. Thank you,
Okay.
Chaitali.
Thank you so much,
Thank you.
ma'am, for emphasizing on the importance of selecting an eligible individuals based on the inclusion exclusion criteria, whom to be selected, how to be selected, and also uh, informed consent and the regarding the medicinal products, how we can use formulation, dosages, administration, thorough documentation, and aligning all with the regulatory guidelines that you have emphasized on. That it was very in detail. So thank you so much, ma'am, for being with us. So now I would like to call our next present speaker. Dr. Pooja Dullo, ma'am, I'm making you co-host.
Good morning, everyone.
Good morning, ma'am. Am I audible to you?
Yes, yes.
Okay, ma'am. So,
Is my screen visible?
yes, ma'am, it's visible.
Okay.
So
I'm
here I
making it as
welcome with utmost pleasure Dr. Pooja Dullo, ma'am. She is being a professor, head and professor of physiology department at Parole University, and she is also being the head of the quality assurance unit at Parul Institute of Medical Science and Research. She has given or served her academic work at Bhaikaka University in past, and she has started her academic journey being an MD in physiology from 2004, and following post-graduation in diploma in health, hospital and healthcare management, master's degree in Keele University from London in 2019, and continuous learning is further demonstrated by her FAMER Fellowship in 2012. She has 19 years of academic experience, both nationally as well as internationally. And she's also has served as an associated editor for the Basic Research Journal of Education Research and Review, and reviewed many numerous national, international journals indexed in the PubMed and Scopus. She has to have her on her name 38 publication, more than 38 publications, and she is a dedicated to medical education, which is evident in her development to 3 ROC templates with 4 more applications which are pending, and I think they must be also come to the confirmation on the other side. In addition to her academic research, she has been actively involved in organizing conferences and webinars, which are associated with APPI. And recently, we were been in touch on the webinar for a webinar on the APPI platform. She has also been shared her expertise as a resource faculty in various national and international platforms. So with this, she's going to enlighten us on the good quality trials which are used for good clinical practice. So I welcome you, ma'am, with all of this full-heartedly.
Thank you. Thank you. It was so big introduction of mine. I think that was the biggest one I ever heard. Thank you so much for being so nice to introduce myself. Although many of the components which I will be talking right now have been explained in quite detail, but I would like to have an overview about it in terms of quality assurance and quality control. Thanks, Dr. Chitali. So as far as the topic goes, good quality trials, the question is, the good quality trials are evident. Basically, they are the foundation of evidence-based medicine, and they ensure that new treatments and interventions, they are safe and effective. They're the most important reason why the quality trials should be good. Now, what actually the good means? So before that, what is a clinical research? a study of health and illness in people. We have two types of clinical research. One is an observational study, which monitors people in a normal setting. And another is a clinical trial, which tests, where the tests are medical, surgical, behavioral, and associated with intervention with the people, with the human being. So that's how the importance, because human intervention has come up. So we need to be very, very careful about it. What is the importance of a good clinical trial? Why we should have a good clinical trial? The first important aspect of it is to have an informed decision making. The quality trials which provide a reliable evidence to guide the healthcare to make a decision and optimize about the patient care. So it has to be very, very good and robust. Then safe and effective treatment, which ensures that the new therapies or new treatment modalities which are coming up by those clinical trials, they are safe and they are effective before being widely adopted by the community as a whole. Moreover, it also is important in terms of advancement of medical knowledge, that trials contribute to advancement of medical knowledge for development of better treatment. Now, this treatment can be laboratory-based treatment, diagnostic treatments, what we term as, or it can be treatment in terms of patient care system as a whole. So we are taking better treatment in a holistic manner. The quality, when any quality trial which is not up to the mark or is not standardized, which we term as a poor quality trials, why we need to look into it? Because if we do a quality trial which is poor, it's a waste of time. Second, it's a waste of resource, patient resource, healthcare resources. It's also waste of financial resources, which is very, very important to look into the matter. And an unnecessary burden to the patient. That means it is unethical. So we need to be very sure whenever we are performing any clinical trials or clinical research, whether it is observational or trial-based, we need to be sure that we do not fall into the trap of poor quality trials, because they actually are making it more burden to the society as a whole. Now, defining the good quality trials, there are many parameters, but I have categorized them under three major headings. One is the clear objective, or the trials have a well-defined goal. They have a well-defined hypothesis to be tested, which ensures a clear direction for the study. That's the most important thing. As well as a well-designed study relies predominantly on a thoroughly considered, well-structured and complete protocol. Even if the goal and the hypothesis has been clearly stated and we know what exactly we need to find out and why we need to find out, if the protocol is not complete, it is not well structured, then also it has an questioning being a good quality trial. The second is the ethical conduct that prioritize. I think my previous speakers have talked a lot about the different aspects of the ethical conducts associated with the patient, associated with the guidelines, ethical guidelines of the research. So we actually need to prioritize the welfare of the participants and adhere as per the ethical guidelines for the research. That's a very important thing. And the next comes up, which is a part of the ethical associated with the ethical conduct, which also separately is being termed as a rigorous methodology, which actually employs strict scientific method so as there is minimum bias and ensure that the results are accurate and reliable. That's a very important thing to have good quality trials. Now, if I go further for characterizing the key components of the good quality trial, the first and foremost is randomization. The patients are assigned to treatment group randomly so as to avoid a bias. If I have a purposive sampling, which we normally do in a qualitative research, then the possibility of bias while we are making a purposive sampling might be there. But when we randomize the trial, then the bias of selection of participants becomes minimum. Second is blinding. Now, it can be a single or a double fold blinding. Single blinding means that the participants are not sure what treatment protocol or whatever the clinical trial is going on. They're not knowing about it. While the researchers or the physician who are a part of this research, they are aware of it. Now, double blinding means where the researcher or a physician who is a part of this research is not very well sure about what exactly is there, and the participants are also not there, which becomes much better assignment to prevent the bias as a whole as far as the outcome of the trial is concerned. Third is control group. A control group receives standard care or a placebo compared with the experimental treatment. Now, these placebos should be well categorized and well stipulated as far as the outcome is concerned. That means the care of the patient should come first. The basic ethical principle should be followed whenever we are giving any placebo to the patient. Next comes the data analysis. And data analysis means the statistical method which are used to analyze the data and determine effectiveness of the treatment. The test, whichever we are following, whether it is a parametric or a non-parametric, if it is a non-parametric, which all statistical tests should be utilized to have a better and a discrete effective outcome from that particular research. Another aspect, the key component is the sample size. The sample size should be adequate. So as we can have a standardized, because whatever we are doing in a clinical trial, we are doing in a group of sample, and then that group of sample is representing the whole population as a whole sum. So we need to take care of the number of the participant needed to detect a statistically significant difference between the groups. It's a very important thing. We should be very clear about the inclusion and exclusion criteria when we are preparing a methodology protocol for any for having a good quality trials. The another important aspect is the statistical power. What exactly it is the probability of finding a statistically significant difference if one truly exhibits. That means the trial must have a sufficiently powered, usually 80% or higher is considered to be better, so as to minimize a false negative or a type 2 error in our clinical trials. So this is very important aspect to have a good quality trial. Each stage of the data handling must be monitored to ensure that all the data, they are reliable and they are procured or processed correctly and appropriately. The ethical consideration, I think Dr. Swapnil has already informed and other speakers have already talked in detail about it, but I'll just make it connected with what exactly they have talked about. The ethical consideration in a good clinical trial is first the informed consent, which has been already explained in great detail by previous speakers. Second, participant safety. That's a very important aspect. The well-being of the participant is of paramount importance, which basically the safety measures are implied during the clinical trial. The third very important aspect is the confidentiality. Confidentiality at every level should be maintained. So that basically is the component which should work upon. Then next comes up the equity and justice. The trial should be conducted in a fair and equitable manner, which actually ensures equal access to potentially benefited treatments. So these ethical considerations are very, very important in terms of good quality trials. Now, why, how, and which parameters need to be taken? Basically, it is the quality management as a whole sum in a clinical research, which aims to establish consistency to achieve the compliance with ethical, regulatory, and GXP standards and maintains authenticity of the clinical data. Now, under the quality management, there comes quality assurance and there comes a quality control. Now, quality control and assurance, they are the standard components of the quality management system in the clinical research. And they are basically attainment of the standardized quality assurance and quality control is very important to have a good quality trials. Before we go ahead, let's have a glimpse about what is the difference between assurance and quality control, because many people have they consider it as a synonym, but they are not synonyms. They are connected to each other, but they are not synonyms. As far as the quality assurance, it is a process oriented, while quality control, it is a product oriented. Let me give a simple example. Say, for example, I am trying to take a blood pressure of a patient as a clinical research with one particular instrument which I want to assess. Now, if the blood pressure value with that instrument is not coming up accurately when I compare it with the standardized instrument, that means there is a fault in the instrument as a whole. Now, quality assurance will ensure that the new instrument is calibrated in such a way that the two outcomes come up at an equal level. While the quality control will focus on the product, the error in the product, so that it cannot be further propagated. So one is product oriented and one is the process how it is going on. So that's a basic difference between the two. One is active and one is a corrective measure. That means the quality assurance, it's a preventive process as it establishes the method which prevents the issue. While quality control, it corrects the process so as to focus on the issues to fix them. So that's the two different things, but they are going hand in gloves to each other. The person who is responsible for the quality assurance, all the people which are involved in the project, clinical trial or a research project, starting from the requirements. While for the quality control, it is the inspector or the testing team that find the issue. They are basically responsible for the quality control. If I give an example for both, one example I've already given. The another is the quality assurance, the process checklist, the process of the standard operating procedures, the documentation, the project audit, they all come under the quality assurance. While inspection, delivery, peer review, software testing process, they all come under the quality control. So that's the difference between the quality assurance and the quality control. And both need to be actually satisfied to have a good quality trial. Now, the quality management as a whole sum, it is a use of risk-based approach. I think one of the speaker did talk about it. The critical process and data identification is basically the sponsor must identify something what is critical and the data during the protocol development, so as to ensure the human subject who are the participants in this, they are being protected and the reliability of the trial results come up to a very great extent. The second very important component for the quality management, which in turn talks about the good quality trial, is risk identification. The sponsor must assess the risk. It should not the sponsor should not be in a way that they are not able to assess the risk of a clinical trial procedures. The risk can be at any level. The risk can be multifactorial. It can be at the standard operating procedures. It can be for the statistical test. It can be the computerized system, personal or informed consent, any component or any level of the clinical trial or a research trial, any aspect can be at a risk. So risk identification is very important aspect to have a good clinical trial. The another very important is evaluating the risk. One is identifying the risk, another is evaluating. That the sponsor must assess the identified risk against existing control, considering firstly that the likelihood of the errors are there, they are detectable, and their impact on the human subject protection and the trial results are having a great reliability. A risk can be considered as a risk issue only if it follows those aspects or they falls into these particular criteria, and they need to be evaluated for it. The next is risk control. We have assessed the risk. We have evaluated the extent of the risk based on the components. Now, we need to control that risk, which is a part of or the work of a quality control individual. The sponsor should decide which risk to reduce and or which risk to accept, because it's not always that all risks need to be reduced or all risks need to be eliminated. It may not be possible 100%. There are certain risks which we need, there is a reason and there is to have a quality clinical trial outcome, the risk needs to be reduced. Or sometimes there are certain risks which we can overcome. Say, for example, a sample size. The sample size is not coming out aptly. Sometimes with the documentation, we can take it as a risk which can be acceptable, but it also depends what type of clinical trial research question has to be worked upon. The approach used to reduce the risk to an acceptable level should be proportionate to the significance of the risk. That means it depends how much reduction is required, whether we should remove that risk altogether or there is a need of reduction, what percentage of the reduction is required. It basically is dependent upon the proportionate significance of that, how much risk hampering will be there as far as the ethical norms are concerned. So accordingly, the reduction in the risk, acceptance or rejection of the risk factor has to be taken care of. The next component is communication. That's a very, very important. Many people, they do find a risk, they reduce the risk factor, but they do not document, which is not right. That may not be considered as a good quality research. Because if you're not documenting it right now, someone else who is doing it in a setting, at their setting, use your methodological protocols to identify whether it is working in their setup or not. Then this non-documentation of this particular aspect will create a questioning at your clinical trial outcome. So the risk should be documented in the quality management activity. The quality assurance should ensure that these risks which have been identified, which have been evaluated and controlled to some extent, or it have been reduced, or it has been accepted. Whatever risk has been, whatever the control measures have been done for those risk factors, they are well documented there. Then review. We need to review also. We have done everything, we have controlled it, but we need to revisit whether we have done it appropriately or not. For that, there is an important aspect of reviewing the risk. The sponsor should regularly assess the effectiveness and relevance of their quality control or quality management activity by reviewing the control measures, whatever have been taken up for that clinical trial. That actually is considered as a new knowledge and a new experience for that clinical trial. This itself is a proven fact that whatever you are regulating, it is being reviewed, whether it is the outcome is coming up to the expected standardized norms or not. That itself is a new experience. So it's very, very important to document everything. So the quality management, actually, they should adhere to international guidelines or the national guidelines, which already have been talked about, the ethical rules, Indian standard or ICMR guidelines. So they should ensure the compliance with the standards like good clinical practice. Safe monitoring by incorporating the mechanism of ongoing monitoring of the participant safety, such as there should be a data safety monitoring board for within the institute wherever the trials are happening. So that board, the task of that board is to monitor those risks and control those risks and finally document it and review it at different intervals so as the safety is ensured. Handling the missing data. Sometimes one parameter or maybe two parameters of the data are missing from that particular participant. That doesn't mean that we should remove the name of the participant. That's not right at all. It should be mentioned there, and there should be a strategy for addressing the incomplete data. That is termed as intention to treat analysis. That handling of the missing data also should be ensured. Ideally, we should try to have complete data, but in many cases, it happens during the clinical trial works or during even the routine observation studies, some of the data is missing. It doesn't mean that we should remove the subject from altogether from the data. We should keep it in the documentation and address it as an incomplete data. The another very important aspect for a good clinical trial is to audit. Now, what exactly, according to ICH GCP, the audit means? A systematic and independent examination of the trial to evaluate that the activities were conducted, the data recorded, analyzed, and accurately reported according to the protocol, sponsors, SOPs, good clinical practice, and applicable regulatory requirements. That means whether international or national regulatory requirements, they are fit for it. That's the basic definition of an audit. Now, an auditor, it has to be commissioned by the sponsor. But the person who is being appointed as an auditor should be independent of those responsible for the study. Normally, sometimes people, what do? They identify a person who can audit it, but directly or indirectly, that auditor is a part and parcel of the study. Then the person cannot be considered as an auditor. They should be independent of the responsible study work. The investigational sites, facilities, and all the data and documentation should be made available to the auditor, and the inspection by the sponsor's auditor as well as by the regulatory authorities. So as it becomes very clear that the documentation, whatever the components of the clinical trial have been going, they can audit each and every step of the process to ensure that the work is quality, is well acquainted with the good quality, it is reliable, it is reproducible, and the outcome is effective. That actually is very, very important. The auditing of the data at the different levels. The sponsor should adopt an proportionate and risk-based quality management approach. We just talked about what exactly the risk-based quality management means, starting from assessing a risk and finally coming up to the review of the risk component. So it is incorporating the quality into the design of clinical research or clinical study. So these all components of identifying the risk and each and every level of the study while the process is being audited is very, very important. The focus should be on identifying factors that significantly impact, firstly, the patient rights, which includes confidentiality, informed consent, and so on. Second, safety. Third, well-being. And last but not the least, the reliability of the results as per ICH E8. So these all aspects should be identified and focused upon while auditing, while the person is auditing the data at different levels of a clinical research. So you can see here, this is the diagrammatic presentation. Firstly, there is a trial protocol. Even for the trial protocol, the audit has to be done for the study protocol, so as to evaluate whether the research question and the objectives are clear, they are clearly stated, whether the methodology is aligned with that of the stated research question, hypothesis, and objectives. And once the methodology is being laid out in a very sequential and characteristic manner, specifying the study design, the data collection methodology, also talking about the sample size, why this much sample size, inclusion, exclusion criteria, all those components are well stated. Then the data collection method also has to be audited. Initially, a small group needs to be audited. Once it is being considered to be well acquainted, then the further data can be taken up. Once all the data has been audited, has been collected, firstly, a small group is being audited, then the whole data is being collected. Now, this whole pooled data or a database needs to be audited, whether the data is as per the protocol being worked upon. Then we come up to the analysis of the data. Again, the audit of the graphs, the tables, the stats, whether the statistical test being implemented to come up for an outcome is appropriate for the type of study. So that also has to be audited. And finally, the trial report. And during these processes, the auditor also looks at the risk aspect, whether any risk factor was assessed, even the how the missing data was handled, whether the documentation was correct, if there was a risk, whether the control measures were done. If the control measures were done, then the review of those control measures, how it was being done. Then again, the process, how it worked upon. All components have to be audited in a very structured format. So as we say that the quality trial is good. That's what we say, good quality trials. And finally, lastly, when the trial report comes up, the audit of the trial report also has to be conducted. These are the steps for different types of study. Ideally, for the clinical trial, all those components are going on. But if you have a observational based clinical research, then maybe the initial part and the audited data, or maybe only analysis and then going up to the trial of the report, that can be taken care of. But yes, these are the basic steps to have a good quality trial. So in conclusion and takeaway message, what I can talk about is good quality trials are essential for advancing the medical knowledge and improving patient care. They provide reliable evidence to guide healthcare decision and ensure safety and effectiveness of the new treatment. That's very important, to have an effectiveness of the new treatment. And by adhering to the ethical principles, which I have just given the glimpse, but the earlier speakers have talked in detail, and employing the rigorous methodology, we can ensure that the research contributes to the well-being of the patient and the advancement of the medicine. With this take-home conclusion, I would like to conclude my talk by thanking the organizing team to provide me an opportunity to talk about the topic, which has been very close to me as per, not as a clinical trial researcher, but as a researcher, as a wholesome. So thank you so much.
Thank you so much, ma'am, for enlightening us on quality assurance in healthcare, which ensures the medical services that has established a standards of safety, effectiveness, and patient care, and how we can systematically monitor, evaluate, and continuously improvise in our practice. This also helps to reduce the errors and also improves the clinical outcomes, and it also maintains the compliance with the regulatory bodies. Thank you so much for joining with us, ma'am.
Thank you.
Now I would like to call Dr. Usha. I'm making you co-host now. Welcome, ma'am. I have made you co-host. Am I audible, ma'am?
You are audible, and right now I am going to present my screen.
Just a minute, ma'am. So here I welcome Dr. Usha Patel, ma'am. She has completed her MD in biochemistry and currently serving as an assistant professor in the Department of Biochemistry at Narendra Modi Medical College, Maninagar, Ahmedabad. She has to have more than 10 publications in her name, and she's going to enlighten us about the trial staff, which is a very crucial role in ensuring the success and integrity of the clinical trials. So I extend my warm welcome to you, ma'am. Am I audible?
Yes, good morning, everybody. Thank you, Dr. Chaitali and JV Bhatt and whole team for inviting me as a speaker on this webinar. This is again very crucial, important for our research point of view in good clinical laboratory practice also. Thank you very much. So just today, I am going to tell you about the different clinical trial staff. Our previous speaker, very first speaker, Guru Sharan Madam, has already discussed about the main principal investigator in the clinical trial staff. Actually, when you see the whole team of the clinical trial, it includes not only the basic regulatory body, but it includes principal investigator, sub-investigator or co-investigator, clinical research coordinator, clinical research associate, data managers, and other lab technicians, pharmacists, etc. So already too much is discussed with Guru Sharan Madam, but just I will brief you about the sub-investigator or co-investigators. These sub-investigators and co-investigators again play very crucial role in the clinical trials, but they have to work under the guidance of principal investigators. Again, they should be from the medical degree or equivalent like dental, and they have a capability to understand that particular disease process, and they have very good capacity to diagnose and treat that particular therapeutic drug or any other involved in the clinical trial. They should undergo the specialized training depending on the need, and they should be aware of all type of research methodologies as well as regulatory requirements, and they should also obtain certain special certificate like GCP certificate. And sub-investigator also should be affiliated with that particular institute which conducted clinical trial. So it must be either medical staff or having formal agreement with the institute. There should be sound in the regulatory knowledge, so it is important to overcome to ensure the compliance. And throughout the clinical trial, all the sub-investigators try to have the capacity to adhere the protocol which is prepared previously, and they should monitor the patient safety. Now, what is the main role of investigator, sub-investigator or co-investigator in clinical trial? Actually, this sub-investigator or co-investigator, they are assisting the principal investigators to whatever main duty of the principal investigator, they have to help them. They either work with the collaboration with the PI, or they have to take a special delegated duty which are assigned by the PI, ensuring that trial protocol is properly followed or not. They have to help the planning and decision making process. They have to take in patient care and management. They have to indirectly or directly engage with the trial participant, including assessing their eligibility, performing their medical examinations, seeing the inclusion, exclusion criteria, and they have to give the treatment as per the study protocol. And throughout the trial, they have to observe the participant for any kind of side effects. And immediately they have to report either monitoring body or the sponsor body or the principal investigator. They should be have very good sound communication skills, so they can easily interact with the patient, research staff, and other regulatory bodies. And this is important for the obtaining the informed consent procedure also. And throughout the trial, the principal investigator ensures that all the aspects of the trial protocol is properly followed or not, including the study procedure, inclusion criteria, exclusion criteria, and site of the visit. And whenever they are performing any procedure, they have to maintain the accurate and thorough documentation of each participant, including their medical records. And whenever any deviation or any adverse event, immediately they have to report. And after performing that procedure, they should give this to the data collecting team, so they easily enter into the database, and it is helpful for the data analysis. So whenever this main role of this sub-investigation, whenever any compliance with the regulatory requirement like GCP compliance, actually they have to follow every time good clinical practice. But whenever any deviation occurs, they have to immediately inform to the principal investigators. And throughout the clinical trial, they have to look after the participant welfare. That is very well discussed with our previous speaker, and they should be having very good coordination with the team meetings. Means they have to participate in study meetings with other technicians and patient status, any issue or challenges, they have to inform to the principal investigator, and they have to organize the training for the other staff members. Whenever any issue arises, they have to immediately resolve any issue or challenges that arise during the trial, such as patient non-compliance or protocol deviation. They have to work with the PI to adapt the study procedures as needed to ensure the trial success. The next staff is clinical research coordinator. They are important for the managing the day-to-day operation, like data collection and data documentation. Means whatever daily recruitment process for the patient in that study trial is that it may be managed by the clinical research coordinator. Again, they should be having the bachelor degree in either nursing or related field, or it may be higher degrees like master degrees, or they should be also having some clinical experience of the research or in healthcare familiarity with the clinical trials, and they should undergo the certain training program so they can have the certification from the Association of Clinical Research Professional or Society of Clinical Research Associate. This clinical research coordinator should be again having very good organization skills, so they can easily organize and manage the multiple tasks at a time efficiently. So it is again helpful for the enrollment of patients. They should have excellent verbal and written communication skills for interacting with the participants. So again, they are helpful for the study participant as well as communicating with the regulatory body, and they have to see high attention details to ensure the accurate data and accurate protocol is followed or not. So whenever there is any change or deviation, immediately they have to document. Ability to identify and address the issue that arise during the trial, including the participant-related problem or protocol deviation. The main important role of clinical research coordinator is study planning and implementation. So whenever we need to study any new drugs or new medicines, immediately they have this clinical research coordinator undergo the training, and they should be having the protocol familiarity, and then they have for principal investigator and sub-investigator to assist the site preparation, including the IRB, ISC submission, regulatory documentation. So they are going to schedule the meeting, and they are important for the preparing the coordinate the participants visit, And whenever it is needed, they have to helpful for the doing performing any test or procedure in accordance with the principal and sub-investigator. Then they have to have very good communication skill between the site operator and study sponsor or research organization. And whenever any compliance, then immediately they have to inform to the regulatory bodies. And throughout the research trials, they also follow the good clinical practice management. They are important for the identifying which patients, which subjects are going to recruit or which are rejected. So whenever there is some difficulty arising during the participant recruitment, they can be mitigated through effective outreach by participant management. They are important for taking informed consent. So indirectly, we are clinical research coordinators help ensure their safety, well-being throughout the trial. And once the trial is conducted, then they have to collect the data and accurately, precisely, including the history, lab research, and then it will give to this, enter into this record form as well as electronic data, and then it to submit to the data analysis teams. So whenever any challenge is coming during the trial, either in the compliance issue or any other things, they have to help sub-investigator or principal investigator. So these clinical research coordinators are critical for ensuring that trials are conducted efficiently and ethically, directly impacting the quality and validity of research findings. And these coordinators are also important for monitoring the any kind of adverse reactions or protocol deviations. So they should be having sound knowledge of that particular protocol. And they should undergo the training of GCP and everything so they can easily manage these things. Next important for trial staff is clinical research associate. Again, this clinical research associates are important for monitoring day-to compliance during the studies. And they have to check the integrity of the data. They have to visit the site. So they are again important for the day-to-day procedure of the trial. They are having they should be qualified in life science or nursing or pharmacy fields, or it may be higher degree in the master degree, or they undergo for clinical research training or health related fields can be advantageous, but always it is not required. So the main role of this clinical research associate is again for the site selection, evaluate and select the clinical trial site based on their capabilities and depending on the requirement of the study. They are important for the site initiation, conduct the site initiation visit with the principal investigator and sub-investigator to ensure that the site is prepared to begin the study, including the training site staff on the protocol and procedure. And throughout the study, they have to visit this particular site regularly to monitor the progress of study, ensuring that this is properly adhere to the protocol and good clinical practice guidelines or not. And whenever any abnormality occurs, any deviation occurs, then immediately they have to inform either regulatory or monitoring body or principal investigator. And data verification, they have to, once the whole process is occurred, then they have to record and everything is they have to submit to the electronic form and data analysis team. So this is the main duty of this. The main skills which required for the clinical research associated is attention to detail, means ability to meticulously review the data. They have to see that data properly and document it. They have again having very good communication with the site staff, sponsor and stakeholders. And they are having very good capability to identify the any issue and challenging and try to solve the problem for the participant as well as stakeholders. They are having very good capability to maintain their organization and maintain the accurate data. So depending on that skills, the whole effect occurs on the trial. So they are the clinical research associate coordinate are important for the quality assurance. They are maintaining the quality and credibility of the trial by ensuring the compliance and data integrity. And they are also important for the ethical aspect in participant safety. So by monitoring the compliance with GCP and protocol, clinical research associate help in the safeguard of participant well-being also. And they are also important for the regulatory success, means they are important ensuring that trial meets the regulatory standards, so which is essential for the success of approval of new treatment. The next step is data managers. This data managers, I'm not going to tell too much about the data managers, but again, they are typically bachelor degree in science, computer or statistical, because our next topic is on the data analysis. And again, this data managers should have sound knowledge of all the different type of software like SPSS, GraphIT. They should be having very good experience in the relevant field before they entering into the protocol. Familiarity with the data management system and tools. The main importance of the this data manager is for the data management. It should be have capacity to standardize the data analysis. Any problem arising, they can be identify that data issue and immediately try to solve it by communicating with the organizing or monitoring body or principal investigator. They have to thoroughly see the accuracy of data and integrity and maintain. So this I am not going to detail, but the core competency of this data analysis is helpful for the outcome of whole trial. The other trial staffs are pharmacists, laboratory staff, then X-ray technicians. In the case of pharmacists, again, this pharmacists are important whenever in drug trials. They should be having the doctor of pharm MD or equivalent, or current pharmacist license in the jurisdiction with the conducted. They should be again having sound experience with the clinical knowledge. So that is important for the research related pharmacy work. And they should understand the regulatory bodies trial related medications, and they should undergo the certain research certification course also. And they are important for the preparation of study drugs, reconstitute, package and label, which are utilized for the study protocols, dispense medication properly and ensure the correct dosing, administration, site of the study, depending on the study requirement. That then they should be also work for drug accountability, properly maintain the inventory as well as storage, and record keeping, where how much drug is utilized, how much it is returned back. They are also important for the safety of the patient and any compliance. Means again, this pharmacists have responsibility to monitor the drug and any adverse drug reactions, and immediately it should inform to the principal or sub investigator on others. The next is laboratory staff. The laboratory staff, again, they are bachelor degree in laboratory science or medical technology or other related field, or they may be having higher degree. They undergo either certification of medical technologies course. The main important duties of this medical technician which are involved in the trial protocols, they should follow the standard of good laboratory practice. And then the accuracy and reliability of that test result which are done during the whole trial process is reliable. So this laboratory technician should be follow the proper good laboratory practice procedures for the collection of the samples like blood, urine and other samples. They have to process the samples, analyze the sample and conduct the result, conduct the whole test and release the result depending on the study protocol. And the documentation of report of laboratory results should be informed to the study team. And actually they have to maintain the proper data entry in the electronic form as well as in the hard copy. And throughout this, performing the test, they have to try to maintain the whole quality control by the high standard of accuracy by running daily calibration, quality control in the machine. The equipment which are utilized, they should be calibrated and maintained in the laboratory properly. And whenever the quality audit is quality assurance audit is coming, they are supposed to show it properly. In this way, by knowing the different clinical trial staff, we are able to manage the budget. So we can utilize that budget properly by distributing among the various staff. So thank you everyone. The very good quote from Henry Ford: if everyone is moving forward together, then success care of itself. Means if we follow the good clinical practice and good laboratory practice for any trial with a teamwork, then success can take care of itself and we can utilize for the better future.
Thank you so much, ma'am, for discussing the key person's responsibility, that is a trial staff's responsibilities during the clinical trials. and how their roles, so being a pharmacist, being a other professional, being a technician, being a research nurse, or being a research coordinator, how their duties will be adding into the trial protocols, and how we can maintain a effective communication for a better ethical conduct and recording. So thank you so much, ma'am, for discussing and describing the duties and responsibilities of the trial staff.
Thank you
Thank you, ma'am.
everyone for this kind listening.
So further, uh, moving ahead with the next speaker, Dr. Harsh Joshi. I'm making you presenter, sir. Am I audible, sir?
Yes, yes. My voice audible?
Yes, sir, you're audible. So he's an eminent doctor and author of a book, Dr. Harsh Joshi. He's currently serving as an assistant professor in the Department of Pharmacology at NHL Medical College, Ahmedabad. He's also contributed in many educational research. He has notable achievements in the publication of an acclaimed book, that is Pharmacological Essentials, which has a vital reference for the students and professionals across the India. He also published, it is also published by a Paris publication, and which has garnered the widespread recognition. He has recently revised an internationally recognized book, Sharma and Sharma's Principle of Pharmacology, which is in his expertise of the field. His scholarly work has more than 10 patents, and showcasing his exceptional contributions to the field of invention. He's also a Guinness World Record holder for the thickest book in the world. His remarkable accomplishments have earned his numerous accolades, including the Bharat Vibhushan Award, Eminent Author in Medical Education, the Rabindranath Tagore Award, the Mother Teresa Award for Social Work, and the Rashtriya Ratna Samman. Today with us, he will be addressing on the topic of clinical trial data and good manufacturing practices. His extensive knowledge and experience make him uniquely qualified for this valuable insight on these clinical areas of clinical research. I welcome you, sir,
Thank
on
you.
this virtual dais.
My slide is visible?
Yes, sir.
Okay. I'm changing the slide. Is it
Yeah, it
proper?
is
And the
visible.
voice
Yeah.
is okay?
Yes.
Okay, yeah. Thank you so much for the kind introduction. So today, I just welcome you all, first of all, to be here in the GCP, a qualified good clinical practice. An update also, I will give you the update which we received a week before that, which are some changes in the GMP and the clinical trial data. So I will take you a brief of the two parts of the talk, which is first is the GMP. GMP is a good manufacturing practice. So first we will understand what is it. So GMP is a system for ensuring that the products are produced in the proper quality, and also it is a maintained in proper quality. So the quality standards to be perfect. It is designed at the minimize the risk as the batches of the products which are published and which are selling in the market should be in a proper quality with the minimum risk with the equal quality distribution. So the final product will eliminate and minimize the risk with the pharmaceutical production. It also goes with the devices, vaccines. GMP covers all aspects of starting from production, from the means the raw material, the equipments, the premise also where the manufacturing is going on. So there are various WHO guidelines which will be given, and we are going to discuss one by one. Okay. So good manufacturing practice is the standard of performance. As you can see in the slide, that it is a commitment that we are giving the quality standard drugs, quality standard device, quality standard vaccines with the top management work holders, operations, technicians, as discussed by the previous lecturers, by the previous speakers, supporting staff. So it is not a single person, it is a committed work, personal work, audit, very, very important. So what is the objective? The objective is to give the high quality product to the consumer and delivery the minimum possible problems, the contamination, as we can discuss. So as per WHO, the first is the pharmaceutical quality system. The manufacturer must assume that it is the responsibility of ours to give the proper product to the community. So then and then the encouragement starts. It comply with the requirement of the authorization, means the regulators, what they give, they have to follow it. So then and then the proper safety, quality, and the efficacy should not be compromised. If it is inadequate, then there is no meaning of the pharmaceutical qualities. The second, WHO said that the good manufacturing practice for the pharmaceutical products. The GMP is a part of the quality system which ensures that the products are consistently proper, controlled manner. The quality standard should be appropriate for the intended use. The authorization, and this authorization gives the product a specificity. Let us say brand name. So GMP is a concern with the production and the quality control, QC. The third, very, very important, that when we are manufacturing and any company manufacturing any product, the sanitization and hygiene. High level of the sanitization should be practiced with every aspect of the manufacturing process. Potential source of contamination should be identified first. We have to prevent that contamination with either the machines or molecules or anything, either human beings who are handling it. So we have to be proper precaution as far as the sanitization is concerned. As I think we know that when we are visiting the pharmaceutical industry, we have to wear the OT dress, what we are going to the operations. So it is that level of the sanitization is followed by the manufacturing companies to prevent the contamination by the human beings especially. The fourth, WHO said that the qualification and validation. So according to GMP, each pharmaceutical company should identify the qualification and the validation work which is required to the critical aspect of their particular operation they are in the control of it. So first is the qualification, and is the validation should establish as far as the documentation part is concerned. Documentation as far as the premises that where we are where they are manufacturing, supporting utilities, equipments, and various procedures as far as you know that the product comes out of. But in the base level, it starts with the raw material. So raw material to the final product, it is more than 10 process. So in the and also the validation in according to the requirement of the GMP. That is very, very important. The fifth is the complaints. As more than 10 process, more than 10 machines are working together, many queries, many complaints will be arised, which is because they are machine and the human being, they are interconnected. So all the complaints or any other information, any other updation in the manufacturing machines should be there. So potentially defective product should be carefully be reviewed as far as some errors during the manufacturing process. So there is some SOPs, very, very important. All the important parts, the SOP should be there. The written procedures should be there, that which complaints should be arised and how we can solve it. There should be a written procedures. So which action to be taken, who are responsible for their complaints. Who will solve it? And if they cannot solve, who is responsible finally? They are all in the documents. So in case of any complaint discerning, so possible product defect and the possible product person we can identify. So the person's responsibility for QC, quality control, should normally be involved by such investigator. The sixth, the WHO said that the product recall, there should be a system of recall from the market. Recall from the market means after the manufacture is done, final product is out of the sale. Recall means which product is not properly manufactured. That should be a procedure, a prompt action should be there, that if some say that is a defective product, that is, say the gram is less, whatever. So the suspected to be defective, it identified to be defective. That product should be recalled. There is also a procedure should be there. So the consumer will not suffer. An instruction should be included in the written procedure for the storage. As we know that every drug has a, on the back side it is there, store in a dry and cool place. In the vaccine it may be different. So all the instructions should be there in a secure segregated area. So that shelf life should be proper. The seventh is the contract production, analysis and the activities. So contract production means to avoid the misunderstanding. So it is the whole teamwork. So you cannot deny that misunderstanding should not be there. So any work or any analysis or any unsatisfactory quality, you have to properly clarity about the work with all the evidence. There must be a written contract given either the contract giver also and the acceptor also. If the outsourcing is there, especially. So who is responsible? That should be clear. The eighth is inspection, very, very important. Self-inspection, self-audits should be there. The purpose of the self-inspection is to evaluate the manufacturer's compliance with the GMP or not. So all aspects of the production should be in a proper way. The self-inspection should be there to design, to detect any lacunes. Implementation of GMP is there or not. And if it is lacunes, you have to correct it promptly. So self-inspection should be performed routinely. It may be in addition, it may be inspection, regular inspection by the healthcare authorities. So any self-inspection, any audits, there should be a perfect one. It is said that what is the frequency of self-inspection? It is at least once a year. So any self-inspection should be in a proper regulatory reviews. It should be in proper interval. So it should be in proper maintenance. The ninth is the personal. As the previous speakers, they said that who is responsible. The establishment and the maintenance of the satisfactory system of the quality assurance to correct the manufacture and the control of the product, that should be the proper personnel. The qualified personnel should be there. The qualified person should be identified. Individual responsibility should be identified. Clearly, you have to train them. You have to understand them. And then they will do the proper work. It should be recorded properly. As the data is very, very essential. Documentation is very, very essential in all the parts of GMP, or SOPs also. So documentation is must. 10th is training. As we know that the machines, if it is old, we have to renew it. If it is the manufacturing process old, we have to renew it. So we have to train each and every part of the manufacturing process. We have to train the other person. So it is a continuous process. So it is a continuous manufacturing process also, apart from the machines and the humans. So it is approved. Training program should be available. Training records should be kept properly. That will be very, very important. 11th is the personal hygiene. So who are the persons going to? Who are the prior to and during the employment? as appropriate, should undergo the health examination. Any person shown at any time to give apparent illness should be properly examined. It should not be allowed till the, let us say, the flu, viral fever. And if that person is the main person, that should be prohibited. So handling of the materials, handling of the packaging, handling of the processed materials, handling of the labels, who are doing this? So that personal hygiene should be maintained. Smoking, all the drinking or the eating should not be allowed. So that is the planting should not be allowed in the proper area of the storage area, the laboratory area, the manufacturing area. That should be completely prohibited. Personal hygiene procedure should be wearing the gloves. As I said you, that where we go to the manufacturing industry, we have to wear all the parts what we wear in the OT, operation room. So that is the how the sanitization and the personal hygiene should be maintained during the whole procedure. The 12th is the premises. The premises should be properly located, properly constructed. There is a whole guideline how to construct the pharmaceutical industry, what is the exact requirement. You have to follow it. During the inspection, they see this. So that's why the minimum error in the whole process of the manufacture. Let us say the dust, the dirt, electrical supply, the lighting area, the humidity, the ventilation, everything should be in the proper way. The entry of the insect or any other animals should then. Rodents, pest control, everything we have to see during the GMP. The 13th is the equipments. All the equipments should be proper and updated without any contamination to minimize the risk. The 14th is the material, the raw material, as I discussed, that the drug or any vaccine that start producing from raw material. It may be anything. It may be materials, packaging materials, it may be solvents, it may be reagents, anything. And after that, all the proper material should be then the manufacturing process starts. So all the material and products should be stored in a proper containers, in the proper conditions, so that established the manufacturer are in the proper control. The batch segregation, very, very important. Usually nowadays, the drugs which is manufactured in the market, they are in batches. And the stock rotation should be there. Which stock to be first expire, you have to say this. So first rule out, which is called as in the industry. Starting material should be purchased only from approved suppliers. So what we are giving the raw material should be from the proper suppliers. Particular attention should be paid from the printing materials. So packaging and printing materials should be in the proper control. Final product should be examined. So that is the finished product. So last what see in the market is a finished product. So that should be a proper SOP for the finished product, that how you can make the finished product, quarantine it, store it, and how you give to the pharmaceutical from companies to the pharmaceutical shops. 15th is the documentation. Very, very important. Documentation, as we discuss later on, that which are the documentations are required. 16th is the good practices in the production. Production operations must follow clearly defined procedure in accordance to the good manufacturing procedures. Marketing authorizations, very, very important. If it is a new drug, who will market it? What we should say, which are benefits, which are lacunae. The objective is to obtaining the products of the requisite quality. All handling of the materials and the product, such as the receipt, cleaning, quarantine, sampling, storage, labeling, even dispensing, packaging. So it is not a GMP is not a single that one word production, but it involves the many underlying procedures. And all is the written procedures. Wherever necessary, we have to record. 17th, WHO said that good practices in quality control. So quality control is a part of GMP. So all the parts, the quality control should be maintained. Necessary documents, relevant test should be there, that that product should be properly manufactured or not. The quality control is not confirmed by the laboratory operations, but it may involve in many decisions. If some says that in mind that this product or this batch is not properly manufactured, now what we do, that should SOP should be there. So everything should be in a written part in SOP. The independence of the quality control from production should be is the fundamental. So all the 17 principles you can see that WHO said for the GMP, that is good manufacturing process. Now we will see the second part, very, very important, that is called as a clinical trial data and the data management. The clinical trial, many the previous speaker says that is very, very important to analyze. For analysis, we need data. So before the trial, we need some documents. The data, as you can see, that first is the signed protocol for the research purpose. Second is the patient information sheet, patient consent form, advertisement for the patient recruitment, and very, very important, as the madam said, that the ethical approval. So before that, now during the trial, there are many, many data. Remember that clinical trial, or that is very, very a controlled manner. So the data is the must. What we see in the, what we search a new drug, let us say, if I search new drug for Alzheimer's, what we believe? I believe only the data available in the published part. So on the data, what you publish, what data you receive, you have to be very, very perfect in that. So during trial, any protocol amendments, you have to document the data, CRF, ethical documents, any updates, the signed patient consent form, very, very important. Any SAE, that is serious adverse events, you have to document it, you have to analyze it. Also, you have to give to ethics committee. After completion of the trial, you have to do the final monitoring reports, that is the closeout report. Decoding in a documentation, how to decode the patient, how to decode either placebo or whatever. Complete subject ID code list, the audit certificate, the final reports to the ethics committee. So remember that clinical trial data is a very, very wide area. The trial file and archives, storage, very, very important. The investigator should keep the setups files for the appropriate documentation. All the documents should be stored either in the hard copy or the computerized electronic. So confidential environment should be there. It should not be disclosed. Even X-ray should be there. Medical notes, which are the drugs, any samples, CRF, all should be there in the proper file. So we have to manage it. So clinical trial data and management is an interlinked process. Very, very important part is the management. We have to manage all the data together. So clinical data management, it involves in all aspects of the processing, the clinical data, working with the computer application, database system, support collection, and the management. So it is not a single procedure. You can see data collection to data extraction, data processing, analysis, even data transmission, data storage, and data privacy and data quality assurance. So the objective of the data monitoring, either it is in the hard copy paper or electronic, integration of the data, very, very important, and validation of the data, very, very important. So what is the objective? The objective is you have to sufficiently clean to support the statistical analysis. What you gather, if it is without error, the analysis should be perfect. So any data gathered without any error, that is very, very important. Then the analysis should be perfect. So it is the vital vehicle of the clinical trial. The integrity and the quality of the data being transferred from the trial subjects to the databases. So what the collected data should be there, it should be there in the proper electronic, same. So no error in between. The trial database should be complete and accurate and a true representation of the original data. The trial data should be sufficiently operational. So what is very, very important is the main two parts of it is either the investigator and the sponsor, as you know. So very, very interlinked between two. The CDM, clinical data monitoring, that involves for the mere data entry or the diverse process. It also provides data and database in a usable format, easy form, and ready to log. Nobody can change it. So data management is a role in clinical research, that the data management function should provide all the data collections, all the data validation. The data management is an essential to overall all the clinical research function, as it is a key deliverable for the community. Assuring the overall accuracy and integrity of the clinical trial data for the clinical data management function. At the study level, the data management ends when the database is logged. Okay. And at the computer level, data management ends when the submission package is assembled and completed. So very, very important, both the process for the proper clinical research data. So four very, very important words during the clinical trial data. First is the consistency of the data, accuracy, validity, and the archival. That is very, very important. It's starting from the CRF to the analysis. So clinical trial data, as you all know, that trial design, so data collection, data entry, data validation, data cleanup, if some errors, then data analysis, data reporting, and the presentation. What we see on Google, what you see in the search, if I say new drug for LZ, some new drug approved, what you see is the data presentation. But before data presentation, there is a many procedures or many steps you can see. And then you can give the proper data to the presenters, to the presenters. So key members in it are the clinical data manager, database administrator, database programmer, coordinator, and clinical data associate. We have to identify it. In this flowchart, you can see in the left side, first part is planning. So data should be in a proper, how you can do, which data I want to collect. So that should be in a proper planned way. Second is design or development. How you do this? Third is data management. Data management involves the whole procedure, starting from the subject visit to CRF, to the any implementation, drug or anything. It involves a wide range. After collecting, the analysis part, medical writing, and the filing part. That is the last part. Everything, the data should be found. So responsibilities of it should be perfectly designed. So study setup, the CRF design should be properly set up. The eCRF nowadays. Database build and testing. Edit checks, preparation and testing. The second is study conduct. Data entry, who will do this? Should be properly designed. Discrepancy management, who will do this? Who will do the data coding using various MEDRA or WHOD dictionaries? That should be proper. Data review, SAE, data transfer, who will do? Who will analyze? So that is very, very important. Here, two roles is made. One is PI and the sponsor. Study closeout, SAE reconciliation, quality control, database log, who will do this? Electronic archival and the database transfer should proper. So here you can see that study startup process review. It starts with the protocol. So CRF design, To it, validation, it ends with the activated database, ready to accept. If you perfect in the clinical data, it is highly acceptable. If it is positive, if it is negative, you have to be transparent. It starts with the very basic ethical principle, as the madam said, that is CRF. Nowadays, eCRF, Oracle Clinical Trial, very, very important. Softwares are available that should be proud. Nobody can change it. Here you can see some glimpse of it, that the initials part, which data should be there. So this is very, very basic CRF, one of the core area of the clinical trial. There are many, many case record forms. So you have to make both case record form and informed consent. Database design. Data from a clinical trial will be collected and stored in a proper computerized system. Yeah, either in the Excel spreadsheet or the Oracle. Nowadays, there are many applications which are very, very reliable. It is a password protected. Nobody can change even a single second. So the recording is a perfect record. So there are many applications available for the clinical trial data if it is not malfunctionized. Now there is also a subject ID like this, name of the patient and all on the initials. So MS Excel to Oracle, Clinical, Medidata Rail, there are many, many. So you have to follow it. You can also see some screenshots of it. Database setup and testing. Database setup and testing should always be there. Only when a database has been reviewed and fully tested, it will be set in production. So once you are confirmed that my data is perfect, then you go out with analysis. If you want any change, there is also SOP of it. There are some lacunae because human beings are errorless. The error should be properly identified, properly solved. Then and then the clinical trial data should be. So study conduct process review. So it starts with the data entry, data loading, CRF, frequency management, query generation, resolution, and the manual checks, that is quality control. So everything should be in the controlled way. And if there is any discrepancy, let us say there is some change, that there is as one, I am a ethics committee, the basic chairperson. So in one ethics committee, I saw that there is a problem where the hard copy of the informed consent form and the Excel sheet of informed consent form, both are different. So the discrepancy will be there. You have to manage it. You have to identify it. Coding should be there. The adverse effects, MEDRA, Medical Dictionary for Regulatory Ethics, should be there. Medications, WHO Organ and Drug Dictionary. You have to follow the proper guideline. Very, very important during the whole process of the clinical trial. So clinical trial data should be in accordance with the guideline. SAE, very, very important. Serious adverse event. You have to, if there is SAE, then you have to manage it promptly. You have to submit that, you have to give the information to ethics committee that the SAE occurs. So clinical data management system and master drug safety database, that should be followed. Nowadays, the Sugam portal also the ethics committee have to upload it, that which SAE is done in which clinical trial. You have to document it. So this is very, very perfect. So study closeout process. The last part is that safety data reconciliation, it involves any discrepancy management. So when we collect whole data, remember, if it is in hard copy, the whole data of the clinical trial, that should be many discrepancy, many lacunae. So the query should be generated and it should be resolved. Once you are confirmed that it should be resolved in with proper guidelines with my database, then and then you go with the highest manual check, the quality control. Either it is informed consent, it start with CRF to the whole procedure, all the follow-ups. At the last, you have to lock and freeze that database. So last is the database lock. Nobody can change it. The last, and nobody can disclose. That is the very, very. The database lock should be the study done by the ensuring no manipulation and no copy paste. Database lock for any study is done once all the data management activities are completed. Very, very important part. Now the analysis part is like. After analysis also it should be locked. So it is a multi-functional, multi-level database lock system. If SAE there, you have to make a separate database for SAE. So very, very essential part. And for that, we have to go with quality control. So it starts with record through the validation, analysis, audits. If your quality control is perfect, all the clinical trial data must share. So there is two parts, quality assurance and quality control. You have to prevent it, you have to treat it, both. So there is a minor difference between two. I think you know this. Quality control means the product quality as a given moment. And quality assurance means you assure that I have done in a proper project process. So quality control is a reactive, but quality assurance is preventive. So there is mild difference. Both are interconnected, remember. So starting point is when there is a presenter gathering stage. And quality assurance means the planning stage. So both are very, very important. At the last, I will just give a glimpse of the guideline which I received the document in August 2024. That with some changes in GCP guideline. So they have done some changes in the e-consenting implementation procedure, enhanced QA/QC procedure. In the recent updated, they have also given some guideline for the phytopharmaceutical drugs, molecules. So a new guideline has been there for the trials involving the data involving the phytopharmaceuticals, means plant-derived drugs, as you know. The next is the metadata. The metadata, what is it? Just I give you a brief. After that, training of the computerized system. Nowadays, the electronic data is very, very at the highest level, rather than hard copies of the whole clinical trial. So they have emphasis on the training of the computerized system part. The next, they have also emphasized on the record keeping of data, source of data. In the new GCP, they have more give emphasis on the record keeping. As we discussed in the slide, that the record keeping, how it is important. Audit trails means strengthening the audit process. As we discussed, that audit should be very, very important. Self-audit and the other for the regulatory audits. The next is the real world data. What is it? We will also discuss it. That what is real world data? It is a new word coming in 2-3 years. Documentation SOP, they have strengthened it. The new GCP guidelines strengthen the SOPs, should be documented and updated. Either it is in the computerized, also in the hard copies. So I want to just describe two new words, what I got to discuss, that is metadata. So new GCP guideline in just a month before, they say that metadata means meta information. Now what is meta information? It is the data that provides information about other data. Let us say email, Gmail, let us say my email is there. So it includes the sender's name, recipient date, what is the date, what is the time, what is the subject, what is the image, what is the website. So metadata means the data from where I can retrieve the data, say WH. So I can retrieve the data from it. So it is a metadata. So they have emphasis on the perfect metadata. I receive some information from proper websites, from proper images. So metadata is very, very important for organizing the proper data. Let us say WHO website, CDSCO website, clinicaltrial.gov. So that is metadata. And the next is the real world data. What is real world data? So this is very, very very old term in the USA, UK, that what is real world data. That real world data is a data relating to the patient health status from a variety of sources. Means one patient to be given a unique code, electronic health record. So only the code should be there, and all the data, the health issues, the previous history, the drugs, whatever, any surgery. So data from the product, any medical claims, they have claims. So in a one single click, the resource of all the information of the patient. So digital health technology, they have GCP guideline new. They have emphasized on the real world data. So it comes with the real world evidence. If you have real world data, then there is evidence, that clinical evidence about the usage and potential benefits or risk of the medical care. So very, very important here. Thank you so much. Most welcome. If the sir allow, I will also share the new GCP guideline with you. There is
Sure,
a
sir.
file. Okay. Thank you so much.
Thank you so much, sir, for giving us a detailed, in-depth view of the essentials regarding the guidelines for product safety, quality, efficacy for pharmaceutical industry, as well as the every bit of all the industries which are used for clinical trials, and also emphasizing the GMP in every stage of production, from sourcing raw materials to final pack, everything accurate, transparent clinical data for according to the regulatory approvals. And also you have shared recent guidelines changes that has happened. So I am thankful to you for sharing this much of
Thank you.
insightful knowledge.
Thank you, Janardhan sir, for giving me opportunity, and all the participants for patience listening. Thank you.
Okay, now I'm moving forward with our next speaker, Dr. Shaista Sayyed. I'm making you co-host, ma'am. Can you hear me, ma'am?
Very good morning. Yes. Very good morning, all of you. Especially respected Dr. Bhatt sir, who always gives the opportunity to me every year. And it is always a pleasure to come back every year. And special thanks to Chaitali also, Dr. Chaitali now, we are very proud of you. And good
Thank
noon
you,
to
ma'am.
all the respected faculty, students, and my dear friends. And shall I start sharing the screen, Dr. Chaitali?
Ma'am, just a minute, I'll give a brief introduction. Dr.
Okay.
Sayyed holds an MBBS degree with the MD in Physiology and PhD. She is has completed FAMER Fellow from CMCL Punjab and ACME Fellow. Currently, she serves as an associate professor in Department of Physiology at NHL Medical College, Ahmedabad. She has extensive academic and research experience, includes numerous publications and co-authored books related to the medical education. She is also a resource faculty member for medical education unit programs which are held at NHL Medical College, and has been an esteemed speaker at various CMEs and conferences. And she's also joined us since years. She is going to address on a topic, confidentiality in clinical trials, which is a fundamental aspect of ensuring trust and integrity in research. So we are honored to have you today, ma'am.
So I'll start sharing.
Sure, ma'am.
Is it visible?
Yes,
Something?
ma'am. Yeah, it is visible.
My PPT are visible?
Yes, ma'am.
Okay. So as already talked by Dr. Chaitali, the topic of my discussion is confidentiality. A picture speaks 1,000 words. As you can see, there is a lock and key also. So let us try to understand what does this mean as far as confidentiality is concerned. Now, since morning, we have been discussing various principles of good clinical practices. And now we have landed up almost in the end, the 12th principle, which is the principle of confidentiality. And it encompasses various aspects which other esteemed speakers have already talked about, slightly superficially. So I'll be taking slightly more in deep. Now, these are a few subtopics which will be included in my talk, and nothing to worry, I will not go too much in detail. These are beginning with the meaning of privacy and confidentiality, then what is the importance of confidentiality in research, ethical principles and guidelines, legal and regulatory frameworks, challenges, benefits and outcomes, best practices, some case studies and examples, and how to foster a culture of confidentiality in research. So these will be my few subtopics of today's discussion. Now, first of all, let us try to understand the difference between privacy and confidentiality. Though both of them are talked as synonyms, there's a slight difference between these two. Privacy, as the name suggests, is a very private thing. It embraces the concept that each individual should have the right to control personal and sensitive information about him or her. It is slightly more limited to the personal thing only. In contrast to this, confidentiality is an important and crucial key ethical principle in research that involves human participants. It is slightly more broader than privacy. It refers to the agreement between the researcher and the participant about how the participant's personal information, identity, and responses will be handled, protected, and shared. So, confidentiality not only includes the personal things about the participant, it includes other information also, as you will see later on. So basically, the investigators obtained private information from the patients and subjects, and it is the duty of the investigators to protect the information itself and any records that contain such information from deliberate or accidental disclosure. And another duty of the investigator is to develop and follow procedures or best practices for release of information only to authorized parties who have a legitimate need for it, including notification of the patient or subject prior to any disclosure. Now, what is the importance of confidentiality? One very important is respect the privacy and dignity of the participants, because participants are the key, is the key for any research module. Another importance is protecting the participants from potential harm or discrimination, especially if the participants are from vulnerable population, to enhance the trust and rapport between the researcher and the participants for the overall quality of the research, increase the validity and reliability of the research data, and last but not the least, to maintain the scientific or academic integrity of the research. Confidentiality is very, very important. Now, these are a few issues which I'll be going to address in this talk of confidentiality. First is anonymity, informed consent, data security, disclosure principles, and the last one. Now, anonymity has already been discussed, I think, slightly. Now, what is the meaning of anonymity is as also talked about during the talk of informed consent. You make the name, addresses, phone numbers, or any thing which tries to identify the participants. You make all these things anonymous so that they are not identified by these names, phone numbers, etc. And especially for most of the cross-sectional studies. But if the studies are prospective, then you can change the anonymity to pseudo-anonymity or give them codes or encrypt the data so that the basic anonymity is preserved, but still you can follow up the participants later on. Second very important issue in confidentiality is informed consent, which has been in detail talked about by Dr. Somville, and it will come later on also in my talk also. Informed consent basically means informing the participants everything about the study, A to Z, beginning from the type of study, who will be involved, how will be the data collected, how it will be used, as well as what will happen if the data is disclosed or leaked. And as we already know, informed consent should be in the signed informed consent and in vernacular language of the participants. Third important component is data security. So whatever data is collected by the investigator, data means in the form of names, phone numbers, then if it is a clinical data, then the signs and symptoms, the the results of the focus group discussions, etc., that should be kept securely. If it is on cloud or if it is on internet, then special passwords or encryption should be there. Firewalls can be used. And if it is physical data, then all the papers and physical aspects should be kept in lock and key. So that means data security. Next is disclosure policies. So there are certain conditions in which the data is needed to be disclosed. And for example, if the participants themselves, they give consent that you can disclose the data, or if it is required by the government, or if there is any other legal compulsion where data is required. In those cases, data can be disclosed, but all this has to be informed to the participants beforehand in the form of informed consent, in which cases the data has to be disclosed. And last is the communication of the results. So at the end of the project or at the end of the research, when the results are communicated to the mass in the form of publications or whatever, poster, paper, whatever, again the confidentiality of the participants or anonymity of the participants, geographical areas, their general, the population, etc., has to be maintained. Just a minute.
No problem, ma'am.
I think my laptop is hanged.
Ma'am, you can anywhere click on the, yeah, we can see the next slide.
Yes. Now, how can this confidentiality be applied or application of confidentiality? It is generally through appropriate procedures to protect the privacy of the subjects and by document and data control to protect the confidentiality of subjects' information, as already I mentioned in the previous slide. Again, through the informed consent process, certain explanations should be provided to the participants regarding the confidentiality of the subject's record and about the access of the data. Now, who is responsible for confidentiality? A very important question. It is not only the duty of the investigator. Now, according to Declaration of Helsinki, it is the duty of the physician in medical research to protect the life, health, privacy, and dignity of the human subject. This sentence forms the core of confidentiality. All the parties are involved in maintaining the confidentiality, including the sponsorer, the monitor, the monitoring agencies like institutional ethical committees, institutional review boards, investigators, staff, and also the regulators. All these should protect the subject's private information and ensure that all the data are secured against any unauthorized access. And in addition to the confidentiality data, it also includes subjects' case reports, source data, source documents, and safety reports. Now, how to maintain the confidentiality? Now, there are various ways. Omitting information that might lead to identification of individual subjects, limiting access to information, anonymizing data, or other means. This is one way of maintaining the confidentiality. Other mechanisms are coding or encryption of the data. This is very frequently done, restricting access to the study records and subjects' medical fields. Example, using passwords on electronic files, files secured in lockers, cabinets, etc. And also using different types of even firewalls can be used if it is a e-records. Now the question is, why should potential risks related to release of private information be disclosed to the study subjects? Now these has to be informed to the participants beforehand. And why confidentiality has to be maintained is because it may involve collection and storage of private information. The information that, if disclosed to third party, can cause harm or distress to the participants, especially as I previously mentioned, if the participants belong to a very vulnerable class. Plus, why confidentiality has to be maintained is to prevent adverse social consequences of breaches of confidentiality. However, some jurisdictions require the reporting to appropriate agencies of For instance, certain communicable diseases or evidence of child abuse or neglect. If they are there, then there are certain rules and regulations during which or according to which you can disclose the data. Another is drug regulatory authorities. They have right to inspect clinical trial records, and as sponsors, clinical compliance audit staff may require and obtain access to confidential data. Also, these and similar limits to the ability to maintain confidentiality should be anticipated and disclosed to prospective subjects, according to the guidelines given by CIOMS. Now, these exceptions of disclosure should be told to the participants at the time of taking their informed consent. Now, how should subjects be informed of the measures that will be used to protect their information? How it is done? One is very important, as already many times I have told, the informed consent document, which should describe who will have access to the personal data of the research participants, including medical records and biological samples, the measures taken to ensure confidentiality and security of research participants' personal information, and the potential risks involved if there is a breach of confidential data. So the bottom line is informed consent only does not mean taking consent of the subject. It also means a very detailed account of the confidentiality clause and various aspects of confidentiality clause. Also, the monitor, auditor, IRB, IEC, and regulatory authority will be granted direct access to the subject's original medical records for verification of the clinical trial without violating the confidentiality of the subject to the extent permitted by the applicable rules and regulations. These are a few ethical principles and guidelines for protecting confidentiality. Already I have told about it: anonymization, data protection, secure data storage, and restricted access. The last one, restricted access, because the previous three already I have talked about. Restricted access means restriction of who should be allowed to take the data. So that also previously I have told you. If it is physical, then special lock and keys have to be used, and whoever or who will be given access should be clearly mentioned in the documents. Now, implementation of confidentiality. The IECs and IRBs, they review and approve the informed consent procedures and documents related to confidentiality to ensure, among other things, that there is adequate explanations regarding the risks related to the release of subjects' private information, how the confidentiality of the subject's record will be maintained, the persons who may have access to the subject's record, example, the monitor, auditor, IEC, IRB, and other regulatory authorities. So it is the duty of the Institutional Review Board and IEC to see that whenever the project is presented, the project protocol, this clause confidentiality has to be dealt with in this particular way. Another is the role of investigators. Their role is to implement procedures to protect and restrict access to study record and private information. Already I have talked about this. Follow national and local laws and regulations related to privacy and confidentiality. Each and every country, and even in a particular country, different local laws are also there. So investigators should be aware of it and also work according to it. Ensure that the study staff are aware of and receive appropriate training related to their responsibility and procedures. Because in addition to the investigators, there will be co-investigators also, and other ancillary staff also, which will be involved in the research study. So which have got access to the data. So special training should be there in the form of development or faculty development programs. Ensure that the study staff follow the procedures established for this purpose. Ensure that the consent form and process inform study subjects about the procedures to be used and protect their private information. Again, the role of sponsors is to ensure that sites allow regulators, IEC, IRB, and monitors direct access should be given to them according again to the rules and regulations. Again, I would like to stress here that the regulators, IEC, IRBs, and other regulatory bodies, they also don't have access to everything. They also have got certain restricted access according to the local rules and regulations. And also this also should be informed to the subjects. So this is how patient confidentiality and privacy should be maintained, the whole key or the flow chart. First is obtain informed consent, then use secure communication channels. Third is train staff on confidentiality and privacy laws. This is lacking in our country actually. And so that and because of that, the staff which are using or facing confidentiality issues, they are certain uninformed. Then maintain physical security and use de-identified data for research purposes. Same thing according to previous slide. Now these are a few legal and regulatory frameworks for ensuring confidentiality in research. First is ethical considerations and informed consent. Already we have talked about it. Second is the role of institutional review board. And again, I would like to stress here, whenever a project is presented in the IRB, special stress has to be put on the confidentiality in the informed consent section. And there are certain legislations also for protection of the data according to the local as well as the national issues. These are a few methods and techniques for collecting, storing, and analyzing confidential data. So confidential data only does not mean the names and roll numbers and the phone numbers, etc. It also means how the data is collected, stored, and analyzed during the research process. So first step is securing the data. Second is access control, who has the access, who has got limited access, and who has got complete access. Third is data anonymizing and pseudo-anonymizing. Now the pseudo-anonymizing means you anonymize the data. Don't give any clue regarding the individual or the participant in terms of the names, phone numbers, etc. Pseudo anonymizing means giving them false names or false numbers or false codes so that directly they cannot get access to the individual information. And fourth is data minimizing and retention. So whatever data you collect, out of that, go on reducing the data till you have got the data which is only that which is required. So that data should be made confidential first, because if you try to make all the data confidential, it is very difficult. So go on reducing the data and retain the data according to the importance of the confidentiality. And last is data sharing and dissemination. So whenever data is shared and disseminated after the research, care is to be taken regarding the confidentiality also. Now, what are the benefits and outcomes of respecting the 12th principle, confidentiality in research? First is protection of privacy. Second is enhanced data quality. Third is ethical responsibility. It is not only our ethical responsibility, but also national responsibility that the vulnerable population is protected. And last is long-term patient engagement. So if you keep the data confidential, then patient engagement or patient participation also becomes more quality and long-term. These are a few best practices and recommendations for enhancing confidentiality in research. First is obtaining informed consent from the participants according to the rules and regulations, using appropriate methods of data collection and storage. These also should be well documented in the research protocol, following ethical guidelines and policies, sharing data responsibly and transparently, and responding to breaches or violations of confidentiality. This can happen during the process of research. If there is any breach or violation of confidentiality, it is the duty of the investigator as well as all the other staff involved to inform the institutional review board as well as the participants regarding the breach and violation, and whatever follows according to the rules and regulations, whatever punishment or whatever is given should be taken care of. Now, these are a few case studies and examples of confidentiality issues in different research domains. So if your research domain is health and medical research, for example, if you're talking about any disease in a particular patients, then right from the signs and symptoms to the treatment portion to the preventive measures, all this data will be included in the confidentiality. And especially if the data includes data of diseases related to HIV or sex workers, this become very much confidential data, and anonymity has to be taken care of. Second is if the data is related to any research related to social or behavioral sciences. For example, data related to any vulnerable population, certain sects of the society which don't want to disclose their identity, then that becomes very important. Confidentiality becomes very important here. And as we know, the educational research also, which involves the students and the faculty, especially because the students are highly vulnerable as they are under the research or the investigators committee. So their confidentiality has to be maintained, especially if you're talking about the perceptions of the vulnerable faculty as well as the students. Confidentiality becomes very, very important here. How to foster a culture of confidentiality in research? There are various guidelines for it. First is clear communication and informed consent. Clear and transparent communication. Second is robust data protection and measures. Third is confidentiality, training and awareness. This is very, very important for the investigators as well as the co-investigators. Fourth is ethical review boards and oversight. And fifth is collaboration and sharing best practices. We will not go into too much in detail, but this is how stepwise you can develop quality confidentiality in research. Now, confidentiality, it appears very easy, but it is not very easy. Also, there was a study conducted regarding confidentiality, and according to that study, there are various challenges also and examples also. First challenge is the management issues, and the sub-themes emerged in that was insufficient laws and regulation and insufficient policies. Though we have got broader national policies, localized institutional policies are lacking, especially lacking in the way that they are there, but they are insufficient, not very clear and transparent. So that can act as a, roadblock for maintenance of confidentiality. For example, lack of national confidentiality and guidelines, lack of transparent policies and implementation, etc. Second is organizational ethics, insufficient organizational regulations, insufficient infrastructure, for example, human resources and technology. We have talked about e-files, we have talked about the physical storages, etc. And examples are lack of transparent regulations for management of data, publication, data accessibility, non-awareness, data safety in cyberspace, etc. This is another challenge. And last is physician-patient relationship. And sub-themes out of this study were service providers and healthcare recipients. And the examples are gap of knowledge, insufficient attention, and even patient awareness. So regular education of service providers and healthcare recipients which are involved in the study is also very much essential if confidentiality has to be maintained. So the summary of my talk is the right of research subjects to safeguard their integrity must always be respected. Every precaution should be taken to respect the privacy of the subject, confidentiality of patient information, and to minimize the impact of the study on subjects' physical and mental integrity and on the personality of the subject. This is according to the declaration of Helsinki, which already have discussed. And second is according to CIOM's International Ethical Guideline, the investigator must establish secure safeguards of the confidentiality of all the subjects and the research data. Subjects should be told the limits, legal or other, to the investigator's ability to safeguard confidentiality and the possible consequences of breaching of confidentiality. So these two statements are also very much important. And these are a few references which I've used, especially the diagrams which I have taken from scientific study website from Faster Capital, and most of the material I have taken from Handbook of Good Clinical Practices by WHO, and one more resource also I had used. Thank you so much for the patient listening.
Thank you so much, ma'am, for emphasizing on the critical things of safeguarding the participants' data to maintain the robust and ethical standards. And you also mentioned about the challenges which in India and in any clinical trial we face, that is trained staff, where they show some lacking of privacy, confidentiality of them, somewhere there is a leak of it. And you also mentioned about the guidelines which we need to follow according to the Helsinki. So thank you so much, ma'am, for sharing.
Thank you. Thank you so much.
Now moving ahead with our last speaker, Dr. Pankaj, sir. Am I audible, sir?
Yes, yes, audible.
Okay. Just a minute. I'm making you a co-host. Okay. So, as we have reached to the last topic of the today's webinar conference, Dr. Pankaj Garg is going to speak on measures and practices which are essential for maintaining high standards in clinical research. The topic is quality assurance in clinical trials. So, Dr. Garg is an assistant professor in medicine at NHL Medical College, Ahmedabad, and he has extensive knowledge on his crucial topic. And he has also contributed in the research, and he has a lot of publications on his name. So, I welcome you, sir.
Yes. I'm just sharing. Just wait for a minute.
Okay, no problem.
काशवी एक मिनट हाँ बेटा
Do you have any problem, sir, for sharing the screen?
I'm just sharing it. Yeah, there is a one problem. मेरी फोन वो भी अनम्यूट भी करना है ना वहां से वीडियो A very good afternoon. Am I audible?
Yes, sir, you're audible. Sir, can you do the slideshow?
Okay, slideshow. Yeah, this is a slideshow only.
We only can see the basic PowerPoint window.
Slideshow. Start video. Video चालू.
विंडोज में जाने का
Is it?
Yes,
Is
sir.
it okay? Okay.
Yes.
Okay. First of all, a very good afternoon, as everybody will be very tired as it is a very lunch time. And my topic has already been done by Dr. Pooja and Dr. Harsh sir. And first of all, thank you very much to Janardhan sir and Chitali Ben for giving an opportunity to talk on this on quality assurance. Though it is a part of a quality system and has been done earlier, and we will delete some slides, and some slides has already been done by the other speakers. Okay, I just start. काश सविता नहीं जा रहे आगे नहीं हो रहे यार कोई बात नहीं Just wait a minute. I think there's some problem.
Just thoda, thoda, thoda.
Is it okay now? Am I audible?
Yes, sir. Yes, sir.
Okay. So what is the quality? As already has been done for the clinical trial, it is a measure of an ability of a product, process, or a service to satisfy stated or implied needs. And as we all know, as a customer, for example, if we are talking at a customer level, we all need a very high quality products and they readily meet all those needs. We need to have a which must satisfy a customer, even in if we are not talking in terms of a trials. But since the topic is on a trials, it may lead to a data that we are applying to a data must be an accurate and reliable or processes, for example, compliance with the study protocol and GCP, informed consent, which once more of the speakers are saying again and again, even Dr. Shesta madam has said, adequate data handling and record keeping, that is the documentation, which is very important for in a context for a clinical trial. Just see, we know that the quality, for example, if we go for a shopping, we don't buy this. These days we are going more for an organic food. That is what a quality means. But in case of a trial, we need to have some other things, including processes, data, consent, handling, and record keeping. So what can be a common way to assure data and process quality? It has already been discussed. It is through standard operating procedures, that is SOPs. Whenever we have to do certain work, for example, even in the hospitals, if we have to shift the patients, when to shift the patients from the ICU to the ward, we maintain those SOPs that defines responsibilities, specify records to be established and maintained, and specify methods and procedures to be used in carrying out study related activities. It can be done for the trials also. And SOPs covered with the personal supervision of trials conduct by the clinical investigator and careful monitoring by the sponsor help to ensure that processes are consistently followed and activities are consistently documented. It means that the investigator has to carefully monitoring has to be done and it has to be followed and activities has to be documented. As a result, data collected using such procedures and under such supervision should ordinarily be reliable enough for decision making. Whenever we have a data, then we go for a decision making, and as the data must be followed and consistently documented. What are the quality systems? As Dr. Pooja madam has already said, which includes monitoring programs, auditing programs, and a compliant handling systems for periodically reviewing the adequacy of the clinical trials. And one important is that there has to be a change so that we can change in the system, that we can periodically review such activities and processes. How these are implemented to the good clinical practices? They are through the coordination by the sponsors, investigators, and then by the IRBs and by regulators to control their operations with respect to quality. It has major three components: control, assurance, and improvement. We will be talking of much of assurance. You all know what is the difference between a control and assurance, and has been done already by Pooja ma'am. What is an assurance? It is an ongoing systemic comprehensive evaluation of healthcare services and their impact of those services on healthcare services. It was given before, and then 1992 it has been defined as all the activities undertaken to predate and prevent the poor quality. That is basically for a trials. And even they says that quality insurance also, it helps in participant safety, their well-being, the reliability of the trial, and it also various type of identifies the risks and also the continuous improvement that we can do. For example, if there is any drug that has come into market, we have to see for its side effects first before that comes into the market. Already been done in detail. Quality control versus insurance. Important is it just measures and determines the quality level of products or services, quality control, but insurance is a complete system to assure the quality of the products or the services. Insurance is a plan and a systemic activities implemented within the quality system that provides confidence that a product will fulfill the requirements for the quality. If their high quality product readily meets all such needs. So as we've done the objectives, we make a mission, we audit it, improvement, allocate the resources. The improvement, ongoing improvement is also very important for the quality insurance. Quality improvement refers to a systemic process for taking the knowledge which we have gained through quality insurance to make changes in the system so that in order to increase an ability to fulfill quality requirements then and for the future. What are the objectives? Objectives can be at the doctor's level, at the nursing level, at a good lab level, laboratory levels, hygienic levels, to ensure the delivery of a quality client care, to demonstrate the effects of a healthcare providers to provide the best possible results. Formulate plan of care, attend patients' physical and non-physical needs, evaluate the achievements of nursing care to support the delivery of nursing care with administrative and managerial services. There are certain principles of the quality assurance. Quality insurance is first done at the level of a customer focus. What the customer needs, all those products, that is important. The leadership is important. You have to involve the people in that. It is a process approach, systemic approach, continuous approach, factual approach to decision making, mutually beneficial. The supplier relationship means, for example, if quality insurance is, if the customer is happy, the supplier should also, both should have a beneficial relationship when you are talking of a quality assurance as a whole. So these are various components. First of all, we observe it. You have to then set certain standards. You have to collect the data, monitor it, action plan, make changes, that is important, or you have to report or documentation and again observe. That has already been done. It's a repetition. You are observe, set standards, collect data, monitor, make changes, documentation. It can be at any level, the components. It can be day to day. It can be operational level. Then it can be medium term decisions, tactic levels, various training facilities or operation of quality assurance. Or it can be long term decisions for improvement, that is at the strategic level. That is a quality, we can make certain type of policies for the long term decisions. The 8 elements, I think the Shiesta madam has also said, but 8 is first is an ethics, which can be organizational or individual ethics. Then integrity, that implies honesty, morals, values, and adherence to the facts and sincerity. That if, for example, if the drug is in a trial is doing certain side effects or adverse effects to the participants, that has to be documented, that has to be told, that has an honesty, that it should not go bad when it comes to the market. Trust is very important. It allows decision making at appropriate levels in the organization. Training is important, that includes interpersonal skills, ability to function within teams, problem solving, decision making, and job management performance analysis. Teamwork, very important in processes and operations. Leadership is very important because a leader can make strategic directions. It can give directions that are understood by all and to instill values that guides subordinates. Then communication, you can give, it's a vital link. You can give an upward communication to your seniors, to downward communication to your juniors, or to your colleagues, or sideways communication. Recognition, it should be provided for both suggestions and achievements for the teams as well as for the individuals. So there are certain models of a quality assurance. Certain models has been developed, but the recent one, the older ones were systemic. We give an input, then that comes an output, throughput, and we get a feedback. Then there comes the Donna obedience model, in which vision, philosophy, values, and objectives, the standard of care, and we can change in the health status of a client. That is an outcome. Then comes the nurses level. You identify structure, standard and criteria, you apply these processes and you evaluate and the outcome of the standards and the criteria. But the last one, which many of people are doing, that we are doing a planning, then we do check, study and act cycle. That is very important for a quality assurance. Levels of evaluation, as has been told by Shasta Madam, can be at national level, trust level, local level, various type of IRBs. Then they are doing all the level of the evaluation of the quality of care. Approaches to the quality assurance programs include credentialing, license, accreditation, certification, and certain types of recognition. There can be general approaches also, and there can be a specific approaches also. What is credentialing? Credentialing, it is a formal recognition of a person as a professional with high technical competence of an agency that met minimum standards of performance. There has to be certain minimum standards of a performance that has to be there. Then licensor, it can be a contract between a profession and the state. Accreditation, it is a voluntary approach to quality control used for institutions. Certifications, educational achievements, experience, and performance on an examination determines a person's qualifications for functioning in an identified, specified area. Recognition, it is a process whereby one agency accepts the credential status and other is confirmed by the other. That whether the person who the participants we are taking for the trial are disease free, whether they will be able to do a trial, that all has to be done by the recognition that what the agency accepts. Specific approaches can be a peer review, or it can be certain type of devices for the quality assurance. So we have now a damning wheel for a continuous improvement, that is very much important. Plan is what changes can be made for improvement. Implementing the plans, talking small control steps, check and then standardize. That is a damning wheel for a continuous improvement in quality assurance. So last all, it's the quality management is sum of all the activities performed in an organization to produce and maintain a product with desired quality level against minimum cost. That includes design, control, improvement, and assurance. So the conclusion and this last slide is the quality insurance ensures ethical compliance and data integrity. The participation safety is the priority, and continuous improvement is very essential part of quality insurance. Okay, thank you very much, and a very good lunch to everybody.
Thank you so much, sir, for briefly summarizing your topic, that is quality assurance, which has already been taken by few parts has been taken by the other faculties, but still you have concisely covered everything and a bit of more of it. So pardon me. So thank you so much, everyone.
Thank you very much.
I'll take a minute of a break. So please be with me. So as we have come to the end, I am actually waiting for our Gujarat Medical Council observer, Dr. Ashish Gojak. He's joining with us in just a minute. So I would like to, am I audible? So here we have with us Dr. Ashish Gojak, sir. I again welcome you, sir. And thank you so much for dedicating your time to us to join with us today on Sunday. And we will be honored if you share a few words with us.
Thank you, Dr. Chaitaliban. So I congratulate and thankful for this opportunity also. I congratulate Narendra Modi Medical College and the association for conducting this excellent webinar on good clinical practices. I also congratulate Dr. Janardhan Bhatt sir, organizing chairman Dr. Saumil Merchant sir, and our respected Dr. Diptiben Shah madam, who has a vision to conduct this webinar for benefit of the all. I also thankful to all the and congratulate all the faculties who are giving excellent lecture. Thank you, Chaitaliban.
Thank you so much, sir, for joining with us today.
Thank you, ma'am.
So, as we conclude this morning's speaker session today, I would like to provide some important informations for those who are going to present for their oral and poster presentations. So oral poster presenters have to follow their instructions which has been given to their respective WhatsApp groups. So there are main group and the other 3 groups are formed according to your specialities. So we are taking a 45 minutes to 1 hour of break from now, 40 minutes of break from now, and then we will be continuing with the oral and poster presentation, which will commence on WebEx and Google Meet on 2 platforms parallelly. And that will be shared on your WhatsApp group. If you have any problem or queries for joining and sharing, you can coordinate with your respective volunteers, which has been already assigned to you. Now, on behalf of organizing committee, I extend our heartfelt gratitude to each one of you for joining us at webinar conference on good clinical practice. It was really an enlightening and inspiring experience to have such esteemed faculties and participants who also have joined nicely and for helping us to conduct the whole webinar conference very smoothly. This was also very much insightful knowledge, and this has made our perspectives. Definitely, we are following all the principles for good clinical practice, but this has revised our guidelines for making the impact on the good clinical practice. So I congratulate all the speakers for being with us and showing your expertise and passion, sharing your expertise and passion with us for this discussion. This contribution since long is a very big commitment with us, and it has served every time a successful event. So I also thank on behalf of the organizing committee of this conference, as well as I would extend my thank to Dr. Dipti Shah ma'am, our dean. Without their guidance, this would not have been possible to meet here on this webinar conference. So I even thank her, and I'm also showing our gratitude to her. I also appreciate I appreciate all the participants for engaging this session. They are constantly there. So that also shows their patience and dedication to this. This will definitely going to help them for their clinical practice. So as we wrap up here, we are this will help us to improve our clinical research. And so I thank all of you, speakers, participants, our esteemed Gujarat Medical Council observer, Dr. Bhojak sir. So I am very delighted to have had all of you. આજે તમારા બધાને મને host કરવાનો મોકો મળ્યો, and I'm very much great for that. So thank you so much. And કોઈ મારાથી ભૂલચૂક થઈ હોય તો to all the faculties, sorry and apology to all. So have a wonderful day to all. I have made all of you from here muted, so you can unmute themselves if they want. To all the speakers, please do not on the mute button from the participants. So I have so I have muted again everyone because everyone was so I have muted everyone. Please share your queries if they want. They can in the chat box. So thank you so much everyone. We all can leave for now. Thank you. We'll be starting with oral poster presentation. We are waiting for judge to join. So I request all of you and your colleagues to please be on the time, join the meeting link. We'll be starting. The first number is Dr. Surbi, followed by Dr. Shikha. So you both of you, please ready. Once the name has been called, please raise your hand so that I can make you a presenter. Okay, Dr. Surbi Ranga, I have shared you the co-host duty. Once I will ask you to share the screen, you can share the screen. I hope you all are clear with how to share the screen.
Yes,
There
ma'am.
will be a share option on the bottom corner. So you have to click on the share followed by share screen. And then you have to share directly the PowerPoint slides. Keep it in the slideshow. And second, if you are joining from mobile phone, please turn off your notifications so that in between a presentation, you are not disturbed by any calls or messages. I hope I'm clear with everyone. So we'll wait for a few minutes and then we will be starting with presentation. Dr. Surbi, I am making you co-host. Good afternoon, everyone. Good afternoon, Judge. Can we start?
Yes, please.
Okay, sir. Dr. Surbi,
Yes, ma'am.
please start sharing the screen.
Yes, ma'am.
Okay, we can see the screen. Open the PowerPoint.
Ma'am, it's visible.
I can see the screen of Webex Cisco, but I cannot see your PowerPoint slide.
See, especially a young patient, it has to be a secondary hypertension. Secondary hypertension, I told you, can have only two causes. One is renal, second is endocrine. Under renal,
Ma'am, it's visible.
Yes, it's visible. Start the slideshow. Yes. Just a second. I'm giving you instructions for all. 3 minutes of presentation and 2 minutes of question answer. Uh, at 2 minutes, they will be given a ring for a conclusion. Am I clear?
Okay, ma'am.
Okay. Now you can start.
So myself, Surbiranga, I'm doing PhD in Department of Physiology from Pacific Medical University. So my co-authors are Dr. Vinodni Varhade, my guide, Professor and Head Department of Physiology, Pacific Medical University, Udaipur, and Dr. Janardhan Bhatt Sir, Professor and Head Physiology, Ananya Medical College, and Dr. Charushila Jadhav, Assistant Professor, Department of Physiology, AIMS, Gorakhpur. So my topic is a comparative study of pulmonary function test results in AC users versus non-users. So introduction. The study of pulmonary function in individual using air condition compared to those who not gaining attention, and urbanization intensifies exposure to controlled indoor climates increasing, leading to concern about its impact on respiratory health. AC system regulate temperature and humidity but may affect indoor air quality and pulmonary health over the time. Impact of AC on respiratory health. Poorly maintained AC units may circulate contaminants including dust, pollens, and microorganisms like mold. These particles can exacerbate respiratory conditions such as asthma, COPD, and lung function impairments. PFT help assess lung health and influence of AC on respiratory health. Several studies highlight the respiratory risk associated with prolonged AC exposure, including reduced lung function. Researches by Al Hazami et al. In 2012 found that frequent AC users had lower FVC and FEV1 values compared to non-users. Other studies such as Tenka et al. 2010 indicate the need of long-term research on chronic effect of AC.
So aims and objective. The aim of present investigation is to raise awareness among individuals whose lifestyle has changed due to occupational exposure to the cold environment. My objective are to study the effect of using air conditions on various pulmonary function tests, to study and compare pulmonary function test results between air condition users and non-users. So material and method study site conducted in Kalol, Gandhinagar, Gujarat over 2.5 years. Total participants were 200 participants were selected. The sample size calculation was based on the previous study by Hulke et al. Considering an effect size of 0.30 and the pooled standard deviation of 0.42 units. So these are some photographs taken during the data collection. So material and method. Participants were divided into two groups, control group and case group. Control group comprised of individual aged 25 to 45 year who do not use AC, while in case group included those exposed to AC for at least 1 year, exposed to AC over 6 years daily. Inclusion criteria: healthy volunteers aged 25 to 45, non-smokers with AC exposure of 6 hours daily for at least 1 year. Exclusion criteria: participants younger than 25 or older than 45, smokers, individual with irregular AC usage, chronic respiratory issues and neuromuscular diseases.
Conclude.
So results, the results demonstrated significant reduction in the lung functions among AC users compared to non-AC users. Predicted FVC was significantly lower in AC users compared to non-AC users. Similarly, predicted FVEVAR and F force vital force expiratory flow 25 to 75% was significantly reduced in AC users, with no significant difference found in FVV1 and FVVC ratio between the two groups. The findings suggest that prolonged AC exposure can reduce lung function and affect small wave function. So these are the anthropometrical parameters of study population, age, height, weight, and AC and non-AC users and their p-value. And these are the parameters of non-AC users and AC users. As you can see, there is a significant difference in FVC between non-AC users and AC users, while there is no significant difference in force expiratory flow rate between AC and non-AC users. So this is the comparison between predicted FVC among this study group and among this study group of AC and non-AC users. This is the comparison of force expiratory volume in 1 second. This is the result of comparison between force expiratory flow rate among study groups, and this is the force expiratory flow rate between 25 to 75%. So this is my discussion. My study conclusion: significant reduction in predicted FVC among AC users compared to non-AC users. Similar findings were reported by Hulke et al. And El Hazami, who also observed reduction in FVC among.
On to last slide, conclusion.
Okay, ma'am. This is discussion.
So which conditions have you been excluded from the respiratory conditions?
Ma'am, chronic respiratory issues like asthma and were excluded from this, and smokers were excluded from this study.
Okay. What are your limitations of the study? What are the limitations of your study?
Ma'am, it is limited to only 25 to 45 age people, because if older people already have respiratory issues and young people will have good respiratory, PLT value will be good for younger patients, younger volunteers.
Okay. What are the other confounding factors that may have affected your result?
Ma'am, ma'am, difference between more than 6 hours per day will be my criteria. People who are using AC more than 1 to 2 years for 6 to 7 hours daily was my criteria in this.
Okay. Any other factor that can affect the values?
Irregular AC, if not used properly, or
Un-
proper maintenance, if not taken.
Okay. Anything else?
No, ma'am.
Okay. And what about the clinical implications of your study?
We can create awareness among people so that not to use AC for more than 6 to 7 hours. Take a break between them, or we have to create awareness, because AC already affects the it also have a headache problem, joint problems, aspect from respiratory issues. There are more health problems also.
Okay. So, because of the geographical condition, we being living in a very different climate, we cannot live without AC. The
Yes, ma'am.
consumption of the AC is increasing day by day. So
Yes,
we don't
ma'am.
even have option. So how can you create awareness among them? And how will you educate them about continuous usage? Or you said that you will give advice for break, right? So ultimately the total hour of duration from 24 hours, that will be the same. If you give 3 hours in morning and 3 hours in evening, then the total hours of usage will be 6 hours. The exposure is going to be remain 6 hours.
Yes, ma'am. Even bank employees, and they use AC more than 7 hours, and
Okay.
that is.
Anything else for a clinical implication?
But I know about this only.
So you have done in among normal individuals, right? So
Huh.
this your
Yes.
result was shown in normal population. That means us with patients who have respiratory conditions are going to have a more significant affection, right?
Yes, ma'am. Those who are using AC will have lower PFT values than people who are not using.
Correct. So even normal individuals have shown to have significant results. The person who have some chronic respiratory condition will show more significant results, right?
Yes, ma'am. They are
So that's the
excluded.
medical.
They are totally excluded from my study. Those who are already having respiratory problems. Already informed consent were taken, and all these respiratory were excluded from my study.
Okay, fine. Thank you.
Thank you, ma'am.
Okay, Dr. Surbi, now stop sharing your screen.
Okay, ma'am. Thank you.
Now our next participant is Dr. Shikha Chandan. Kindly raise your hand if you have joined. Dr. Shikha. Okay, so now we are moving ahead to our next participant. I think Dr. Shikha is not joined yet. Our next participant is Dr. Srishti Krishna. Dr. Srishti.
Dr. Nikita Jain. Kindly raise your hand, Dr. Nikita. Dr. Nikita. Kindly unmute yourself,
Yes.
Dr. Nikita. Yes.
Yes.
Okay,
Hello.
so now you can open your slideshow.
Okay. Is it visible?
Yes, it's visible.
Okay. My topic is prognostic significance of serum uric acid in ST elevation myocardial infarction. Shall I begin?
Just have your presentation on landscape mode.
Um,
Just tilt it horizontally.
just a second.
Just do landscape mode. It's showing in portrait mode. So
Mm,
you are presenting from phone, na?
landscape mode?
Yeah, yeah, yeah. This is okay, perfect. Now you can go ahead.
Okay. My topic is prognostic significance of serum uric acid in ST elevation myocardial infarction. First, I'll begin with introduction. Ischemic heart disease, particularly acute myocardial infarction, is the leading cause of death across the world, accounting for 12.7% of global mortality. Serum uric acid levels have been correlated with coronary artery calcification and atherosclerosis. It's produced by the enzymatic activity of xanthine oxidase and is the final product of purine metabolism. Xanthine oxidase produces that may have role vascular disease were correlate serum uric acid levels with severity of elevation myocardial infarction. The helps of Phillips classification at presentation and to assess any clinical role of serum uric acid levels on in-hospital mortality in ST elevation myocardial infarction patients. High serum uric acid levels have also been identified as a risk marker for cardiovascular disease development, progression, and mortality. Now I'll discuss about Phillips classification. It is a system used in individuals with an acute myocardial infarction and heart failure, taking into account physical examination and development of heart failure in order to predict and stratify their risk of mortality. Patients were ranked by Phillips classification in the following way. There are 4 classes, CLIP 1, 2, 3, and 4. CLIP 1 includes individuals with no signs of congestive heart failure. CLIP 2 is presence of S3 or lung disease. CLIP 3 includes pulmonary edema and includes cardiogenic shock. Now, aims and objectives of my study is to assess serum uric acid level in acute myocardial infarction, to know the prevalence of hyperuricemia in STMI patients, and to study the prognostic significance of serum uric acid in ST elevation myocardial infarction. Methodology. My study design is observational cross-sectional study, and I collected data from period of 1 year between March 2023 to 2024, and the place of my study is Dheeraj Hospital, SPKS Vadodara, and study population is 100 consecutive patients of STMI admitted in our Department of General Medicine of Dheeraj Hospital. Inclusion criteria included all patients of 18 years or more and diagnostic cases of STE elevation myocardial infarction, which are diagnosed with the help of history, physical examination, ECG changes, and biochemical markers, and that were admitted within 24 hours of the onset of symptoms. Now I'll tell about exclusion criteria. I excluded patients with chronic kidney disease, hypothyroidism, hematological malignancy, gout or other inflammatory diseases, chronic alcoholism, and patients with history of drug intake like aspirin, diuretics, ethambutol, pyrazinamide that increases serum uric acid levels and will falsely increase the product of my study. History and physical examination was done at the time of admission or within 12 hours. The Phillips class at admission was noted, and investigations like blood sugar, HbA1c, lipid profile, CBC, urea, creat, ECG were done, and serum uric acid was determined within 12 hours of admission, and all data were then analyzed statistically. Now I'll tell you about my results and observations. Occurrence of hyperuricemia and gender ratio in the study. I included presence of hyperuricemia, which is present and absent in normal individuals, versus the percentage and gender, which in male is 76% and female is 24%. And I'll tell about all the risk factors that were included in the prevalence of this study, which included age more than 50, male sex, smoking, hypertension, diabetes, dyslipidemia, and hyperuricemia, and their occurrence with hyperuricemia. Now I'd like to discuss about all this, that in our study, total of 100 patients were included. Okay. Measuring serum uric acid is one of the predictable prognostic indicator in AMI and one of the early and short-term predictor. In general, serum uric acid is higher in male patients compared to female, but in our study, female patients of more than 70 years of age with STMI had significant hyperuricemia 3 and 4, and elevated uric acid had an objective correlation with echocardiographic evaluation of LV dysfunction. Combination of serum uric acid and CLIPS class after STMI is a good predictor of mortality and severity of heart failure. Thus, in India, where most of the people are belonging to a lower middle socioeconomic status, can be easily monitored using serum uric acid levels as the biomarkers for outcome of myocardial infarction. I would also like to discuss about the flowchart I had already shown above, that of the total 100 patients, 76 were males and 24 were females, and show predominance of male sex affected ST elevation myocardial infarction, and uric acid level significant rise in female patient more than 70 years of age.
Hello, excuse me.
Hello.
Can you hear me?
Yes. Hello.
Can you? What is the? How can you establish the relationship between the myocardial infarction and uric acid level?
Hyperuricemia, if the uric acid levels are an early prognostic marker of ST elevation myocardial infarction, like sir, in poor resource settings where the gold standard that we do, drop eye, etc., are very expensive, and STMI can be prognostically raised in patients with early ST elevation myocardial infarction. If the uric acid levels are raised, hyperuricemic condition is early and short-term predictor of uric acid levels and suggests this correlation with MI. Like in the case study, I included 100 patients, and of the total patients, 52 were CLIPS class 1 and 19 were CLIPS class 2 belonging, which suggested that hyperuricemia is indirectly indicated to myocardial infarction.
But what is the mechanism? I ask. How mechanism?
It is because there are inflammatory markers and mediators are raised, and hyperuricemia is also elevated in myocardial infarction because of the inflammatory mediators that's cascade that is involved because of endothelial cell
Very
activation.
good. Very good. Very good. Thank you.
Okay. Thank you so much, sir.
Okay, so now our next participant is Dr. Padmini Sargara. Dr. Padmini, are you ready with the presentation? Dr. Padmini?
Yes, ma'am. Should I share the screen?
Yes, yes. Yes, you can continue.
Good afternoon, everyone. I am Dr. Padmini Sargara, cardiac resident from Pathology Department. I am presenting
Sorry to
topic on.
Sorry to interrupt.
Yes,
Your slides are not showing. Have you started your sharing screen?
Yes, ma'am.
Dr. Padmini? Okay, now it is visible. Okay.
Visible, ma'am?
Yes, yes, it is visible, but your content is not visible. It's showing just as white screen, but your content is not visible.
Right, ma'am.
Okay.
Okay, ma'am.
Now start your slideshow.
Okay, ma'am.
Start slideshow.
Okay. Wait, ma'am.
There will be an option there on the above. Home, insert. You click on the slideshow there. Can you see?
Fine.
Yeah, so you click on it and then click on from the beginning.
Okay, ma'am.
What's the problem, Dr. Padmini?
Ma'am, slide share is not going on.
You stop sharing the screen.
Okay, ma'am.
Then again do the slide sharing.
Okay, ma'am.
Okay, now reshare. Click on the screen. Do not click on any other thing. हाँ ऊपर स्लाइड शो નો ઓપ્શન આવશે હોમ ની બાજુમાં હોમ લખ્યું છે ને હોમ ઇન્સર્ટ ડિઝાઇન એનિમેશન અને સ્લાઇડ શો સો ક્લિક ઓન હા ત્યાં સ્લાઇડ શો પર ક્લિક કરો and then from beginning ત્યાં નીચે જો પહેલો જ ઓપ્શન છે ને લેફ્ટ સાઈડ હોમ ની નીચે
Is it visible, ma'am?
હા હવે હા બસ
Okay, ma'am. Good afternoon, everyone. I am third year resident from pathology department, Dr. Padmini Sargara. I am presenting gastrointestinal tract malignancies and their histopathology IHC correlation. Introduction. GIT tumors represent formidable challenges in healthcare system to prevalence and high histology subtypes. They are various in morphology like adenocarcinoma, neuroendocrine, gastrointestinal tumor, lymphoma, and they are very significantly seen globally, varying incidence rates and mortality trends depending on geographic and genetic lifestyle factors. GIT arise from epithelial, mesenchymal, neuroendocrine, or lymphoid tissue from digestive tract. Adenocarcinoma originated from glandular structure, most common type, affecting regions like esophagus, stomach, colon, pancreas. Neuroendocrine tumors are rare, are known for hormone secreting capabilities and unpredictable clinical courses. The study of GIT tumors with their histopathology and IHC correlation holds significant implications for clinical practice and patient care. By investigating correlation between histopathological features and IHC profiles, this research aims to enhance the accuracy of GIT diagnosis and refine the prognostic predictions. The integration of IHC into routine diagnostic protocols promises to streamline decision-making processes, optimize the molecular profiling, good treatment selection, and IHC analysis represents a paradigm shift to GIT diagnosis, offering enhanced diagnostic accuracy and prognostic insights. Now, aims and objectives are that to study the morphology of all GIT tumors extending from oral cavity to anus, to detect the role of IHC study in early detection of GIT pathologies, to correlate IHC marker study with histopathological findings of these GIT specimens, and to find the diagnostic accuracy of IHC by comparing it with the final histological findings. In matter of method, we took 50 cases of GIT specimens for the duration of 2 years. In inclusion criteria, I included all histopathological confirmed cases of gastrointestinal tumor malignancies, all patients of radiologically diagnosed GIT tumors, and patients above the age of 18 years of all both the genders. And we excluded the patients of previously diagnosed gastrointestinal malignancy, the patients on chemotherapy, all non-neoplastic lesions, and lesions from pancreas, liver, and biliary tract tumor. All specimens submitted in the histopathological section are processed for paraffin embedding, taken the section and studied with H&E stain and performed by light microscopy. After that, the block tissue from the block we taken a 4 mm thick section and doing IHC on L-lysine coated slides, which accordingly primary antibody and treated with secondary antibody
to
known as
conclusion.
poly-SRP. Okay, ma'am. The tumors of GIT tract are varied. Yet it can often improve diagnostically challenging and understanding the unique immunohistochemistry marker profile for each entity will greatly assist in diagnosis of these tumors. The cases I took in GIT malignancies are more common in male than in females, and commonest age group is 61 to 80 years. And out of 50 cases, 20 cases were adenocarcinoma of colon, 11 were adenocarcinoma of stomach, 8 were squamous cell carcinoma of esophagus, 5 were adenocarcinoma of duodenum, 3 were GIST, 1 were gastric lymphoma, and 2 were adenocarcinoma of rectum, and all were confirmed by appropriate IHC marker study.
So, what is your
Thank you.
take-home message?
Sir, take-home message is there that histopathological morphology is a primary step in the diagnosis of malignancy. That is okay, but we have to confirm the lineage from the IHC marker study, and IHC marker study also gives a prognostic factor also like Ki67, EGFR, P60, which will be helpful in patients further prognosis and treatment courses.
What are your immunotherapy for the malignancies of GIT?
Sorry, sir.
Immunotherapies for GIT malignancy.
I'm sorry, sir. I don't know this.
Okay. Next, please.
Thank you, sir.
Our next participant is Dr. Dharti Kanani. Dr. Dharti, are you ready? I have made you presenter.
Am I audible, ma'am?
Yes, you are audible. Now start sharing your screen.
Yes, ma'am. Is my screen is visible, ma'am?
Yes, it's visible. Now start your slideshow option.
Can I start, ma'am?
Yes, now you can start.
Good afternoon, all. Myself, Dr. Dharti Kanani, third year resident at the Ampisha Medical College. I am presenting a paper on the study of the epithelial to mesenchymal transition process by the vimentin expression in the ductal carcinoma of the breast. Why it's not moving, ma'am? Is it not? It is not moving.
Anywhere on the screen and then change the next slide.
Okay, thank you. The epithelial to mesenchymal transition is defined by the loss of the epithelial characteristic and the acquisition of the mesenchymal phenotype. It is an active physiological process such as the embryogenesis and the morphogenesis of the mammary gland. It is also reactivated during the wound healing, tissue fibrosis, and the pathogenesis of the tumor progression and metastasis of the carcinomas. It is reversible process. So the mesenchymal to epithelial transition is essential for the establishment on the outgrowth of the cancer cells at the secondary site. EMT is associated with increased aggressiveness, invasiveness, and the metastatic potential of the tumor. Now, the characteristic of the EMT, there is a loss of the intercellular adhesion, that is the E-cadherin or the occludins, downregulation of the epithelial marker, that is the cytokeratins, upregulation of the mesenchymal marker, that is vimentin and smooth muscle actin, acquisition of the fibroblast-like morphology, and increase in the motility, invasiveness, and the metastatic capabilities. My aims and objective of this study is to study the epithelial and mesenchymal transition process by the IHC expression of the vimentin in the invasive ductal carcinoma of the breast. The material and method. This study includes the 100 cases of the histologically diagnosed case of the ductal carcinoma of the breast. The tumor with extensive necrosis without sufficient viable tumor cells are excluded from this study. The sections from the specimen containing the lesion of the interest were used for the IHC staining for the vimentin. The assessment of the vimentin stain slide is assessed under the light microscope. 8 to 10 fields were observed. The areas of the necrosis, hemorrhage, and the tissue folding were excluded.
Last 1 minute.
cytoplasmic staining was considered positive. 10% of or the more of the total cells were positively stained are considered as a positive for the vimentin. Observation and results of the my study shows that out of 100 cases, majority are the females. Incidents were more in the fifth decade of the life. 92% cases were having a modified Bloom-Richardson grade 2. 54% cases were positive for the lymph node metastasis. The result of the immunohistochemical study shows the 79% cases are ER positive, 71% PR positive, 13% HER2 positive, and 35% shows the high Ki67 index. Molecular classification according to IHC, it shows the majority of the cases are the luminal type A. Luminal B cases are 18%, followed by the HER2 enriched 12% and triple negative 9%. Vimentin study shows the 17% cases are positive for vimentin and 83% cases are negative for the vimentin. This table shows the various pathological parameters and association with the vimentin. So the vimentin is positive in 33% cases of the early age breast carcinoma, that is less than or equal to 40 years, which is more than the cases of the higher age group. All vimentin positive cases are modified Bloom-Richardson grade 2. All grade 1 and grade 3 cases are the negative for the vimentin. Cases with the positive lymph node metastasis having a 7% positivity with the vimentin, while cases which are negative for the metastasis have a 26%. Okay, ma'am.
So what is take home message?
So the take-home message is as the epithelial to mesenchymal transition increase, the invasiveness and the aggressiveness of the tumor is increased. So the chances of the metastasis is increased. So we can evaluate it by the epithelial to mesenchymal transition by the vimentin expression in the by the help of the IHC.
What are your recommendation to general public to prevent the carcinoma of breast?
Sorry, I didn't get you, sir.
What are your recommendation to public and mass to prevent the carcinoma of breast?
So for the early detection of the breast carcinoma, like self-assessment of the breast, awareness of the self-assessment of the breast, then early diagnostic, early screening for the breast carcinoma, like the mammography and routine examination of the breast after 45 years of the age.
Okay, thank you.
Yes, thank you, sir.
Okay, stop sharing your screen. Okay, so our next participant is Dr. Kishore. I am making you presenter, Dr. Kishore. Kindly unmute yourself. Dr. Kishore. Yes, Dr. Kishore, now you can start your PowerPoint.
Yes, ma'am. Hello?
Yes, your screen is not visible yet. Are you presenting from mobile or laptop? Yes, are you presenting from mobile or laptop?
From mobile, ma'am, I am not able to. Hello?
Can you see red option, sharing option?
Yes,
Click on
ma'am.
it. Click on share option.
Open your PPT. Directly open
Yeah.
your PPT.
Yes, ma'am. Hello?
Yes. What kind of difficulty you are facing right now?
It's not.
Okay, you do reshare. Right now, you stop sharing and again
Okay,
reshare
ma'am.
your. Okay.
Okay.
You first click on share option.
Yes, ma'am. Then optimize for video.
Yes.
Okay.
You have to click on the screen right now.
Doctor?
No, I'm trying.
Okay.
Hello?
You have joined from mobile, right? So when
Yes, ma'am.
you're clicking on the share content, what do you see the
Yes,
first thing?
Oh,
You don't have to optimize the video. You have to click on the screen. There will be options. If the next participant is ready, Dr. Monik Rathod, please raise your hand. If you are ready, then we can take you. By the time, Dr. Kishore, please resolve your problem. Dr. Monik? Dr. Monik Rathod?
Dr. Monik Rathod, are you ready? Unmute yourself.
Yes, ma'am.
Okay. Now start sharing your screen. You are presenting from mobile or laptop?
Laptop. ma'am.
Okay. Okay. Your screen is visible now. Now you can start your presentation. Okay.
Myself, Dr. Monika Rathod. I am third year resident in Sri M. Pisha Medical College, Jamnagar. I am presenting the study of histopathological spectrum of lesions in leprosy patient at Guru Gobind Singh Hospital, Jamnagar. Leprosy has been declared eliminated. Just a second. Just a second. Leprosy is one of the most ancient diseases known to mankind. It is a chronic debilitating granulomatous disease caused by the Mycobacterium lepra, principally affecting the nose and the skin, cooler parts of the body. It also involves the eye, bones, testes. The positive agent is Mycobacterium leprae, which was discovered by the Hansen in 1873. Now, leprosy has been declared eliminated with a prevalence rate of less than 1 per 10,000 population. as an important public health problem in our country from January 1, 2006. Still, its prevalence is reduced to 0.66 per 10,000 in 2016. Despite the successes, fact remains that India continues to account for 60% of new cases reported globally each year and is among the 22 global priority countries that contribute 95% of world numbers. Now, physical disabilities also caused by the leprosy often evoke severe social stigma that leads to prejudice against patients and their families. Hence, we need to control the communicable diseases and identify and destroy the positive organism. It may present as a skin lesions or extensive disease causing profound disability. Now, precise criteria is laid down by the Ridley-Jopling in 1966. We need to classify into 5 categories: tuberculoid, borderline tuberculoid, mid-borderline, borderline lepromatous, and lepromatous leprosy, which is based on clinical, immunological, and histomorphological factors. Indeterminate forms are also included, and histioid leprosy is also included. Now, the aims is to study the histopathology and classify different histopathological subtypes. We basically received the skin biopsy specimen from 100 diagnosed leprosy patients in Department of Pathology from January 2022 to August 2024. And materials mainly came from the OPD in dermatology department. All the diagnosed cases were included in the study. Cases were selected regardless of age, sex, religion, occupation, and socioeconomic status. We exclude the cases which were inadequate biopsies, inconclusive reports, and plurally preserved biopsies. Biopsies were taken in among the 100 patients diagnosed in present study. It is the age group range from 13 to 80 years of age, and study mainly shows the male patients' male predominance, which the male to female ratio of 1.7:1, and the maximum cases were seen in age group of 31 to 40 years. Among 100 biopsies, the most common type was borderline lepromatous, followed by the lepromatous leprosy, and 5-varicose staining was positive in 52 cases. Most of the cases in age group of 31 to 40 years, which is 32. And according to Ridley-Jopling logarithmic scale, we classify them.
To conclusion.
Accurate diagnosis is necessary for adequate treatment and avoiding deformities and medication resistance, because leprosy is a slowly progressing infection affecting the peripheral nervous as well as cutaneous nervous system. So histomorphological analysis is essential for accurate typing and classification. Basically, it's skin smear.
What is your take-home message?
Take-home message is that, sir, we need to accurately classify the disease so we can provide treatment accordingly.
What is how can you differentiate Mycobacterium leprae and Mycobacterium tuberculosis?
Sir, we can do acid fast staining, and also in 5-varicose staining they are visible.
Any immunological test?
Lepromin test is useful in leprosy patients.
Okay, thank you very much. You can go.
Thank you, sir.
Dr. Suchesha, you are the next participant. Kindly stop sharing your screen, Doctor.
Yes, ma'am.
Dr. Suchesha, I am making you presenter. Kindly unmute yourself.
Yes, ma'am.
Okay, and start sharing your screen.
Share screen.
You are presenting from phone or laptop?
Ma'am, iPad.
Okay.
Is it visible, ma'am?
Yes, visible.
Okay. Ma'am, I'm presenting case of accuracy of ultrasound in detecting antenatal anomalies in the first and second trimester. Ma'am, it is visible?
Yes, you are audible and visible too.
Okay, ma'am.
Continue.
Over the last 4 decades, in genetic basis of an increasing number of diseases becoming understood. At the same time, safe and effective fetal diagnostic techniques are being developed. Introduction. Prenatal diagnosis of the anomalies is beneficial in the following ways. Malformation incompatible with life may be terminated. Certain abnormalities may be correctable in utero. Provide opportunity to arrange corrective measure beforehand. Offer a chance to be delivered at a place where the required facilities available. Aims and objective to determine the sensitivity and specificity of ultrasound in the diagnosis of first and second trimesters antenatal anomalies. Materials and method. Antenatal patients who were referred to Dheeraj General Hospital during a period of 5 months were included in the study, out of which high-risk group were carefully evaluated and 30 patients were diagnosed having congenital fetal anomalies in first and second trimester. The study was carried out by an experienced operator using sophisticated ultrasound equipment. Ultrasonography in prenatal scans. It is a screening tool in all the trimester, evaluating the utility and accuracy of antenatal ultrasound in a distributively complex due to variables such as risk status of the group examined, type of anomaly, operator skill and experience. Sophistication of ultrasound equipment affect the results of the investigation. Ultrasound in prenatal scans. At the 10 to 14 weeks, the knuckle translucency more than 2.5 mm is the chromosomal. There might be a chromosomal anomalies association. 18 to 20 weeks, 75% fetal abnormalities can diagnose on ultrasound. Chromosomal anomalies such as trisomy 21, trisomy 18, trisomy 13 are diagnosed by ultrasonography. Maternal risk factor, increasing maternal age, congenital anomalies in previous children, family history of stillbirth, recurrent first trimester abortion of marriage, present history of drug intake, radiation exposure, maternal chronic disease, small for gestational age, decreased fetal movement, fetal malpresentation, viral infection in early pregnancy. Result: out of 30 subjects with congenital fetal anomalies, 14 diagnosed with CNS abnormality, 6 with renal, 5 with GI abnormality, 2 with facial and skeletal abnormality, 3 with single umbilical artery. Correlation between history and positive finding. Out of 30 patients, 10 patients have positive family history. Five had a history of viral infection in early month of pregnancy. 14 has diabetes mellitus. 1 has history of intake of phenytoin. 1 patient was above 35 years of age. Accuracy of ultrasound.
Conclude.
Hence, we conclude ultrasound is not only the first line of investigation in diagnosis of antenatal anomalies, but as it is cheap, dynamic, and easily available modality, it is the preferred choice of investigation in prenatal scans.
So, what is your take-home message?
Sir, take-home message is that every pregnant female of first and second trimester must go under one ultrasound examination, anomalies cancer.
What is the impact of age of the parents on congenital malformation?
Sir, as the age increases, there is increased risk of anomalies in fetus, sir.
Why? Why so?
Sir, that I don't know why.
No, okay.
Stop. Okay, so stop sharing your screen. Our next participant is Dr. Bharvi. I am making you presenter. Dr. Bharvi, kindly unmute yourself.
Yes, ma'am.
Okay. You can now start sharing your screen now. Open your PPT.
Am I visible, ma'am?
Yes, okay.
I am Dr. Bharvi Ninama, second year resident of General
Can you
Medicine
just
in Animal.
go on the landscape mode? You have been on portrait mode.
Yes, ma'am.
Okay, great.
My case of the intermediate syndrome following organophosphate poisoning. Introduction in organophosphate poisoning is the most common poisoning in India. These chemicals are found in pesticides, insecticides, and nerve agents. These substances interfere with the normal functioning of the nervous system by inhibiting the enzyme acetylcholinesterase and resultant accumulation of the acetylcholine with continuous stimulation of the local receptor and eventual paralysis of the nerve or muscle. Clinical history, a 64-year-old male patient, known case of hypertension, hyperthyroidism, chronic alcoholic, came to the hospital with complaint of vomiting, increased frequency of the stool, difficulty in breathing, which started suddenly since 3 hours. Patient relative gave history of alcohol drink with consumption of the unknown substance 6 hours ago. At the time of admission, the patient was conscious but disoriented to time, place, person. Vitals temperature is normal, pulse rate 80 per minute, blood pressure is 140 by 90 mmHg, respiratory rate is 20 per minute, SpO2 is 84% on room air and 96% on 4-liter O2 by oxygen mass. Respiratory system bilateral air entry present with rhonchi and crepitation. Patient with started deteriorating and become drowsy and more breathlessness so that he was intubated. CNS examination, bilateral pinpoint pupil noted. Power and reflex could not be elicited as the patient was intubated. Tone was normal in all limbs. In view of history of ingestion of the unknown substance, false smelling vomitis, bilateral pinpoint pupil, organophosphate
Sorry to
poisoning was
interrupt,
suspected.
Dr. Bharvi. Your slides are not changing.
Now, ma'am.
No, not yet.
Now, ma'am.
No, it's not. Okay, now visible. Okay, now it's changing. Okay, fine. Go ahead.
Patient general conditions started improving and extubated on second day, started maintaining sp2 and 3 to 4 liter of O2 and breathing improved. After 1 day of improvement, the patient became breathlessness and drowsy again. So emergency intubation was done and paradoxam started for accident day. Patients started showing improvement clinically with treatment, extubated and monitored closely. After a period of close monitoring, patient was discharged and was with stable vitals. Investigation. In plasma cholinesterase is less than 0.2 and RBC cholinesterase less than 0.2 is a low level.
Sorry to interrupt, Dr. Bharvi, but your screen is still not visible. If you see on the below left corner, there you can see the present. Click on the present.
Yes, ma'am. Now, ma'am, change.
ચેન્જ થાય છે પણ તમે ત્યાં ઓલું પ્રેઝન્ટ ઉપર ક્લિક કર્યું?
Yes, ma'am.
Okay, now it is visible properly. Go ahead.
My differential diagnosis is organophosphate poisoning because the clinical feature is vomiting, salivation, lacrimation, diarrhea, meiosis, bradycardia, and bronchospasm. Botulism, ascending flaccid paralysis with diplopia, dysphagia, dysarthria with anticholinergic signs such as constipation, dry skin, urine retention, and increased temperature. Opioid poisoning, euphoria, headache, hypothermia, hypotension, bradycardia, constricted pupil, flushed face. Mushroom poisoning like a ingestion of the toxic species, vomiting, fever, diarrhea, kidney and liver injury. Myasthenia gravis is clinical feature like weakness of voluntary muscles, progressive weakness as day passes with activity, stosis, diplopia, difficulty in speaking, normal deep tendon reflex, and Guillain-Barré syndrome, progressive motor weakness of limb
Come
with
to
hypo and
conclusion.
hyper. My conclusion is an intermediate syndrome contribute to morbidity and mortality. Delay presentation of this patient after organophosphate phosphorus ingestion in 6 hours is likely cause intermediate syndrome like complication of organophosphorus poisoning. As soon as patient is admitted and diagnosis and treatment started as early as possible, early recognition will help in prompt ventilator support. Patient with acute organophosphate poisoning should be assessed for muscle weakness after cholinergic crisis is over to anticipate impending respiratory arrest due to intermediate syndrome. Without a clear understanding of the pathophysiology of intermediate muscle syndrome, specific therapy is not available and supportive measures remain the cornerstone in the management of intermediate muscle syndrome. The prognosis of intermediate syndrome, however, is likely to be favorable if respiratory failure can be promptly recognized and treated accordingly.
So what is your take-home message?
My take-home message is that if the patient comes with the history of the unknown substance, we have to ask for proper history and throughout clinical examination and repeated investigation
Suppose
with
patient
eyes
is
open on possible
suppose pa-
differential diagnosis.
Hello, suppose patient is brought unconscious on the road, what will you do?
Sorry, sir.
Patient is found unconscious on the road with suspected unknown poisoning. What will you do?
Firstly, you check vitals and clinical examination and CNX examination.
Okay.
Then and basic investigation is done.
Okay. Okay, thank you very much.
According to different. Thank you.
Okay. So our next participant is Dr. Kishore. I am making you presenter.
Hello.
Yes, Dr. Kishore.
Yes, ma'am. Hello.
Yes, yeah, your screen is not visible yet. You are not audible.
Oh. Hello.
Yes, Dr. Kishore.
Yes, am I audible?
Your voice is breaking.
Hello. Hello.
Yes, Dr. Kishore. Your voice is not audible right now.
Yes, ma'am. Hello.
Hello, Dr. Kishore.
Yes.
તમે વચ્ચેથી જોરથી હલો હલો કરો છો એ સંભળાય છે પણ એના સિવાય પછી સંભળાતું નથી અને
મેમ શેર આમાં નેક્સ્ટ ટેક્સ્ટ એન્ડ ઇમેજ ઓપ્ટિમાઇઝ ફોર વિડિયો એન્ડ શેર સ્ક્રીનમાં શેર સ્ક્રીન કરીએ છીએ પણ થતું નથી.
શેર સ્ક્રીન પછી પાછળ ઓપ્શન નથી આવતો કે સ્ક્રીન કયો પાર્ટ તમારે શેર કરવો છે
નહીં.
અત્યાર સુધી બધા જ એવી રીતે જ શેર કરે છે
શેર સેકન્ડ ચાલુ છે જેટલી મિનિટ થી ચાલુ છે પછી નથી આવતું મેમ.
એવું હોઈ શકે કે તમારા સેટિંગ્સમાં કઈ સેટિંગ્સમાં એવા પ્રાઇવસી નોટિફિકેશન્સ ઓફ હોય કે જેના કારણે એ અલાઉ ના કરે તો તમે કદાચ એકવાર એ ચેક કરીને પછી હોય તો ફરી આવો તમે શેર સ્ક્રીન કરો છો ને તો દેખાય છે કંઈક બ્લેક બ્લેક આવે છે પણ દેખાતું નથી કે તમે શું શેર કરો છો ઇફ પોસિબલ તમે કોઈ આજુબાજુમાં કલીગ કે કોઈ ફ્રેન્ડના ફોનમાંથી ફરી ટ્રાય કરી જુઓ આમાં જજનો પણ ટાઈમ બગડે છે So let's call the next one. Dr. Kishore, you can solve your query after till now. ત્યાં સુધી આગળના બીજા પાર્ટિસિપન્ટ્સ ને પૂરા કરી દઈએ. So now next participant.
So our next participant is Dr. Lakshmi Anvita. Dr. Anvita, I am making you the presenter. Kindly raise your hand. Unmute yourself. Dr. Anvita, kindly
Yes, ma'am.
unmute yourself. Okay. I have made you presenter. Now you can start sharing your screen, Ram. You are presenting from phone or laptop?
iPad.
Okay.
Is it visible now?
No, it's not visible yet. Not visible yet. Have you started your screen sharing?
Yes, ma'am.
એવું હોય તો પાછું તમે સ્ક્રીન શેર કરવાનું ચાલુ કરો બંધ કરીને.
Okay.
શું પ્રોબ્લેમ આવે છે અન્વિતા? ડોક્ટર અન્વિતા?
मैम शेयर तो हो रहा है मैम, लेकिन फाइल ओपन नहीं हो रहा है.
आपने शेयरिंग के बाद स्क्रीन किया था ना? ओके ओके ओके.
एक बार फिर से ट्राई.
स्क्रीन पे स्क्रीन वाला ऑप्शन है ना, वो वाला सिलेक्ट करना है.
ओके, शेयर स्क्रीन.
यस.
शेयर स्क्रीन वेबएक्स हो रहा है मैम.
Okay, your screen is visible now. Okay, okay. Your start your presentation slideshow.
Okay, I myself Lakshmi Anvita from
Sorry to interrupt.
General
Start
Medicine District.
slideshow.
Okay, I'm going.
સેકન્ડ લાઈનમાં ઉપરથી તમે જોશો ને હોમ ઇન્સર્ટ ને બધું લખ્યું છે એની બાજુમાં
Okay,
જ
okay, yeah.
સ્લાઇડ શો લખ્યું છે. ઓકે.
Yes, fine. I'm going to present a case on prevalence of left ventricular diastolic dysfunction in chronic obstructive pulmonary disease. Or
Dr. Anvita, you are not audible.
Yes, ma'am. Just a minute.
Dr. Anvita, we are running out of time. Do fast.
Yes. Yes, ma'am. Is it visible now? Hello?
Open your PowerPoint now.
Yes, ma'am. Is it visible?
Yes, it's visible. Now start your slideshow.
Okay. I'm sorry for the disturbance. I'm going to present on a case about prevalence of left ventricular diastolic dysfunction in chronic obstructive pulmonary diseases. Or chronic COPD is characterized by fibrosis and lung tissue destruction, resulting in decreased elasticity. It is a fifth leading cause of death and its second most common lung disorder in India, following pulmonary TB. And COPD is a treatable and preventable disease, which is caused by preventable side effects like tobacco smoking. COPD is also linked to a number of extrapulmonary manifestations like ischemic heart disease, congestive heart failure, arrhythmias, and most commonly AF. These all cardiovascular diseases are the most common systemic manifestation, accounting for a high mortality and morbidity rate. And cardiovascular disease account for 50% of hospitalizations and 20% of all deaths among COPD patients. Therefore, there's a strong association between COPD and cardiovascular disease. Aims. If you look at the aim of the study to identify the prevalence rate of left ventricular diastolic dysfunction in patients with COPD, and objectives include to assess the clinical profile of left ventricular diastolic dysfunction in COPD patients and to grade the severity of each one, and to assess the relation between severity of COPD and grading of LVDD and in its correlation with CRP, which is studied for 12 months. And inclusion criteria, it includes patients with age between 30 to 70 years of both genders, and patients who are diagnosed with COPD as per the GOLD criteria. And exclusion criteria includes patients with other comorbidities such as diabetes, hypertension, hypothyroidism, and patients with already having a lung disease such as chronic asthma, ILD, and pulmonary TB, and patients with arrhythmias, valvular heart disease or congenital heart disease or coronary artery disease. The collection of data, 120 patients with COPD and diagnosed with COPD have been included in the study. According to the discussion, diastolic function of left ventricle was assessed by transmitral flow velocity, and diastolic filling is usually classified initially on the basis of the peak mitral flow velocity of the early rapid filling wave, peak velocity of the late filling wave caused by atrial contraction, and accordingly diastolic dysfunction is graded into 4 grades. Grade 1, which includes mild dysfunction, grade 2 moderate dysfunction, and grade 3 severe reversible dysfunction, grade 4 severe irreversible dysfunction. If you come to the results of the study, according to the sample we have taken, age distribution is mostly in between greater than 60-year age group have been included more, then followed by 51 to 60 years. And smokers have 92% of the population sample was smokers, and the remaining were non-smokers. And the male population were predominant, as COPD is a predominant male disease. And almost 5 to 10%, according to the symptoms, 5 to 10 years of a person having symptoms have more propensity to develop left ventricular diastolic dysfunction, and mostly grade 2 and 3, that is mild and moderate grading of COPD, have been mostly associated with left ventricular diastolic dysfunction. According to the conclusion, in among the COPD patients, left ventricular diastolic dysfunction is the most common cardiovascular side effect, followed by pulmonary arterial hypertension. And cardiovascular diseases in COPD is mostly seen associated with smokers, then non-smokers, and in more in males than in females. And and mostly in greater than 60 years of age group. And according to X-ray changes, hyperinflated lungs are mostly present in COPD patients, plus cardiovascular dysfunction, followed by abnormal ECG changes.
Which test is performed to confirm diastolic dysfunction?
Sir, can you repeat, sir? I couldn't get.
Which test will you perform to confirm the diastolic dysfunction?
On the echocardiography.
So, what are the criteria, echographic criteria of diastolic dysfunction? Okay, anyway, what is your take-home message?
Sir, take-home message is that any patient who presents with chronic obstructive pulmonary disease has to be evaluated for cardiovascular disease, as both the treatment criteria are different. Most of the deaths and hospitalizations are more in COPD patient who has a complication of cardiovascular disease, sir.
Okay.
Stop sharing your screen, Dr. Anvita. Our next participant is Dr. Samyak Jain. Kindly unmute yourself, Dr. Samyak. I am making you the presenter. Dr. Samyak, now start sharing your screen.
Hello. Yes. Wait. Good
Okay, now
afternoon,
start
everyone.
slideshow. Yes, your screen is visible now.
Myself, Dr. Samyak Jain, second year PG resident, General
Start
Medicine.
slideshow.
Yeah, I've started. Is it visible?
It's visible, but presentation mode you have to do, na? Can you see the slideshow wala option from the
Yes,
top?
I've clicked it.
Okay. No, but it's not on the presentation mode. Reshare now.
What's visible?
Can you do reshare?
Wait. Yes. Now it's okay. Hello.
Yes, hello. Still it is not showing the slideshow. Don't click on the Microsoft option. Directly click on the screen. Stop sharing. Go back,
Okay.
reshare.
Then
And while sharing, do not click on the Microsoft. Click on the screen.
okay. Now it's okay.
Okay, now you go ahead with slideshow.
Slideshow. Now it's okay.
તો પણ નથી દેખાતું. કઈ નહીં, આમાં જ continue કરી દો.
Okay.
Slides change કરીને બતાવો ને.
Is it changing?
ના.
Like this?
હા, ચાલશે. હા, okay.
Okay. So my topic is a rare case of atypical HUS. Hemolytic uremic syndrome, particularly atypical, is extremely rare condition among the thrombotic microangiopathies. Thrombotic microangiopathy can be broadly classified into thrombotic thrombocytopenic purpura or HUS, with HUS further classified as typical and atypical HUS. Atypical HUS is a rare form of complement-mediated TMA, most commonly caused by mutation in the alternative complement cascade, resulting in the overactivation of complement, which causes endothelial damage. Endothelial breakdown leads to platelet activation and consumption, microthrombi formation, and erythrocyte lysis, leading to hemolytic anemia and cystocytes. While the pathophysiology of various TMA is different, clinically it can be challenging to distinguish atypical HUS from TTP. So my case report is a 35-year-old male with no known comorbidity presenting as acute dysentery since 7 days associated with nausea, non-bilious vomiting, and abdominal pain, and with anuria since 3 days. He denied any melena, hematemesis, or fever chills, and no history of any medication consumption. His lab reports were anemia and thrombocytopenia with hemoglobin of 10.2 and platelet count of 1 lakh on presentation. Peripheral smear showed schistocytes and LDH was elevated, suggestive of microangiopathic hemolysis. Stool culture was sterile. His RFT was create level was 5.75 and urea level was 75, suggesting of AKI. His coagulation studies remained normal, ruling out disseminated intervascular coagulation (DIC). Complement levels of C3 were reduced, with normal C4 suggestive of complement dysfunction. Atypical HUS is a result of complement dysregulation due to congenital or acquired causes. It classically presents with a triad of thrombocytopenia, microangiopathic hemolytic anemia, and acute renal failure. The affected patient often have low C3 and normal C4, suggestive of alternate pathway activation due to factor H deficiency or deficiencies in other complement regulatory proteins. Physicians need to differentiate TTP from atypical HUS as trials have shown the efficacy of eculizumab in treating atypical HUS, particularly with regard to improvement in renal function and in case of recurrence and post-transplant. So my conclusion of this case report was atypical HUS is a rare disease most commonly caused by the mutation in complement regulatory protein. It can be challenging to diagnose, especially if the anemia and thrombocytopenia are not found at presentation. There are no clear diagnostic criteria for atypical HUS, and it remains a diagnosis of exclusion. It is vital to diagnose atypical HUS promptly, as prompt initiation of eculizumab can lower mortality and morbidity. Atypical HUS has a poor prognosis, eventually leading many patients to require dialysis. Treatment include plasma exchange, eculizumab, immunosuppressant, and dialysis.
Sir, any questions? Sir, any questions you wanted to ask from the presenter?
So, what is your take-home message?
So my take-home message is, so there is no clear diagnostic criteria to diagnose HUS. So one should be vigilant. Even if the patient doesn't have the feature of anemia and thrombocytopenia, then also he should view a wide aspect of diseases, like in case of atypical HUS.
Which are the factors affecting this type of the condition, precipitating?
Precipitating, sir, in case of infection, in case of sir, if the patient is having any cancer or has already done any transplant, or
Malaria.
he's a case of
Malaria
diabetes.
can do malaria.
So in any kind of infection, in any kind of serious infection, severe infection, it can precipitate the disease.
So it is a immunological disease, you mean to say?
No, sir.
What is basic pathological mechanism of this condition?
So in this, sir, so it is mainly because of any mutation, some mutation in
Anxiety,
so gene.
microangiopathy.
Microangiopathy, yes, sir.
Okay. So our next participant is Dr. Kajal Makwana.
Yes, ma'am.
Okay. You can start sharing your screen now.
Okay.
It is visible, ma'am? No, not yet. Ma'am, I already shared it. Wait. Okay. You are presenting from mobile phone or laptop? Yes, okay, it's visible. Okay. Myself. Sorry to interrupt. From the Just a Department of second. Dr. Kajal. Yes, So ma'am. we are taking Dr. Kishore after Dr. Kajal, right? So Dr. Kishore, be ready with your presentation. I will be sharing your presentation. Go ahead, Dr. Kajal now. Okay. Myself, Dr. Kajal, PhD scholar from Department of Anatomy at Narendra Medical College, Gujarat University. My guide is Dr. Mayuri Shah. So my topic is a dermatoglyphic pattern in the type 2 diabetes mellitus in the comparative with the study of the non-diabetic patient. So start with the introduction. The dermatoglyphics is a study of the skin marking producing by the ridge on the hand and the foot. Dermatoglyphics is the use to a way of the measuring gene expression determined by to the early prenatal environment. So the dermatoglyphic is a distinct subfield of the anatomy concerned with the analysis of the epidermal ridge and the configuration of the palmar and the plantar surface. So its its application is more important in the criminology, forensic science, embryological research, comparative anatomical study, physical anthropometry, genetics, and any other medical diagnosis. So the diabetes mellitus, it is a complex metabolic disorder with the genetic predisposition. The dermatoglyphic is the study of the fingerprint pattern and the emerge as a potential tool for the identifying the genetic marker. Diabetes has become the major health challenging driver. So this dermatoglyph is a very important for the diabetic patient because in the 2030s it may be estimated to be a 336 millions patient in the worldwide. So the idea is also this idea is also supposed to by the fact that the annually 3.2 million in the diabetic. So that's why this dermatoglyphic pattern are very important for the diabetes. The present studies are designed to compare the dermatoglyphic pattern of the patient suffering from the diabetic mellitus type 2 with the normal individual of the same reason, and the finding were compared with the previous study. The three type of the pattern are present in the dermatoglyphic, that is the arch, loop, and the wart according to the Hong and Chen classification in the 1999. So the aims and the objective this study are examining the diagnostic potential of the fingerprint patient in the disintegration type 2 diabetic mellitus patient from the control, and the significance difference in the fingerprint pattern at the frequency where the observe, suggesting that the utility as the predictive tool for the type 2 diabetes mellitus as the risk estimated. So the material matter, the present study what the carry out the total 150 patient in which there is 75 male and the 75 female diagnosed prior to the prior with the diabetes mellitus 2. In the control group also the control group consists of 150 patient in which the 75 male and 75 female patient. So the exclusion criteria are the known genetic disorder, the congenital disease, and the pre-exciting fingerprint on the dermatoglyphic anomalies. Although through the medical history, the screening ensure the eligibility for the both the cases and the control. Material required are the code duplicating ink and the paper and pencil, etc. So the pre-recording procedure are the in the method inform the concern about the what is the purpose for the study and the take the consent form. Then the preparation for the clean the hand and the water with the dry with the clean cloth. Then the recording procedure in application, the place the small amount of the ink in the slab and the spread it to the ruler and the hand inking the smear ink uniformly on the palm and the finger, ensuring to the flexor creases, ulnar margin, and the central hollow and the fingertips. In the palm recording, the place on the palm on the paper and the roll the hand from the wrist to the finger with the gentle dorsal pressure. So this is the procedure, and the same procedure are repeated in the contralateral hand, and this protocol are ensure the high quality fingerprint record for the analysis. And the dermatoglyphic pattern where the examining using the 75 mm diameter magnifying lens and the sharp HB pencil was the utilized to the mark and record the pertinent features, facilitating the detailed analysis of the reach characteristic in the pattern type or pattern area. So this is the one of the example of the right hand print in which we can see the pattern as seen in the fingertips. So this is the arch pattern, this is the wool pattern, this is the loop we can see in the observation. So the result are total in the 150 patient, 75 male and the female. And the dermatoglyphing pattern were analyzed the separately and observed were the recorded and the tabulated. So the data was analyzed by the two type of the t-test for to the finger quantitative parameter. All the analysis was carried out by to the data software SSS version 50. Okay. So this is the table for a conclusion. The present study are underscored the potential of the dermatoglyphic analysis as a screening tool for the identifying the individual predisposed to the diabetic mellitus, enabling the every intervention and the prevention of the complication. So the dermatoglyphic marker may serve as a non-invasive and the cost-effective screening tool for the type 2 diabetic patient, and the early identification of at the risk individual can be facilitated the timely intervention. And the limitation or the future scope are the with the our finding aligned with the some study, the contraindicated with the other highlights for the need for the large or multi-center study for the validate dermatoglyphic marker and the standardize the methodology and the analysis for the particular disease and investigation of the population and the specific variation and the integration with the genetic and the clinical data. Thank you. Hello, ma'am. Am I audible?
Yes, you are audible now.
Yes, ma'am.
Sir, ma'am, do you want to ask any questions?
No, fine, okay.
Okay. Thank you, sir.
Well done.
Thank you, sir.
Stop sharing your screen now. Our next participant is Dr. Kishore.
Janvi Modi, are you there?
Dr. Kishore, are you there? Raise your hand.
Janvi Modi, are you there?
Sir, Janvi Modi will present after Dr. Kishore.
Okay.
Dr. Kishore. Yes, Dr. Kishore. Unmute yourself. I'm making you a co-host. I'm sharing your PPT on behalf of you. Please unmute.
itu connected అవ్వాలి హలో అవ్వదు
Hello. Am I
Hello?
audible?
yes ma'am hello
Yes, you can present now.
yes ma'am my topic is histopathological study of non-neoplastic and neoplastic lesion of nephrectomy specimen at tertiary care hospital of Saurashtra region under the guidance of Dr. Vijay C. Popat sir and Nandini madam. Introduction. Kidneys are affected by various non-neoplastic and neoplastic pathological process. Common clinical conditions involving the kidney include the nephritic and nephrotic syndrome, renal cyst, and acute kidney injury in chronic kidney disease, urinary tract infection, nephrolithiasis, urinary tract obstruction, and various cancer of the kidneys. Because of widespread use of imaging, an increased number of renal lesion is being discovered. This renal condition can be managed medically or surgically. Aims and objective to find out the different histopathological findings in received nephrectomy specimen, to analyze gender and age-wise frequency of neoplastic and non-neoplastic lesion of the kidney, and to study the different lesion and evaluate the rare condition. Material and method. Type of study, retrospective study. Location in our medical MPSI Medical College. Duration of study 1 year. Number of cases 25, and sample type is the all nephrectomy specimen. Specimen processing. Grossing was done to see the representative areas of the whole specimen. Then fixation was done using 10% neutral buffered formalin, followed by passing, dehydration, embedding block, trimming and 3 to 5 micrometer thick microtome sectioning were taken, and slide were prepared and stained with HNE stain. Then examined by the light microscopy and histopathological diagnosis given. Inclusion criteria: all age groups, sex group, and different types of the nephrectomy specimen like simple, partial radical, and laparoscopic. Nephrectomy specimen included into the study. Exclusion criteria: small inclusion or core needle biopsy and autolyzed samples were not included. My result is age and sex-wise distribution of the lesion in the received nephrectomy specimen. Here is the from less than 10 year, male is 1, and in 11 to 20 years, there are total 2 specimens received, 1 male and 1 female, and age-wise distribution of non-neoplastic and neoplastic lesion of nephrectomy specimen. Number of cases and percentage of cases on the basis of non-neoplastic and neoplastic lesion. Sex distribution on the basis of non-neoplastic and neoplastic lesion of nephrectomy. Here, distribution of nephrectomy lesion. According to the study, maximum cases were reported of inflammatory condition in non-neoplastic condition. Chronic pyelonephritic is a 10 cases and was the most common condition found in our study, followed by chronic non-specific inflammation, 4 cases. In neoplastic condition, total 8 cases were reported, among which 7 cases belong to the malignant tumor of RCC, in which 5 cases of RCC clear cell variant and 2 cases of papillary variant of RCC, followed by 1 case of clear cell sarcoma. Discussion. In the present study, total of 25 nephrectomy specimens were received in the pathology department of Sri MPSI Medical College. Age range of cases was from
Come to conclusion.
There are many different diagnoses of nephrectomized kidney lesion. So for accurate diagnosis and treatment, correlation of clinical, radiological, pathological modalities are important since they are complementary to each other. Non-neoplastic lesions were more common than the neoplastic lesion in our study, among which chronic pyelonephritic was the most common histopathological finding reported in our study. Among the neoplastic condition, RCC clear cell type was the common all the malignant tumor. Peak age of incidence of nephrectomy cases were seen in the 5th decade, and majority of them presented with chief complaint of flank pain as a presenting symptom. These are my reference.
So, what is your take-home message?
Sir, in take-home message, we receive many nephrectomy specimen in our institute, so we can correlate the which type of symptom occurs in kidney. So it is a neoplastic or non-neoplastic.
What was the method of surgical method, whether it was transabdominal or laparoscopic?
Sir, in our institute, it is laparoscopic.
Laparoscopic, okay.
Yes.
Thank you.
Dr. Janvi Modi.
Yes, ma'am.
Yes,
Hello.
you can start sharing the PPT.
Yes, ma'am. Is it visible, ma'am?
Yes.
Is it circling or not?
Yes, it is showing. Start the slideshow.
Yes, ma'am. It is a slideshow already.
નથી દેખાતું slideshow. Slideshow માં from beginning કરો ને.
Okay, ma'am.
Okay, go for it.
Good evening, everyone. Today I am going to present on an oral presentation on study of the histopathological spectrum of the prostatic lesions under the guidance of the Dr. Dhara Trivedi. Introduction. Disease of the prostate consists a significant portion of the cases seen by the urologists in the males and are a substantial source of the morbidity and the mortality among the adult male population worldwide. Three pathological processes mainly affect the prostatic gland: inflammatory, benign prostatic hyperplasia, and the tumors. Of these three, BPH is the most common and occurs so often in an advanced age that they can almost be constructed as a normal aging process. Prostatic carcinoma is also an extremely common lesion in the men, and prostatitis may be the acute or chronic bacterial prostatitis, chronic bacterial prostatitis, or the granulomatous prostatitis. It is not moving.
Click on the slide and then change the slide. Yes, it was moving.
મેમ આ રીતે કરું તો ચાલશે? ઓલામાં મૂવ નથી થતું.
થાય છે હમણાં થતું તું વાંધો નહીં. અહીંયા કરંટ સ્લાઇડ થી ચાલુ કરી દો.
Okay.
કરંટ
With the with the increasing age, most of the other organs undergo the atrophy, but mostly the prostate undergo the hyperplasia and is of the clinical relevance. Benign lesion usually present with the frequency and the nocturia, whereas the hematuria and intermediate streams are significantly associated with the malignant lesions. Early detection of the prostatic malignancy is essential to prevent an equal rise in the mortality. Aims and the objective: to study age-wise distribution of the prostatic lesions, to study the incidence of the neoplastic and the non-neoplastic lesions, to study the pattern of the histopathology type of the prostatic lesions. Material and the methods: an observational retrospective study of the various prostatic biopsies sent for the histopathological examination at the Sri MPSA Government Medical College, Gujarat, India was carried out. Study was based on the histopathological evolution of the prostatic lesion received in and duration from the June 23 to June 24. Total 65 prostatic biopsy were analyzed. Tissue were processed with the standard paraffin embedded technique and were stained with the HNE to study various histopathological patterns. Inclusion criteria: all the type of the prostatic lesion were they included. Result: a total 65 prostatic biopsy were received and the processed. The age group here is a 60 to 69, closely followed by the age group of the 70 to 79 years, accounted the most lesions, 36.93% and the 33.85 respectively. The age group of the 40 to 49 and the more than 19 years accounted for the least number of the cases, 1.54% and the 3.08 respectively, as shown in the figure 1. Second one is a true cut needle biopsy, accounted for 15.38 of all the specimen, and TURP biopsy accounted for the 84.62%. Among all the 65 cases, non-neoplastic lesion is a 75.38, where the common and the neoplastic lesion is a 24.62%. The most common diagnosis was the BPH, 43.08%, distantly followed by the BPH with the prostatitis, 32.30%, and carcinoma of the prostate is a 60.92%, and the prostatic intraepithelial neoplasm is a 7.7%. Gleason score was a 7, was the most common score and was a 45.46%. Carcinoma prostate cases, while Gleason score 6, Gleason score 6, 8, and the 9 had 18.18%. Moderately differentiated carcinoma prostate was 63 and poorly differentiated 36. My final conclusion is the BPH is the most common prostate lesion. Only few cases of the carcinoma of prostate were documented. This may be the higher if the mass screening is introduced. Hence, the effort should be made and increase awareness so as to reduce the mortality associated with the carcinoma of prostate. Surgeons should try to do ultrasound guided biopsy so as to reduce the time wasted and not to discourage a few patients who accepted to do biopsy. This one is my references. Thank you.
So, what is your take-home message?
Sir, my take-home message is as BPH is the most common prostatic lesion, so the rate may be higher if the mass screening is introduced. Hence, the effort should be made and increase the awareness to reduce the mortality.
Is there any preventive measure do you recommend to elderly population to prevent the prostatic problems?
Sir, we can do a PSA screening, serum PSA screening.
Okay, very good. Thank you. Okay, done.
Okay, stop sharing screen, Dr. Janvi.
Yes, ma'am.
So we have reached to the end of the session, end of the oral poster presentation. Sir, do you have any queries for posters?
No, all are okay. We have accepted all posters, and you can distribute the certificate whenever they are available to our office.
Okay. So, sir, would you like to announce the name right now?
No, not right now. We will declare tomorrow by tomorrow morning in our groups so that they can know better way. So that all
Okay.
the branches can also declare simultaneously.
Okay. Okay. So, here we come to the end of the oral poster session. So I hope this today's morning session has helped you today to carve yourself in the clinical practice for being a ethical and good clinical practice, which is also mandatory for your curriculum, as well as you will also have added certificate for completing the presentation of oral and poster, which is a requirement of again your presentation. I hope you all had a great time for presentation, making of and presenting as well. The poster presenters are still left with presentations, but I hope they have committed their prime time in making the posters. So here we conclude our session. The name of the uh, prize distributors and the best poster and best oral will be announced tomorrow morning. So till that time, you please be in the group, do not leave the group. And second, the certificates are still on way to get prepared properly by sign of authorized peoples. So we will be announcing the date for distribution of the certificate. Second, I also request all of you to please mention your address for delivering your couriering or sending the courier of your certificate. So write your name. I will be sharing in the group the details. That is your name, your branch name, you have presented poster or oral, your title of the study, and your address with your contact details. These things I will be needed for delivering or sending the courier of your certificate. So stay tuned into the WhatsApp groups. So thank you so much, participants, for cooperating with us. And thank you so much for listening patiently, cooperating with me, and to all the organizer teams.
for smooth conduction of the webinar. Thank you so much. We all can leave apart from the link. Thank you so much.